It will begin a bit late, but it's not a real problem. I need on the here the panel, Yolanda. I don't see Yolanda, she's late. Robert, okay, will be with us. Dr. Saito, please come. And Mahadevan, Kalevani Mahadevan, yeah, I see you. Yeah, please come here. Francesca, still sleeping, maybe. Jacques Monségur. Petre Kala, I've not seen Petre. Maybe he's not here in the meeting. No. And Dr. Srinivas Biravajalala, sorry. And Jaskaran Dugal. Okay, just stimulate a bit outside. And I'm coming back. Okay, I think we can begin, and as usual, in this meeting since the very beginning, we will have a welcome address from the local. Robert Gill, member of the club since a very long time. I even don't remember the first time. So you have 15 minutes. We are waiting for you.
Yeah, thank you very much. I appreciate this invitation. This is a big honor to do that. Just to start, I have no any conflict of interest in this presentation. So I'm not originally from Warsaw, but I fall in love with this country, in this city. Where is the point? I don't have any. Thank you very much. So, this is Poland. Poland in Europe. This is fifth country in Europe, in fourth right now, after excess of Great Britain in terms of area and population. You see here almost 38 million of people. We are located centrally in Europe. So the country is divided into 16 voivodeships, kind of districts with small capitals. The main capital is Warsaw, located, let's say, on the two sides of Vistula River. Here you can some information about the city. The Warsaw was established as a capital in 1592, just after Krakow. This is our second, basically, capital, because the first was Gniezno. Doesn't matter of the history. The metropolis, as you see here, stands on River Vistula in this east central part of Poland. The population is around 2 million people. This is a very big area around this part of Vistula. You can appreciate here that the city or area is divided into 18 districts. The area covers by all of these districts is more than 6,000 square kilometers. So Warsaw today is a big European city. You can here appreciate the skyscrapers of Warsaw. This is a downtown of Warsaw. It looks very nice. But the history of this city during last 80 years is different. So just before the Second World War, that was a diamond of the Europe, I would say, in terms of architecture and nature. It was called Paris of the North. You can appreciate here the architecture, which was very similar to Paris, really. We were very proud of this city for years. That was a beautiful piece of architecture. We love this city. That was the capital of Poland. On the last picture, you see the first skyscraper of Warsaw. That was, you can appreciate here. And then here, a part of old history, a so-called palace on island, located in central parts of Warsaw, by the way. In terms of communication, you can appreciate here that that's before the Second World War, it was well prepared. Let's say the life in Warsaw was very convenient, very comfortable. I would say, and the population of the city was 1,300,000 people, a huge city in that time. However, the 1st of September 1939, not right now, just the symbols of Polish statehood. This is a royal palace. This is Parliament. Just before the Second World War, that was a presidential palace, and here you can appreciate the palace of Saski Palace, with the location of headquarters of Polish Army, mainly. So the 1st of September, the aggression of Nazi Germany, and here you can appreciate the bombing of Warsaw. This is a royal palace. This is the parliament. This is just a picture showing how the city was attacked after 22 years of fighting. There was a capitulation of the Warsaw. In 20% of architecture was completely destroyed. But that was then not the end of the war story in Warsaw. Here you can appreciate that 1st of August 1944, there was a Warsaw uprising. For years, it was hidden by, let's say, for Western people. There was only story about the Jewish uprising in 1943, but the second one was Warsaw was not very, let's say, pleased and stable city for German Nazi. That was the truth. Here you can see the troops of Polish soldiers, civilian soldiers, and fighting. And even with some successes, we took prisoners, war prisoners from Germany. But finally, at the end of September, there was a capitulation, and that was a time when Hitler was just after the assassination attempt in July 1944. He got mad. He was very badly attituded to the situation in Warsaw, because he destroyed plans to defend Soviet troops. And here you can appreciate the consequences of this uprising. That was Warsaw. You see here at the end of the picture this first skyscraper of Poland. Look, this is Old Town. This is also the central part of the Warsaw. It was completely destroyed. We lost 700,000 people. We lost more than 80% of architecture. But we rebuilt everything. Here you can appreciate Royal Palace, presidential castle. This is Parliament. This is city hall of Warsaw. And then the residuals of Saski Palace with the tomb of unknown soldier. Today, everything looks very nice. This is a palace on water. This is Villanov Palace. This is similar to Paris Palace, Versailles. And then that was one of the reason why it was called Warsaw as a Paris of the North. This is a great theater. This is part of Old Town, the same. And this is a very well known for tourists, a New World street. Look at the location of the new buildings, the beautiful pictures of Warsaw. The life here is really very good. This is a very well infrastructured city in the central part of the world, of Poland, and then you can appreciate this special illuminated piece of architecture. This is a gift of Stalin. The seventh of the same buildings is in Moscow. The eighth is in Warsaw. That was a great debate whether it should be destroyed or not. Finally, that it was decided to keep it, to remember who was the real enemy. Some words about the Polish interventional cardiology. In 2016, we had 159 centers located very well, distributed equally in Poland, in these 16 voivodeships. But right now, it looks like that. We have almost 170 centers in 2023, with the members of Association of Interventional Cardiology, Cardiovascular Interventions of Polish Cardiac Society, more than 1,200. Here you can appreciate the increasing numbers of procedures for acute coronary syndrome and association between the decreasing of mortality of this patient. This is our work. The position in Europe in 2010 was not so bad. We were in the first 3 leaders of the intervention of primary PCI for acute coronary syndrome. Here you can appreciate the highest number, that was more than 700 per million. But of course, during last years, we observed the decreasing. It is also a result of prevention taken in our country, and of course, due to the COVID-19 pandemic, we observe 25% decrease of procedures regarding diagnostics and intervention procedures as well. We are also busy with structural heart diseases. Right now we have at least half of the average procedures for TAVI. We are also busy with pulmonary valve treatment, the mitral edge-to-edge procedures are not so bad as well. However, we have to improve it. For tricuspid, we started right now, but it's increasing. But we have also some new devices in terms of structural heart disease. So thank you for your attention.
Thank you for this piece of history. I think it was a good idea to keep this story, from my opinion, because this is to remember. So this is part of your history, and it was but it also was beautifully rebuilt and it's a very beautiful city. So thank you for this presentation. So well, now, you can come here. There is a place. No, we need you need an additional chair. Is possible? Okay. So first of all, I want to present you Dr. Shigeru Saito. He's an old and good friend. We were in the campaign of, can call it a campaign, it's not a war, but it was a campaign of radial approach. For many years, we were proposing the radial approach everywhere in the world with Jean Fajadet, with Ferdinand Chiamenet, and Shigeru, myself, and many others. So I'm very happy to see him. He wanted to visit this meeting. I'm very happy to see him with us. So please, Shigeru, please call the first speaker.
Okay, I'm very pleased to introduce the first speaker from South Korea, Dr. Kang. He will present the antiplatelet therapy in ACS patients and bifurcation lesions. Please, thank you.
Yes, thank you for the kind introduction, and it's my honor to have a speak at the EBC 2023 with the opening of the second day. As you can see, my talk will be antiplatelet therapy for ACS patients with bifurcation lesions, and I will divide this into the acute phase and the chronic phase for antiplatelet therapy. Now, regarding the guidelines of antiplatelet therapy, we know that there has been various clinical trials that have evaluated various strategies of antiplatelet therapy. And now we have a very complicated guideline, and to make it simple, the DAPT duration or intensity is stratified by the clinical presentation, which is stable coronary disease or ACS, and if the patient has any kind of high bleeding risk or not. So in this kinds of era, how should we use DAPT in ACS plus bifurcation PCI or complex PCI? And what should we consider in determining the intensity of DAPT? So there has been a couple of studies that have evaluated the DAPT duration in complex PCI, and this was the first study that gave us the concept of complex PCI. We can see that bifurcation with two-stenting technique was included in the definition, and this study evaluated that a longer DAPT, a DAPT more than 12 months, significantly reduced the ischemic outcome compared to those who had a shorter DAPT duration. So this gave us an insight that the procedural complexity should be considered when we determine the DAPT duration. However, a following study then showed that not only the complex PCI, but the high bleeding risk, the patient characteristics are also important, and only if there is an absence of the HBR that a longer DAPT is better when we perform longer DAPT for complex PCI, which includes bifurcation to stenting techniques. So again, we have to consider the procedural characteristics and the clinical characteristics when we determine the adequate DAPT duration for a patient. So then, how should we treat these highly thrombotic patients who present as ACS and have a bifurcation PCI? We can divide this into the acute phase, which can be defined as within the first year after PCI, and the chronic phase, which can be defined as after the first year of PCI. So we can consider the thrombotic risk, the bleeding risk, and there are various kinds of strategies that we can consider in these kinds of patients, and I will talk about this in the following slides. So to simplify the contents of my presentation, I would like to divide this into antiplatelet therapy in the acute phase and two topics, whether we can abbreviate antiplatelet therapy or can we soften the DAPT intensity. And then beyond 1 year, is there a specific antiplatelet agent that should be prescribed? So regarding the first topic, can we abbreviate antiplatelet therapy agents? When we consider the DAPT duration, as I said, there are various factors that we should consider, the patient factors, the angiographic or procedure factors. And if we want to abbreviate or kind of tailor these kinds of antiplatelet therapy agents, we should consider how long these patient or procedural factors give any impact into the outcome of the patients. So to compare the clinical and the procedural characteristics, we did analysis of the Grand DS registry, which is a registry that we have in Korea, including more than 13,000 patients. And all the patients were divided into clinical characteristics and procedural characteristics. And in this slide, we can see that there was a substantial amount of patients who had bifurcation lesions, which was a procedural characteristics. So during the 3-year follow-up of this patient, we divided the patients into high, intermediate, low clinical risk patients and high, intermediate, low procedure risk patients. And we did an annual landmark analysis. And in this slide, we can see that during the first year, both the clinical and the procedural characteristics were important. However, after the first year, the procedural characteristics, the importance declined, which made the clinical characteristics the more important factor. So we can consider that at least during the first year, the procedural characteristics are very important in the clinical outcome of the patients. So we should keep in mind the procedural characteristics, that is, if the patient has received bifurcation PCI, in determining the DAPT duration of the patient. So based on this slide, I can say that it might be slightly risky to reduce the DAPT duration because the procedural characteristics have a large impact during the first year after PCI. So then the second topic, can we soften antiplatelet agents? There are a lot of strategies to de-intensify the antiplatelet strategies that we do, especially in ACS patients. And we did a study called the Host-Reduced Polytic ACS trial, which was a clinical trial to determine whether we can de-escalate a potent P2Y12 inhibitor while using DAPT during the first year after ACS patients. So as you can see in the figure right here, we evaluated the de-escalation group, which was a aspirin, prasugrel therapy, and within the first month, the conventional dose was used, and after the first month, prasugrel was reduced to a half dose. So overall, in this trial, we could see that overall in ACS patients, the de-escalation strategy had a risk reduction about 30%. Then can we apply this kind of strategy to those who have a complex PCI, who receive bifurcation PCI? So there was a sub-study that we did of this study, and we could see that there was about 1/3 of patients who had complex PCI within the total patient population. So before doing the comparison between de-escalation strategy and conventional dose strategy, we could see that from this slide that complex PCI itself did have a large impact on the ischemic outcome, MACE, during the first year after PCI, while the bleeding events were quite similar, which is quite easy to understand. Also, many of the factors that are included in complex PCI, that includes 3-vessel disease, more than 3 stents, etc., all had a small and impact in increasing the MACE rates, which means that all of these factors have additive value in increasing the ischemic outcome of complex PCI patients. So then in the complex PCI patients, when we compare conventional DAPT and the softer de-escalated DAPT, we could see that by performing a de-escalation, this means that using a half dose of prasugrel while using dual antiplatelet therapies within the first year, had a decrease in NACE, which was majorly determined by a decrease in the bleeding risk. However, there was no trade-off of increase in the ischemic risk. So by this slide, we can see that even in those who have a complex PCI, which includes bifurcation PCI, we can de-escalate the potent P2Y12 inhibitor, even though if this patient has presented as a ACS, which means that we need a potent P2Y12 inhibitor during the first year. So then, going to the third issue, is there a specific antiplatelet agent that should be prescribed? Well, this was based on the host exam trial, which was another trial that we did, which compared clopidogrel monotherapy versus aspirin monotherapy after the first year of PCI, which excluded those with any kind of clinical events. This means that these patients were stable CAD patients who received PCI at least 1 year ago. So of this study, some of you might be familiar with the results, but we could see that clopidogrel monotherapy as compared to aspirin monotherapy decreased the clinical outcomes of up to 27% with a risk reduction of 2% within 2 years after follow-up. I would like to stress again that these patients were not enrolled during the index PCI period, but they were enrolled after they were event-free of the first year after PCI. So again, can this strategy be applied to those who have a complex PCI, a bifurcation PCI patient? So we should talk about the thrombotic risk if we want to discuss of the complex PCI. So again, we did a sub-analysis of this study, which included the high thrombotic risk patients among the patients that were enrolled in the host exam trial. Again, we can see that there was a large amount of patients who received various kinds of complex PCI characteristics, and we can see that there were some patients who received a bifurcation two-stenting techniques. So before comparing aspirin versus clopidogrel, is complex PCI a risk factor after the patient is stabilized during the first year? Surprisingly, in this slide, we can see that after the patient is stabilized, complex PCI itself was not a risk factor of any kind of adverse clinical events after the first year of index PCI. And also on the right panel, we can see that the number of complex PCI features was not associated with an increased risk of any kind of clinical event. We can think that a larger number of risk factors of complex PCI might give us a higher thrombotic risk, but this was not present after the patient was stabilized during the first year. So then in the complex and non-complex PCI patients, we compared aspirin versus clopidogrel, and we could see that although the P4 interaction in the right, it was 0.181, which is insignificant. However, we could see that the impact size of clopidogrel risk reduction was larger in that of in complex PCI patients. In complex PCI patients, the hazard ratio was 0.61 compared to 0.80 in non-complex PCI patients. There was no significant interaction, but still we can say that probably the risk reduction in complex PCI patients might be larger when we prescribe clopidogrel instead of aspirin, which is in the current guideline right now. And in the X panel, we can see that this was a long-term follow-up which extended up to 5 years, which means that it was 6 years after the index PCI period. So during this long-term follow-up period, we can say that as compared to aspirin monotherapy, clopidogrel monotherapy was superior even in those who received any kind of complex PCI patient. So this is the conclusion and the last slide of my presentation. Patients who present with ACS and bifurcation lesions obviously have a highly thrombotic risk, and potent P2Y12 inhibitors and aspirin is recommended because these patients are ACS patients, not because they have received bifurcation lesions. And within the acute phase, because the procedural factors have a impact during the first year, the APT should be maintained. However, it may be softened, such as a dose reduction of the potent P2Y12 inhibitor. In the chronic phase, which means that after these patients are stabilized, clopidogrel monotherapy may be superior as compared to aspirin monotherapy, especially in complex PCI patients. Highly thrombotic patients, ACS plus bifurcation PCI patients, can use prasugrel-based de-escalation followed by single antiplatelet therapy of clopidogrel, and this may be a feasible option. And thank you for your attention.
Dr. Khan, thank you very much for your very comprehensive, summary of antiplatelet therapy. So, anybody? Question or?
Good morning.
Question or comment?
I have a question. So, congratulations, really beautiful data. Can you comment on the use of imaging in the both studies?
Yes, this is a very important comment. Well, actually, both studies were performed 100% in Korea. So the imaging usage was about 30%, which is an average number that we have in Korea. It's slightly lower compared to the numbers in Japan, and slightly higher compared to the numbers in studies performed in the Western countries, but it was 30%.
So do you think that the high use of imaging also correlates to the results? Do you think that if the imaging wouldn't be used, the number of thrombotic events might be higher? So if we have high bleeding risk patients and plan to reduce to short the DAB, should the imaging be obligatory?
Yes, of course. I think that imaging is a very nice tool to reduce any kind of clinical event. Well, actually, this is especially in the first year because most of these thrombotic events occur in the early phase after PCI. After the patient is stabilized, I'm not sure that imaging, which was performed 1 year ago, might have a clinical impact in the adverse outcomes.
Petre Kala is with us. Petre, comment or question?
Hello. So I think that the imaging is really crucial for the future, and we have now very good data from ESC, from the meta-analysis, and also from the original studies that were presented. So the risk of, especially of thrombosis, was really significantly lower. And it was more than 50% lower than in the control group. And so I think that also for the antiplatelet or anti-thrombotic regime, this is quite important to take into account. And I would like to congratulate my colleague to their work and to their results, because this is a really very important clinical issue. And I don't have any question now. Thank you.
Thank you, Petra. Just a brief comment from me, because we are late. So I'm thinking that why we are not putting this hemorrhagic potential inside the MACE rate. If you take the point of view of a patient, MACE is not enough to describe the events. You have to add the hemorrhagic problem. I think I don't understand why we have the thrombotic problem and we are not taking into account the hemorrhagic problem. So I think if we push the treatment with antiplatelet, antithrombotic treatment 2 years because you did very exotic techniques with a lot of metal, normally it has to be associated with some events, hemorrhagic events, and it has to be part of comparison of two strategies and two techniques. So this is my point of view. This can be discussed. But even in the club, we may decide to propose this. This is a question. So next presentation, please, Jolanta, call the...
So now it's my great pleasure to invite Dr. Kinoshita, who will be sharing with us his expert opinion on the importance of bifurcations in the CTO PCI. Dr. Kinoshita, welcome to the stage.
Good morning, Chairman and ladies and gentlemen. It's my honor to be here, and I'm glad to meet EBC members. This is not my slide.
This is not the good slides. So we can go on with the question. I was looking at Jacek. Jacek, what's your opinion about what I said just before? You have patients that may have more than 2 years, maybe more, even more antithrombotic treatment, and we are not including in MACE rate any of these hemorrhagic problems. So a microphone for...
I absolutely agree with you that it should be included. Hemorrhagic complications are sometimes more dangerous than just ischemic ones. So this is good comment, but also I would love to acknowledge the comment of Jolanta that the intravascular imaging is the tool which has to be used in those patients at high thrombotic risk, high bleeding risk, especially if we do complex PCI procedures, because this is the only way to lower the risk of stent thrombosis, and then we will
discuss this afternoon. So this, please, Dr. Kinoshita.
Okay. Thank you. So actually we have been challenging the treatment of the CTO for more than 30 years. Actually, we introduced EBC guidance and CT image guidance for the treatment of CTO from early dates. And in 2006, Dr. Sumeri, he's a doctor, he reported the first original CAR technique in the world from our center. And in 2010, Dr. Latour, he's one of the EBC member, also reported on the reverse CAR technique from our center. And we've also involved in the development of the colossal microcatheter and Gaia wire. 2 years ago, we reported the importance of the side branch protect in the treatment of the CTO bifurcation. So fortunately, this paper was cited in the list published the expert consensus document from the European Bifurcation Club and the EuroCTO Club. Today, I would like to talk about this our study. The purpose of this study is to investigate the appropriate strategy for the CTO bifurcation region. So totally the 314 patients out of the 1,049 patients who underwent the CTO PCI in 3 centers from the 2010 to the 2018. All of these 314 patients has a bifurcation involved in the CTO region. The side branch diameter is more than 2.5 millimeter. And we divided these patients into the 2 groups, and one is a side branch loss group, another is a non-side branch loss group. Side branch loss was defined as a final thrombolysis in TIMI flow is less than grade 3 in the side branch. So this is a flowchart of this study. So 1,049 we excluded from the 1,049 patients. We excluded the 141 unsuccessful case, and the 301 the cases without no follow-up, and there are 893 cases without which is no bifurcation CTO regions. So finally, the remaining 314 regions were divided into two groups. One is side branch loss group, number is 47, and another is a non-side branch loss group, number is 267. And so as a result, in terms of the patient case characteristics, so the side branch loss group had a higher percentage of the presence of stenosis in the side branch, and the side branch located within a occluded segment. But otherwise, there is no difference, no significant difference between the two groups. Together with procedure characteristics, the side branch loss group showed the more use of the RDR technique and the subintimal tracking at side branch ostium and the subintimal dissection. And also the carina and plaque shift after stenting in the main branch was significantly more frequently observed in the side branch loss group. So regarding the clinical outcomes, there is no difference in the MACE between the two groups, but the TLR in side branch, TLR for side branch is significantly higher in the side branch loss group. So regarding the predictor of the TLR, side branch loss in RCA and subintimal tracking of the side branch loss significant, strong predictor, independent predictor. And this shows the Kaplan-Meier analysis of the cumulative 1-year incidence of the TLR. Although the TLR in all regions, there is no difference between the two groups, but the TLR in RCA, we could see a significant difference between the two groups. Actually, the side branch loss group are significantly higher. And concerning the predictor of the side branch loss, it's the multivariate analysis indicated the side branch located within the occluded segment and the subintimal tracking at the side branch ostium. And presence of the side branch stenosis is an independent predictor in this analysis. And also, we performed the sub-analysis of 82 bifurcation regions located within the occluded segment. This is about 25% of our subject. And it shows that the two-cent strategy is a little bit better than to keep the good side branch outcome compared to the 1 cent technique. So, ladies and gentlemen, this is my conclusion. The predictor of side branch loss was presence of side branch stenosis, subintimal tracking at side branch ostium, and the bifurcation region located within the occluded segment. Especially since suboptimal side branch result in RCA may lead to TLR on main branch, it is important to keep the wire inside plaque to preserve side branch. Use of two-stent strategy may be desirable for the preserved side branch patency in the treatment of the CTO bifurcation region located within the occluded segment. And this is my final slide. At about the same time of our report, there was a report from China that suboptimal side branch results are related to the prognosis. So I'm convinced that it is important to treat CTO while the side branch, preserving side branch appropriately. Thank you for your attention.
Thank you very much. Who has a comment or question?
Manuel and Dr. Oreda published on this.
Congratulations, Yoshi, for your data. No, my question is about the protection of the side branch with a wire. I didn't see that the possibility to protect the side branch is a factor of side branch loss. If you can't protect the side branch, do you think that this is a factor induces the possibility of side branch loss?
Yes, thank you for your question. Actually, in the CTO region, especially the side branch from that coming from the in the CTO region, it's difficult to keep only using the protection wire. So sometimes we need the gel band technique. And after putting the stent, and after that we often use recently we often use DCB to the side branch.
Just a comment.
Yep.
Did you perform an analysis of the location of the side branch? In the top of the bifurcation, the middle, or at the end? I think there is a great difference in terms of side branch loss when we are in the CTO, just in the middle or at the end parts.
Yes, thank you for your comment.
In Manuel was paper was also the present inside the corpus of the occlusion is a higher risk of losing the side branch, which is logical.
Yeah. Actually, so of course, the side branch position is very, very important to if we can keep the side branch. But proximal side branch, side branch at the proximal of the CTO region, actually that is easy to keep it. But most of the difficulty is side branch from the just within the CTO part.
Oh yeah, there's a question from Professor Kala. Yes, please. We can't hear you. You are probably mute.
Sorry. I would like to ask you, and thank you for the data. I would like to ask you about the selection of side branches that have to be protected. So are there any side branches that you are not interested? Of course, I'm not talking about the diameter of the side branch, but if we are talking about the side branch at least with diameter 2.5 millimeters, are there any of them that you are not interested in preserving them?
Thank you for your question. That actually, in this study, how can I say, simply to collect the data, we have a limitation to the side branch diameter is more than 2.5. But actually, recently, we always almost all cases we check the CT angio, CT image before the CT region, and we always calculate the territory of the side branch. If the side branch diameter is less than 2.5, but this side branch territory is more than 10%, at that time we try to keep the side branch.
This is using the relevance of the side branch, the concept created by Bonkwanku. So yes, I understand. It's time to move to the. Thank you, Dr. Kinoshita.
Yep. So now it's my great pleasure to invite Professor Gill, who will be sharing with us data on the BIOS LIMC stand, a dedicated stand for bifurcation.
Thank you very much once more for inviting me. Somebody can be a little bit surprised that we are back with the history of BIOS, but I have to announce you that COVID-19 pandemic and the death of owner of the company Balton changed completely the plans and transferred our dream somewhere outside. But anyway, we have 4 years follow-up of this stand, and I would like to show you the data, just to remind you and ask you, not kill the idea of dedicated bifurcation stand. I truly believe that there is still place for that. Before I will go into the details of the results, just to remind you the stand, 2 pieces connected with 2 connectors, 70 micrometers struck thickness, biodegradable polymer with sirolimus in that. The mechanism of implantation, just to insert the stand in a proper position, giving a good access to side branch. The stand is located on a special balloon with a bigger sizes in proximal, say smaller for distal positions. This stand was quite well tested also in animal study. Here you can appreciate the comparison with the Orsiro stand in terms of the angiographic results and histopathologic. There was a very good results comparable to this particular stand. We started in the beginning registries for this stand. Here you can appreciate the inclusion and exclusion criteria. Just to summarize and simplifying everything, We just took for treatment patients with the big promise of results for provisional stenting, and of course we try to exclude acute coronary syndrome patients and the lack of informed consent of the patient. We included also left main cases. Here you can appreciate primary and secondary endpoints as regular, normal for such studies. Then in terms of proximal optimization technique, which become a kind of the must, we included also this part for protocol of the implantation, because we started without this requirement, believing that the difference in the size proximal to distal makes the same effect. Here you can appreciate the population of this first in man with this stent. Some characteristics: 2 subgroups, left main and non-left main, well distributed without significant differences. Here you can see important issues regarding the protocol of implantation. What is really very bad, that the percentage of proximal optimization technique, despite we asked implanters to do that, was significantly lower than for left main group. That was below 50%, as you see here. And here you can appreciate the results of first in man with this BIOS LIMC stent. The MACE in general below 10%, TLR say around 6%. That was a total, let's say total values, but if we split this data for left main and non-left main, for non-left main, that was around 3%. So we went after that. That is also OCT performed for the follow-up, showing that there was a very good adoption of the stent within the coronaries. So we predicted looking in vivo a late lumen loss, as you can appreciate here. So we got definitely similar information. So the conclusion of this first in man with BIOS LIMC was that this is a promising stent. We should go for the randomized trial, and then we organized that. This was Polbos free, with all of the same inclusion and exclusion criteria. I would like to stress that in Polbos free there was no left main cases. The implantation protocol as regular already with proximal optimization technique as well. Here you can see the study flow chart. Unfortunately, because of COVID-19 pandemic, we stopped enrollment. So we stopped this enrollment on 116 patients with BIOS LIMC and 114 with regular drug-eluting stents. You can appreciate here the list of these stents used, and of course, all of these patients were under our control. We followed them for next years, and of course, as usual, the primary endpoint was the complex, included cardiac death, myocardial infarction, target lesion revascularization at 12, and then as a secondary for up to 28 months, so it means for 4 years. So if you look at the baseline characteristics, you can see that slightly BIOS group was just younger. There was a bigger percentage of prior revascularization compared to BIOS group. The rest was well distributed without significant differences in terms of Medina classification. The percentage of true bifurcation was around 70%. Some procedural details, and again, Unfortunately, the percentage of proximal optimization technique was really very low, just 1/4 of the cases, half for regular drug-eluting stents. And just to tell the truth, that was a trial, which was organized in two centers, in two post centers. So we were very straightforward in terms of protocol details. However, as you see here, we didn't succeed. Anyway, the rest was very similar to other. And then results after 4 years, or every single year, you can appreciate that the percentage of MACEs increased by years, but the differences between regular drug-eluting stents and BioSlim-C was not significant. Here you can appreciate much better looking at the cardiac death. There was no differences in myocardial infarction, no differences in target lesion revascularization. There was slightly better for regular drug-eluting stents, however, without significance, and the same because of this previous one, the composite endpoint was also without significance. And just let me conclude that experience so far with BioSlim-C stent shows that its further development is able to fulfill the initial hopes that it will be better in the treatment of bifurcation lesion compared to classic drug-eluting stents. I really believe that we shouldn't kill this idea. We should pay much more attention for details and using the well confirmed and proven scientific data in terms of optimization of our results. Thank you very much for your attention.
So thank you very much, Professor Gill, for sharing this important data. Who wants to comment or ask questions? Yes, over there. The micro is coming.
Thank you.
Thank you.
Okay, so thank you, Professor Gill, for the excellent presentation. So in your slides, that the numerically higher rate of TLR for the biostent, and have you ever analyzed the location of the TLR in terms of proximal, distal, and side branches?
We already checked that issue in previous registries, but for sure that was not a mid portion of the stent, not at all. There was almost equal distribution for proximal and distal position. What we should do much better is just not only proximal optimization technique, but also distal optimization technique. This is one issue. The second, the usage of intravascular visualization, allowing us to better preparation for stent implantation optimization, the final result. And the third, we truly believe that construction of this stent is optimal for non-left main bifurcation. However, we need more potent anti-proliferation, let's say, action. And as far as I know, the Balton compound already achieved that.
Thank you.
Thank you, Robert. I think we have to move. Yes.
Very briefly, thank you very much for sharing this interesting data. I had always thought that one of the advantages of the BIOS stent was the possibility of skipping the pot, because it was already created by the shape of the balloon. However, I've noticed that it's part of the protocol.
We believed for that at the beginning, so therefore in our primary protocol there was not a requirement of pot. However, we found that without intravascular optimization, the calcification and fibrotic tissue due to the non-compliant balloon for stent delivering the stent resulted in a non-optimal result. So therefore, right now, I would say that after inspection, without a lot of calcium and fibrotic tissue, sizing properly, it's theoretically possible. But you know, intravascular visualization is not 100% cases in my country.
Sir, if the side branch requires stenting, how would you do that? Is there any particular strategy we follow, or we'll just nail at the osteoma of the side branch?
Can you repeat?
The side branch stenting is required after this bias stent. If the side branch needs to be stented, how would we do that?
You know, I didn't focus on this topic for this particular group of the patient, but from other registries we have data showing that the need of second stent implantation is less compared to regular drug-eluting stents. However, in this randomized trial, we observed an opposite. So it means that the operator wanted to improve the results for BIOS, implanting additional stent sometimes too early. But this is the true. We can, with the proper positioning of the BIOS stent, we can, let's say, decrease the rate of side branch implantation for sure.
Thank you, Robert. So we will have some news during the next years. You are continuing with this, yeah? We'll see. So the next speaker will be Bonkonku Kwon. Welcome. He will speaking original talk this year on sex differences in procedural characteristics and clinical outcomes among patients undergoing bifurcation PCI.
Thank you. Good morning, ladies and gentlemen. So women and men are different, but some may disagree. But at least for coronary artery disease, difference exists in terms of clinical risk profiles, vessel size, disease burden characteristics, myocardial mass, stenosis hemodynamic relationship, etc. And this is the reason why in the flavor trial, even though same criteria of IVUS and FFR were applied to both men and women, PCI rate was different. Women resulted in less PCI than men despite the same criteria for IVUS and FFR. And this was translated into the difference in outcome. Women had a better outcome than men. When we focus on a bifurcation PCI, you will see that there has been several decent large number of studies, but the results are different and contradictory. Some are saying women are worse, and some are saying no difference. And these contradictory results should be interpreted under the context of different characteristics between men and women and among different studies. So this is a very complicated studies, but you can recognize that the difference exists in terms of baseline characteristics and angiographic characteristics and also procedural characteristics. So in summary, we now recognize that sex-based difference exists in terms of outcome. So we need a very comprehensive investment into the baseline and procedure characteristics and their prognostic impact. So that's the reason why we performed this study on the sex-based difference in patient level and lesion level characteristics and procedures and outcomes following bifurcation PCI. So this is data from the COBIS-3 registry, which is a Korean multi-center real-world registry data, including around 2,600 patients. And for this study, we excluded small vessel bifurcation PCI, and we did the QCA for all lesions and include only the vessels, main vessel 2.5 millimeter or more, and side branch 2.3 millimeter or more. So this is the results. Like all cross-sectional PCI studies for men and women, women are older, leaner, more hypertension, more diabetes, and less smoking, so that it's universal. But it's interesting to see that the real-world cross-sectional data of the lesion characteristics or angiographic characteristics between men and women. So women tend to have a less prevalence of multivessel disease like the previous studies, but bifurcation location, left main or not, LAD or not, it's exactly the same. And bifurcation classification, true bifurcation, Medina classification, it's exactly the same. And it is also interesting to see the procedure results. So we know very well that the women has a smaller vessel, so that the main branch vessel size, side branch vessel size, women has a smaller vessel size. But in terms of bifurcation angle and angiographic percent diameter stenosis in main branch, side branch, and after PCI, residual percent diameter stenosis in main vessel and side branch is exactly the same. So it's an interesting phenomenon. And for the procedural characteristics in Korea, men and women underwent the similar degree of IBUS guidance, and it is interesting to see that in terms of bifurcation PCI technique, simple crossover, one stent side branch balloon, two stents technique, it's exactly the same, and also the number of stents per patients and main vessel stent length and discharge medication is all the same. So in summary, despite the differences in baseline characteristics, lesion characteristics are quite similar, and procedures are quite similarly performed. So then the question is, what will happen in terms of outcome? So we analyzed the 5-year outcomes. The primary endpoint of this study was target lesion failure, which is exactly the same between women and men. And for the secondary outcomes, cardiac death, myocardial infarction, target lesion revascularization, exactly the same, so equal. And it is interesting to see that the subgroup analysis, so there was no difference with the most of the subgroup categories, but like the previous studies that the age, diabetes, there was an interaction. So this means that you should be careful when you are treating bifurcation lesion in young diabetic women rather than the other counterpart. But left main category, two stenting category, there was no difference. And this year's EBC, we are talking a lot about imaging. So we analyzed the data according to the imaging, intravascular imaging plus intravascular imaging negative. So no difference in terms of the target lesion failure. But the limitation of this study is that we analyzed only the Korean patient so that we collaborate with our Italian colleague to analyze the Italian data using the RAIN registry, which is another very big real-world registry, around 3,000 patients. And this shows that the baseline characteristics, so like our previous Korean data, women older, more hypertension, more diabetes, more hyperlipidemia, and less smoking, but no difference in diagnosis, left main bifurcation, true bifurcation, and two-stent strategy, so that it's universal difference in baseline characteristics, but the lesion characteristics and procedural characteristics now both are similar. And when you see the results, it's exactly the same as the Korean COBIS registry in terms of TLR, myocardial infarction, stent thrombosis, and MACE. There was no difference between men and women. So in summary, ladies and gentlemen, we recognize that the women and men are different in terms of baseline lesion characteristics, plaque characteristics, and reference diameters, but if you treat them equally, the outcome will be all the same. Thank you very much for your kind attention.
Very well done in time, as usual. So some question maybe from women. In my mind, remember some trial showing that really everything is different, but we are the same, except in the size of the vessel.
I have just a small comment here, Gianluca. Yeah. We published around 2 years ago same work, basically, about the left main bifurcation, women and men, in 500 people. And we saw exactly the same result, except the rate of bleeding in women with double stent. Bleeding is twice the bleeding of the men, especially in not by age but by weight. So the only different thing is that the women, in particular small women, if you put two stents, they bleeding more.
Yeah, I think that's a great point. So that I didn't show you the data. It is interesting that you may expect this, but the women, in terms of femoral radial, women has less radial approach, and our data also show that the bleeding risk is also higher in women, and I thought that it may be due to the approach.
I mean bleeding in the long term, not bleeding from the radial and the femoral was similar men or women.
Isn't it related to the dosage of the drug? Because they are taking the same dosage as we take.
Maybe, but unfortunately we don't have detailed in terms of doses, but the number of drugs are always similar. But I agree that they may matter.
There's another question.
It's more a comment. Because the risk factors for coronary disease between men and women are very different. Women have more diabetes, are older, less smoking. They tend to have more diffuse disease and not focal disease. And as we only treat really focal disease, not really diffuse disease, then the treatment options for men and women are quite different.
Right. So that there are several, baseline characteristics which unfavorable to women may be the small vessel, small stent size. But we also know that when we analyze the plaque burden and plaque characteristics, despite the more favorable baseline characteristics, men tend to have a higher disease burden despite the similar angiographic characteristics, and also men has more adverse characteristics. So there are several favors men, favors women, but in combination, if we treat them equally, my message is they will show the same outcome.
Thank you. So other comments on this?
I would like to also comment on the bleeding risk in women and men. I think, as you have shown, that women are older and are sicker. So if we will use any of the bleeding risk score, I started to use the HBR Academic Research Consortium score because it's really easy to use. There's a mobile app. And I really started to use that for each PCI before the PCI, actually, because it changed very often my strategy. But if we use it in each patient, so 42% of all female patients undergoing PCI are on high bleeding risk, whereas 33 men. So actually, in more women than men, we should short or de-escalate probably. And also in your data, you have shown that, and that's the question, that less women received statins after the PCI than men. So what could be the reason for that?
I don't know the reason. This is the data, but I agree that we should, focus more on those, differences in terms of risk profile, patient risk and lesion risk, so that that may, the outcome, greater, more to the equal.
Right. Thank you.
Thank you.
Kwon. So please, Shigeru, can you present the next speaker, Japanese?
Okay, I'm very pleased to invite Dr. Fujimura. He will talk about the serial changes of the side branch ostial area after single crossover stenting with kissing balloon inflation. Okay, it's virtual. Oh, okay.
Easier.
Please. I cannot hear you. Excuse me, I cannot hear you.
EBC meeting today.
Yes,
I am Tatsuhiro Fujimura from Yamaguchi University Medical Hospital, working as a Japanese interventionalist for 20 years. Time is limited. I will start my presentation. The title of my presentation is Serial Changes of the Side Branch Ostial Area After Single Crossover Stenting with Kissing Balloon Inflation. In previous report, Dr. Okamura defined optimal rewiring as rewiring to distal cell without a link. And he demonstrated that the optimal rewiring groups in single stent KBI strategy can lead to reduce incomplete stent apposition at the side branch ostium. The result is also substantiated by the optimum trial conducted by Dr. Onuma and Dr. Miyazaki. And then I demonstrated that the side branch oscillator area dilated with optimal rewiring was preserved at the follow-up in European Heart Journal 2018. However, the study was a retrospective and single-center study, and the study number was very small. Left main cases was only 20. So I sought to investigate the relationship between optimal rewiring and the side branch oscillator area again in another study. Here you can see our methods. Patient with single crossover stenting with kissing balloon inflation who had accessible OCT images at the post-procedure and the 9-month follow-up were extracted from the 3D OCT bifurcation registry. The registry is a multi-center Japanese registry that had PCIs for bifurcation regions in OCT guidance. Optimal rewiring was defined as a distal rewiring without a link on the carina. The side branch oscillator area were measured by the dedicated software made by Medis Corporation, Q-Angio OCT. This software can accurately measure an suboptimal side branch oscillator area from the main vessel OCT pruvac, like this. And the difference in change and the change ratio of the side branch oscillator area were calculated as below formula. I will share the results. 168 bifurcation regions were enrolled in the 3D OCT bifurcation registry. 75 bifurcation regions were selected single stent KBI strategy and had the follow-up OCT data. Left main was 35, non-left main was 40. In the patient and region characteristics, there was no significant difference between optimal and suboptimal rewiring groups, regardless of left main and non-left main, except for stent size. This is main result. The serial changes of the side branch oscillator area of each site and condition. The red line and the blue line indicate a decrease and increase. As you can see, in suboptimal groups, the side branch oscillator area was significantly decreasing. On the other hand, in the optimal rewiring groups, the side branch oscillator area was preserved at the follow-up, regardless of left main and non-left main. Similar to previous report, the side branch incomplete stent apposition was proportionally higher than that in the suboptimal rewiring group in both. In left main, the side branch oscillator area in the suboptimal group at the post-procedure significantly bigger than that in the optimal group, like this. This represents a distribution of the difference in the absolute change of side branch oscillator area in left main. Here is a box plot depicting the change ratio of the side branch oscillator area in left main. There was a significant difference between optimal and suboptimal groups in either. While in non-left main, there was no statistically significant difference in either. So the side branch oscillator area in left main with suboptimal rewiring might tend to be smaller than that in non-left main. Here, I'd like to show you representative cases in left main with suboptimal rewiring. As you can see, compartments made by residual stent strut at the side branch ostium were filled in at the follow-up, like this. There was no significant difference in clinical outcomes because the event number was small and there was a bias of only patients who was able to have the follow-up OCT image. Conclusion: the side branch ostial area dilated with the optimal rewiring position in the bifurcation regions with single crossover stenting and kissing balloon inflation was preserved at the 9-month follow-up, regardless of left main and non-left main. Thank you for your attention.
Okay, so, thank you very much for your excellent presentation. Anyone have?
I have a comment, maybe regarding our Korean colleagues. So there is a cultural difference between Japan and Korea about the kissing in the left main. So, and I know that the trial is beginning in Korea, kissing versus no kissing. And I remember the time that with Thierry we did kissing is useful, but we have to do a good kissing. So to be to be a good kissing, do we have to enter the distal cell? For me, this will be the best use of intravascular imaging. So maybe you have a comment of Bonkonku on this. Part of your trial is to enter the side branch through the most distal cell and to remove the connector, if possible. We need a trial because it's too long time to wait for an answer.
Yeah, so I don't want to talk in detail about the trial because he's going to present next session. So, but one thing I'd like to comment about this results is that even it is guided by OCT, there should be the optimal and suboptimal wiring. So that's the reason why when we do OCT guided and whatever guidance we made, the outcome may not good as better as we anticipated. So that I think it gives us a very important insight that if we cannot guarantee the very optimal wiring, the outcome will not be improved even with the OCT guidance or the additional procedure. So that's my take-home message from this result. But congratulations on your successful study.
Maybe Yoshi, Murasato, or Yutaka, a comment about that? The Japanese point of view?
Excuse me. Can you hear me?
Yeah, we hear you.
Good morning, everyone.
Yeah, please, you can comment about what we are discussing. There is a trial beginning in Korea. So are you waiting that we'll see a difference if we enter distally towards the side branch or not?
Yeah. So thank you for your comment, Professor Ku. So final kissing balloon inflation is considered as no advantage, at least in ESC guideline. But I think it is difficult to. I think it is very challenging to demonstrate the use of 3D OCT in clinical event because there are many factors of clinical event for bifurcation lesion. So plaque distribution and plaque characterization, and more. But one thing I can say from the study, the optimal rewiring can lead to good side branch expansion and maintain the side branch ostium. But if you can achieve the optimal rewiring, the KBI could be optimized. However,
we need the clinical validation. You said that the clinical follow-up was the same. So what we need to invest in a 3D OCT to enter the most distal cell, we need absolutely clinical results, clinical validation. Petre?
Yeah. But if you can not achieve the optimal rewiring, I think it is one option not to dilate side branch. So now we conduct the next 3D OCT bifurcation registry with more than 600 patients in OCT guidance for 3 years follow-up. So I will research about that. So relationship between a clinical event in the future.
So we'll see next year or not? Petre, one small comment.
Yeah, thank you, Yves. I think that the role of imaging is really increasing, and it will continue. But at the same time, it's not so easy, and I am not talking about the expenses of these technologies. But I think that we have also quite good stent enhancement technologies that could be used, and I haven't seen any data from the trials that have been published yet about the. It can be stent boost, it can be clear stent technology, because it can get quite nice data, and I think that
this is for this afternoon, Petre. We'll speak about that this afternoon. Thank you.
Thank you.
Thank you. So the last presented by Yolanda.
So now it's my great pleasure to introduce Dr. Arun Tarai, who will be sharing with us his presentation about the stepwise provisional versus systematic culotte for stenting for true coronary bifurcation lesions, the 5 years follow-up.
Okay, good morning, and thank you very much for the opportunity to present at EBC 2023. My presentation is going to be on the 5-year follow-up of the EBC2 trial, which we first discussed at EuroPCR earlier this year. This trial was on stepwise provisional versus systematic culotte for the treatment of true non-left main bifurcation lesions. Present these results on behalf of all of the EBC2 investigators. Just to acknowledge that funding was provided for this trial from both Terumo Europe and Pi Medical Imaging. So the optimal treatment of true non-left main bifurcation disease, whether this be from an upfront two-stent strategy or by a provisional strategy, has been widely debated for many years. Early randomized trials were performed, and these actually tended to show neutral or even poorer outcomes with two-stent strategies, driven by both myocardial infarction and mortality. There was some criticism of these studies in that they involved the implantation of first-generation stents in patients with small caliber side branches, which may not have always been functionally significant. EBC2 was designed by the European Bifurcation Club in specific to address some of these concerns, and a provisional strategy which involved routine kissing balloon inflation and a T-stent if required was compared to an upfront culotte. Second-generation Nabori bioluminescent drug-eluting stents were used, and the side branch diameter to qualify for entry had to be at least 2.5 millimeters, with a side branch lesion length of over 5 millimeters. In all, 200 patients were recruited in Europe. Monitoring of the trial was performed by CIRC, and there was an independent clinical events committee. Now, the patients ended up being relatively high risk for coronary artery disease. There was a high prevalence of diabetes, previous MI, and previous PCI, and a third enrolled with ACS lesions. The predominant bifurcation site was in the LAD diagonal, and this is where the bulk of these results apply to. You can see that the main vessel and side branch lesion length were well matched between the two groups. There was a high rate of successful kissing balloon inflation, and of note, despite randomization, there was an increased rate of bystander PCI in the culotte arm. Procedural success was defined as a main vessel stenosis of less than 30% and TIMI3 flow in the side branch, and this was high in both groups. So the 12-month outcomes were reported in 2016, and the primary outcome was MACE, which was a composite of all-cause mortality, all myocardial infarction, and target vessel revasc, and this was not significantly different between the groups. What was noteworthy was that there was only a 16% use of side branch stenting in the provisional cohort, which meant that overall this group had shorter procedures, less radiation, and cheaper procedures. So 5-year follow-up was completed in 197 of the 200 patients. The primary endpoint which we report is the same. Bifurcation-related MACE was also analyzed, and we made this composite endpoint a combination of procedural acute vessel closure, stent thrombosis, target lesion MI or target lesion revasc. So these were the results at 5 years, and as you can see, there was no significant difference between the provisional and the clot groups at this time period, with a MACE rate of 18.4% versus 23.7%, and it was clear that both the curves tracked a similar gradient with time. Now, this particular pattern was seen with the individual components of the primary endpoint as well. It is noteworthy that there seemed to be a disadvantage for clot in terms of MI, and this was purely driven by periprocedural events, which you can see at the very start of that curve. Now, the mechanism of this is unclear. Acute procedural vessel closure was very low in both groups. Clot does involve several additional steps. Obviously, you need to pass a second stent, you need to do a repeat pot distal rewiring, and repeat kissing balloon inflation. It's possible that this extra instrumentation increases the chance of periprocedural myocardial injury, but we should also remember that the clot group did have a higher incidence of bystander PCI, and this may have contributed to some of those periprocedural events. We also looked at the influence of side branch disease length on the primary outcome, and there was no significant interaction seen. Once again, you can notice that for shorter side branch disease lengths, there seemed to be a benefit for provisional. Once again, this was driven by reduced periprocedural myocardial events, and as I mentioned, this is not of clear significance. Looking at specifically bifurcation-related events, overall there was no difference between the two groups. What was noteworthy was that the event rate was very low. It was at 6.5% in 5 years, and I think this was reassuring that we do achieve quite good outcomes in the longer term now with current bifurcation techniques and modern day devices. You can also see the site of bifurcation failure, and this was spread in both the groups similarly between both the main vessel and the side branch. So the conclusion from this study was that the use of routine clot did not really improve the 5-year MACE beyond provisional stenting in non-left main true bifurcation lesions, and in particular this did not interact with the length of side branch disease. Only 16% of provisional patients required a side branch stent, which meant that over 80% of patients in this group avoided the need for positioning of a second stent, repeat pot, repeat distal wiring, and repeat kissing balloon inflation. And this clearly had a benefit in terms of time, cost, radiation, and potentially myocardial injury as well. So in conclusion, we do recommend that the provisional strategy continue to be the default approach for bifurcation disease outside of the left main. This study was published in Eurointervention, and this was the QR code for access. Thank you.
Thank you very much for presenting this reassuring data. So maybe I will just start with a comment. Do you think that 5 years after the study was performed, we would do something differently in any further, techniques used with the knowledge and so on?
Yes, yeah, I think that's a very good point. I mean, both procedurally and medication-wise, things have changed. Procedurally, there's increased use, I think, of intravascular imaging. There's increased use of lesion preparation, things like shockwave have come out. Medications have changed over this time. We've got more potent dual antiplatelet therapies. We've got more significant lipid control agencies. And one thing that I didn't mention was the bifurcation-specific rates were much lower than the trial MACE rates, which meant that most of the recurrent events were outside of the bifurcation. So potentially, if we improve our medical control on these patients, we will reduce events further. In specific with clot, there have been discussions about using a DK clot, minimizing the area of overlap, and these changes may have also affected the outcome. I think the fact that at 5 years, the bifurcation-specific events, that they were so close, you would probably need a very large trial to then determine whether those features have an outcome effect.
And could you comment on the techniques itself? So were the operators really experts in the techniques they used, or the patients were randomized and they, like, per chance, the operators performed the technique for which the patient was randomized? But what was the percentage of port also, like final port in the culotte technique? Do you have the data on that?
So actually, unfortunately, that wasn't recorded, but I'd say that the enrollment of this trial was in Europe, where provisional and culotte is well known by most operators, and therefore most of the operators that took part in this trial probably had a specific interest in this. I think that any bifurcation trial, we are prone to some recruitment bias, where if the operator feels that if they're going to be randomized to provisional, they do not want to do a provisional, that is going to be a problem. So we need to understand that the patients that were involved in this trial were ones where the operators would have been happy to do whatever they were randomized to. And for every bifurcation trial, I think it's important to keep that in mind.
Do you plan to have a 10 years follow-up?
Not that I'm aware of, unfortunately.
Because
but,
we will, I think, looking at the result, we can put this trial, the results, in the series of Nordic 1, BBC 1, and this has something to see with the concept of Bonkonku, which is we were probably treated aggressively or not, vessels which are not important. That's maybe an explanation of the absence of the, the sub-diagonal with LED sub-diagonal bifurcation has to be treated with a crossover stenting, that's all.
Yes.
And we may be surprised if you look at 10 years. Remember Nordic and BBC One, you may have 5 years more, you may have a difference in mortality, what we observed in this trial. So this is another reason to be very simple in such a majority of bifurcation lesions.
Yes, and I think that goes along with what David was saying yesterday as well, that all of the stents we implant have an ongoing perpetual MACE rate associated with them. And what's not obvious at 1 year and 5 years may then be obvious at 10 years. So even talking about some of the balloon-related bifurcation studies with drug-coated balloons, it's probably important to do extended follow-up on them.
So I see now some additional question and comments. So we'll start with Kalavani, please.
Thanks, Yolanta. I just have one comment or question, or combination of both. Did you have an analysis of the bifurcations by the complexity of the bifurcation itself? So if you look at the definition criteria that studied complex bifurcations, which is slightly different, of course, and this is all-comers, so we all agree that a provisional strategy is completely appropriate in all-comer bifurcations, but the caveat on that was that in definition they found that if there was a very complex bifurcation, so one with a severe side branch stenosis, longer than 10 millimeters of disease, significant calcification or thrombus and angulation, then sometimes a two-stent strategy in just that group was beneficial. So did you have any analysis by the complexity of the bifurcation at all?
Yes, there's not enough information gathered to look at the specific definition criteria. What I will say is that the obvious comparison is with the DK Crush trials for these studies, and that the DK Crush side branch lesion lengths on a mean were always significantly greater than what was recruited in EBC 2. And we'll talk a little bit about this when we talk about EBC main a bit later today, but the trial populations are very different, and I don't think you can apply the results to any patient group. You need to be aware of that factor, and like I said, the fact that the patients that were included in this trial were the ones that the operators would have been happy to do either strategy for, and that may not have been the case if they were faced with one of the DK Crush population patients.
Sure.
So what percentage of your patients had kissing balloon or side branch inflation? So do you know that data, or was it just left alone?
So the kissing balloon inflation was routinely performed after the provisional strategy, so it was part of the trial protocol. Yeah.
So we are late. You have to run to the coffee. 5 minutes. I'd like to go.
Good morning, and thank you for coming. So we'll start right away in the interest of time. And the first speaker on the physiological evaluation of bifurcation PCI is well known, done a lot of work in this area, is Bon Kwan-Ku. Good morning, Bon.
Thank you. Good morning again. So can I have my slide, please? Okay. So sorry. I searched the PubMed and I found that the first specific bifurcation PCI paper was published in 1984, and this is one of them. And it is interesting to see that it is described as that the first kissing balloon angioplasty was performed in 1981 by Dr. Andrea Grunci. So since then, there has been a great and significant evolution of bifurcation PCI in terms of devices, procedures, trials, and techniques. But in terms of conceptual evolution, I think there can be one very simple concept under this evolution is that fixing the synaptic lesion will improve the patient prognosis, and we know that the larger, the better. And today I'm going to talk about the conceptual and psychological evolution of bifurcation PCI beyond that very simple concept, starting with the fractal ratio. So there are several complicated math and formulas and laws represents this fractal ratio, but the simple insight underlying this fractal ratio law and formula is that the D1, D2, D3 are not the same. From this very simple insight, we know that the concept of corneal shift and path has been established, and both were presented during the EBC 2008. And now we use this concept as a kind of common knowledge during the bifurcation PCI. But it is interesting to see the researches about the history of this concept, and the first paper on this Murray's law was published almost 100 years ago, followed by the 1960s association between Warsaw stress in bifurcation segment and pathologic studies, and we know that this really matters in terms of patient clinical outcome. So that the fractal ratio is really, really an important conceptual evolution in bifurcation PCI. The next story is very well about discordance between anatomical lumina narrowing and ischemia. So since the publication of this paper in 2005, we have accumulated lots of data that shows that the anatomical severity versus functional significant mismatch. So we are not surprising anymore when you see the FFR value measured at that big, significantly anatomically narrowed branches of 0.85. But what is more surprising to me is in this almost first paper about the kissing balloon angioplasty, they measured intracoronary pressure in both main and side branches before and after angioplasty, proximal, distal to the region. So that it's amazing to see how our ancestors or the pioneers did this beautiful work in the beginning. And the next concept is that the clinical relevance. We've been talking a lot about this clinical relevance because this relevance is very important in bifurcation PCI. We know that due to the very high variability in the side branch territory, as in this figure, between 3% to almost 20%. And that's the reason why when we deal with the side branch clinical relevance, ischemic depth is less important than ischemic width, or the myocardial mass at risk is more important than ischemic severity. So last year in this two consensus paper, one is KBC, Korean, Japanese, and European Bifurcation Club consensus, and the other is Bifurcation ARC, stressed the importance of clinical relevance. And it is very surprising to see that actually this is the first paper I found on the bifurcation PCI. And when you see the last sentence of this paper is that this paper ended up with the relevance of side branch at risk. So they already know in the beginning of the bifurcation PCI, and the pioneers of the physiology, Dr. Gold, Dr. Kirkedy, Dr. Christian Geiler, they already did elegant studies to assess the myocardial mass cell risk or clinical relevance of the lesion using beautiful and very elegant angiographic studies. And the last one is a little bit complicated one, microstructure and function discordance. So here is unfortunate case with complete occlusion of all diagonal branches. And in the ammonia PET scan, you can see a very clear defect in the anterior wall, all diagonal branch territory. So you may expect a zero coronary flow, but in this PET flow, you see that the average flow on those segments is as much as 1.64. It's not supernormal, but maybe enough to maintain the function. And this is the reason why in another case of total occlusion of the diagonal branches, significant reversible defect, but even during exercise, you cannot find any regional wall motion abnormality. So there is a discordance between ischemia and also the clinical and prognostic relevance. And I think this is the reason why I believe there's a missing piece in significant side branch puzzle, and which I can find that in the microcirculation or discordance between microstructure versus function relationship. And that is one of the reasons why we are now working hard on establishing microvascular simulation model in whole coronary circulation or the myocardium. But it is also surprising that all our previous pioneers did these wonderful works. In the paper you see on the left panel is that the anatomical assessment for the muscle arrangement and muscle structure between anterior wall and septal wall. So that we believe that the anterior wall, septal wall both are the same LAD territory, but they found that there was difference in the structural way, and this may translate into the difference in the ischemic resistance and collateral recruitability. So in this animal study, it was found that the same amount of ischemic insult, MI territory was less in anterior wall in comparison with the septal wall. So since the beginning of the bifurcation PCI, we really made a great progress in terms of techniques, procedures, and devices and trials. And I briefly mentioned some kind of conceptual evolution. To some, it may new, but we have to acknowledge that these concepts at least were proposed and established several decades ago, and some are almost a century ago. So my final question is that in this psychological evolution map, at which stage of your psychological evolution do you find yourself? Thank you very much for your kind attention.
Yeah, thank you very much for excellent presentation as always. So I'm sure there will be a lot of questions and discussion. Can we have microphone for Dr. Lovar?
I am very, congratulations for the presentation. I'm very interested by the oldest concept, the one of Murray and the fractal ratio. So I think we have probably in many countries now, in databases, we have the QCA post-procedure. We have a dedicated QCA, and we are able to measure the fractal ratio. We have the rule in Korea, which is 5, 6, 7, 8. This is made to preserve the specific anatomy of the bifurcation. But if you calculate the fractal ratio of this is not 0.678. This is 0.6, which is maybe a small difference. So what we can do, we can ask people working with big database, with QCA before, QCA after, and the clinical follow-up, we may see if it's bigger is better or ratio is better. I think we have the potential to do that. And if you, in Korea, in your database, and in many others, I presume. And I am looking at something also coming from you, which is myocardial segmentation. Do you think that having a systematic myocardial segmentation before treatment will help us, especially viable myocardium, will help us to define the optimal diameter for our bifurcation treatment?
Yeah, thanks for the very important question, but I think it's too complicated and too far, so that we have to wait another 10 years to be involved at that stage. But that will be helpful to assess. But it is important. It is interesting to remind that those studies which assess the territory or the territory-based vessel size assessment was elegantly done in the papers published in 1992-93. So that before we analyze the data, I think it's better to look back and review all those data, what our pioneers done, and think about what will be the next evolution in terms of our bifurcation PCI.
Dr. Cook, can I ask you on the opinion regarding angiography-based FFR softwares and promotion of those softwares to evaluate side branch before, during, and after the procedure, which does not really go aligned with our consensus. So please comment on that one.
Yeah, thanks for another very clinically relevant question. So that the previous original angio-FFR METIS system, actually side branch osseous analysis was kind of an exclusion criteria because they don't have enough data. But recent Murray law-based mu-QFR, they are supposedly saying that it can be feasible. At least it cannot be excluded. But we know very well about the angiographic limitation, and any image-based physiology is quote-unquote image-based physiology. So there's no kind of supernatural way to overcome the limitation of imaging. So that my bottom line is it can be helpful, but it will not be as good as a non-bifurcation lesion.
I have a question for you. So if you have a clinically non-relevant, say, diagnosed side branch, I've been bitten many times where you put a stent across, nothing happens. Other occasions, you might put a stent across, your patient has severe chest pain, ST elevation. Yeah. So how do you differentiate which diagonal side branch is very relevant? Particularly if the size is your defining factor of intervention.
Yeah, so that there are several ways to assess the territory using CT scan and size and the length, etc., etc. But my message is that there's a difference. So I'm talking about this relevance and functional test is that in a stable stages, not in the cath lab. We know that in cath lab, even losing small side branches causes a significant arrhythmia, etc., etc. So that what I'm saying is that whether to do a stenting or not, it matters, but maintaining TIMI3 is a totally different story.
Thank you very much, Dr. Ku. Excellent presentation. And it's my honor now to invite Professor Sunao Nakamura, Respect the Nature of the Vessel.
Thank you. Just talking about very interesting toy for the interventional cardios, just enjoy. So, how do you treat? This is a case of left main bifurcation lesion, true bifurcation lesion. Actually, always we discuss about what kind of stent technique and maybe target. We have two principles, provision stenting and TK crash. Even though, if we know everything about this, so maybe you will be agree. Thank you very much. Maybe you will be agree if you can finish in one stent in a bifurcation lesion very optimally, clinical result will be nicer than finishing a two stent. Look at this. This is a true bifurcation lesion. So actually, two true bifurcation lesions, circumflex and the LG circumflex. If you check the IVUS, you can see large plaque burden, around 90%. In this kind of session, we take this year. This is a resurrection of the new platform made in Japan. Very sharp cutter, small catheter, and high MDU, powerful. So actually, first, we need a test cut. We can see the window, so we can do the easily test cut, and then confirm by IVUS. Need to confirm what you have done right or not. And further cutting, need to check maybe every 10 reduction, need to check how much plaque burden already removed and still safe or not. And finally, less than 40%. Then DCB stent, no overlapping stent. So this is after the finishing, the no overlapping stent. Number 2, true bifurcation lesion, the distal left main. You can see this is a IVUS, big plaque burden without obvious calcium. And left main to the LED, cutting gradually, left in the circumference, finally plaque burden going to the 40%, and KBT with the DCB. Plaque burden going to the 90% to the 40%. This is the 12 months follow-up, actually very beautiful. So this is the rationale of the DCAB strategy, decreasing the number of the stent in the left main true bifurcation area, possible avoid overlapping to stent. And also quick discontinuation of the antiplatelet therapy, maybe patient with a severe thrombocytopenia, patient with metal allergy, maybe be nice. We already have some feasible study, DCB following a LOTA, following a DCA. Respect the best nature. This is Dr. Nakajima, my junior, his achievement. OCT follow-up study after the DCAB strategy. This is the OCT follow-up study DCB following DCA. Pre and post. And this is a representative case of the favorable healing. Actually, more than 90%, 95% case, we can see like this picture. 5 among the 60 cases, we have a restenosis. I'd like to show the representative one. This is an unstable angina. So actually, plaque area 85 to the 45%. And you can see this. Surface irregularity and the distorted shape of the lumen. Surface of vessel is uneven and the stratum-like appearance. Maybe microchannel, multiple healing event may be associated with TLR. So next case is also the unstable angina. Plaque burden 90% to the 47%, no deep cutting. And you can see the surface irregularity, the distorted shape of the lumen. Surface of the vessel is uneven and the stratum-like appearance. Maybe the multiple healing event, microchannel, and also microhemorrhage between the layer, maybe associated with TLR. This is the third case, actually no deep cutting, and the plaque area going to the 40%. Also, we can see the surface irregularity, distorted shape of lumen. Surface of the vessel is uneven. Excessive, so you can see the excessive layer formation. Maybe I think this is another mechanism. So we suppose distorted shape of lumen, uneven surface, stratum-like appearance might cause the uneven endothelialization, which means result in multiple healing. Actually, I said 5 of the 6 cases. About the remodeling process, this is the IVUS follow-up study. This is Dr. Ox's achievement. This is a case of vessel remodeling after the DCAB. Anyway, post 18 months follow-up. You can see this vessel area 29 to the 31, and then finally 25. Remodeling index is close to the 1. This is another case on post 18 months follow-up. You can see this is IVUS, vessel is 10 and 16 to the 15. Remodeling index is 0.99. This is the IVUS cross-section area. You can see that this is the original lumen and plaque area, and a stretch lumen cut plaque, and actually the very small part, but the negative reverse remodeling. You can see the negative reverse remodeling and the positive reverse remodeling. So this is the vessel area change. Maybe I think this is much easier to understand. This is the vessel remodeling index after the DCA plus DCB. You can see the both positive and the negative remodeling lesion seem to return to the normal size. Actually, this is in 59. So we want to believe DCB from DCA combined therapy for leaving nothing behind may lead. Actually, DCAB potential reverse remodeling toward a normal vessel size in both positive and negative remodeling lesion at baseline. Actually, I just remind that some, like 2017, Patrick Schreiss, reported that the artery remodeling after the BBS and the metallic stent, reverse remodeling. And also, I just remind the Million study, this is the Osaka University study, aggressive lipid and blood pressure lowering may lead a reverse remodeling. So my second rationale is that DCAB makes a vessel can move very freely, whatever he wants. We still, actually, we need more data. We're still on the way to solve the unclarified validity and effectiveness of the DCAB. Thank you very much for your attention.
Thank you very much, Prof. Nakamura. Any questions from the panel? Please.
Thank you. That was really innovative. For somebody who's new to this technology, there's a couple of questions.
Technology about the DCA.
Yes, that comes to me in terms of the simplicity, in terms of we're actually going to cut out the atheroma and then drug-eluting balloon. Sounds amazing, but it does worry me about putting a mechanism that cuts inside the coronary artery. What are the risks with the procedure? And also, I'm assuming there's only certain subsets in which this technology works in terms of it looks quite bulky. It wouldn't work on calcified lesions. So what are the risks and what particular lesions are you targeting?
First of all, if you want to answer your question, maybe it takes 30 minutes. And anyway, we have a DCA 30 years ago, maybe around 30 years ago. At that time, just the timing of the launching of the stent. And the DCA and the stent, so they fight under clinical trial, and the DCA failed. So actually at that time, the profile of the DCA is pretty much big, and not so actually bulky devices. And at that time, we don't have a DCB. This is another point. And actually, some Japanese guy very much like the DCA asked the Japanese company to make it. And finally, 5 to 6 years ago, we made it. Very smart one, sharp one, and very high, high-speed one. And this is very user-friendly. So even the circumference area, we can, advancing. And one big point is this is, if we want to use this, we need a pretty much sharp eye of the IVAS, and also some learning point. This is maybe I think some difficult point.
Dr. Nakamura, do you have data on the type of DCB that was used, sirolimus versus paclitaxel?
Unluckily or unluckily in Japan, we have only
paclitaxel.
Paclitaxel.
Okay.
So having used the Simpson catheter many, many years ago,
yeah,
this is a modification, right?
Yeah.
So are your guiding catheters smaller now? I mean, we used to use
7 French.
7? Oh, really?
Yeah.
7 French. And do you have an ultrasound attached to it, or is it on this catheter, or not?
So IVAS, different.
Okay.
Yeah.
Dr. Buran.
Yes, I remember the papers of Lansky comparing stents and DCA many years ago. The technology always coming back, new opportunities, new imaging modalities. I'm not necessarily convinced that you should not use it only without stents. There is a heavily fibrotic lesions that have a terrible recoil after putting a stent. You're struggling to get the stent size the right dimensions. And with imaging, I believe using this combination will be able to perform DCA, polarized OCT is coming. We may get more opportunities to understand better collagen content and distribution and use it in combination with drug-eluting stents. Definitely there is space. What about the amount of calcium that allows you to perform DCA? You don't have this technology in Europe, unfortunately.
So
how much calcium do you use?
Yeah, if you can see the calcium, superficial calcium, we cannot use DCA. This is a very big weak point.
Thank you very much. Excellent presentation.
So we need to move to the next presentation, which will be by Dr. Chang-Wook Nam, and he will talk about how to treat 001 bifurcation lesions, 1 versus 2 stent strategy. Please.
Thank you, Chairman. It's my great honor to have a chance to share my experience with all of you, especially it's a wonderful EBC 2023. So I'm talking about the side branch opening after, this is not the second presentation. Oh, no, not a big issue. So I will present the second one first. Okay, yeah. So this is a presentation about the design of a cross-copies randomized trial. So side branch opening after main vessel crossover stenting. So I'd like to start with a case. So this is RAD bifurcation region, 011 region, but the diagonal branch has moderate stenosis. So in this case, usually we prefer the provisional approach. So just a simple crossover stenting and additional posterior. And this is the result after simple crossover stenting. So there is some pinched jailing of a diagonal branch. So whether treat or not, there is still a very controversy in next step. So indication of coronary revascularization, usually there should be an angiographic target region, and also there should be some ischemia. And also, Dr. Gu already mentioned that there should be some enough myocardial burden for the treatment of revascularization. So already know that there is some discrepancy between anatomy and functional significance in jailed side branch after main vessel stenting. And also already see the result. There is the incidence of clinical real relevant side branch is not so frequent in real world practice. So indication of additional procedure in jailed side branch, it is very difficult to decide actually. So, and there is another issue about the residual strut of side branch ostium, protein strut. So you may see that this kind of picture that penetrated restenosis after crossover stenting of main vessel. But when we analyzed from the COVID-3 data more than around 2,200 patients with simple crossover stenting, the recent target region revascularization event in between the simple crossover or side branch opening was not different. And what our concern is whether the relation of side branch ostium related target vessel revascularization event, even though you do the side branch opening or just the simple crossover stenting, there is no difference between group. And also the outcome of strut opening in jailed side branch in non-left main bifurcation, there is several small studies. Nordic bifurcation study 3 in 2011, they include around 500 patients, no difference whether routine kissing or simple crossover leave alone. And also cross study from Korea, 2015, included 300 patients, even though it's a small study, but it's the same result. And this year, a KISS trial was presented at EuroPCR. They include 600 patients and randomized whether side branch opening or not, but early outcome was not different. But main issue is that the previous clinical trial showed the routine kissing balloon or leave alone, even though they include non-jailed side branch. Nowadays, EBC accepts that leave alone strategy if the side branch is not jailed after simple crossover stenting. So this is not, some doctor believe that this is not indication for kissing balloon. And then about the side branch diameter, small side branch was also included in the previous study. and then very small sample size, and no core QCA analysis, and no long-term clinical outcome. So we need another clinical trial to improve, to find out the real result. So our primary hypothesis is that the simple crossover stenting would be non-inferior to side branch opening strategy in the risk of target region failure in patients with angiographically compromised side branch. Visually, side branch stenosis more than 50% after provisional main vessel stenting for non-left main bifurcation reason. So inclusion criteria, side branch should be larger than the 2.3 millimeter is kind of treatable side branch, and then angiographically compromised side branch, visual more than 50% stenosis after provisional main vessel stenting. And exclusion criteria is a elective two-stent strategy needed reason, or after simple course stenting, TIMI-PRO, side branch TIMI-PRO decrease, or side branch dissection more than type 3. And also visually uncompromised side branch also excluded. And our primary endpoint is target region failure, composite cardiovascular death, NAMI, spontaneous peri-procedure, and clinically driven TLR. And secondary endpoint include many other results. And then sample calculation, as you can see, that finally we need each group 500 patients. We will include 1,000 patients. If I summarize again, cross-COVID trial, we include the non-left main bifurcation reason with a stentable side branch. And if need, the two-stent strategy, we will exclude. We will observation group 1 for that reason. And then we will do the main vessel stenting, and then if the side branch treatment is needed as a TIMI-PRO decrease and dissection, observation group 2, and if there is no compromised side branch, it's observation group 3. And finally, if the angiographically compromised side branch visually more than 50%, but TIMI-3-PRO is clinically acceptable reason, 1,000 patients will be one-to-one randomized to the simple just crossover with the medical therapy alone or side branch opening group. So this patient was actually randomized to the side branch opening. And we do the balloon angioplasty and then DCB treatment and then kissing again. And this is the result. So still we are doing initial point of this cross-COVID trial, and hopefully we can see the result in a few years later. Thank you very much for your kind attention.
Thank you very much. Excellent as always. If I remember correctly, in the KISS trial, randomization was done after POT, not just simple crossover. So I don't see that in your protocol. Is POT mandatory or not?
Yes, of course. We are strongly recommended to do a POT after simple crossover stenting, but this case is too short proximal segment, so we cannot apply the POT technique. But in protocol, we strongly recommend the POT. Then, after POT, when you did the final angio, the side branch jailing, then we tried to randomization.
Perfect.
I have a question also. So we know that just angiographic compromise, it's many times not enough. It doesn't correlate with the functional compromise. So do you classify this group according to the evidence of active ischemia, like angina symptoms or EKG changes in the group of over 50%, I mean?
Yeah, that is a very important point. But actually, during the procedure after simple crossover stenting, there is a definite evidence of ischemia. Operator can do the additional procedure. So there can be a decision depends on the operator. So we do not do such kind of things in randomization, but also we do highly recommend the imaging and physiologic guidance. But even though it's lesser than 0.80, but randomized to the liver alone, we will do the liver alone if the patient is stable. So we want to see the result.
Can I ask one question? Yeah, it's a great study design. Are you using drug-coated balloon in all patients, or is it just operator's discretion in which you go for side branch balloon dilatation?
Yeah, that's also very important question. So actually, in the protocol, we do not emphasize about DCB treatment, but recently, many doctors are very interested in the DCB treatment of side branches, so we highly recommend to use the DCB treatment, but not obligation in this study. Also, it's a pre-specified subgroup analysis.
I don't want to capitalize my position, but it's a very interesting concept, a very interesting study. One point, the problem by leaving the struts across the side branch is that you are not going to have neointima formation there. The main problem is that you have disturbed flow, abnormal shear rate, not shear stress, which is a predictor of thrombosis. And we have quite a few cases that I have seen living in the struts across the side branch that eventually the patient come back with clot in that branch rather than have neointima formation. So it's very likely that anecdotal cases, not enough to give you the power to prove the primary endpoint, but some to consider to have a long follow-up for patient for study like this.
Yeah, that is another big issue. But yeah, unfortunately, during the last 10 years, we are concerned about that issue. But when we get it from Korean data, actually, that kind of problem event was not so frequent. You cannot discriminate whether often or not. So,
and usually it's happening after the first year, again, the discontinuation of dual antiplatelet therapy.
Sure, but the depth duration is very important. Actually, your comment is very important. So if we do not often the side branch ostium strut, when we follow up the OCT 1 year later, most of the stent was covered. But until the 1 year, we don't have enough evidence. So maybe until the 1 year depth may be needed in that case.
Thank you. Do you want to present the second presentation as well now?
I'm not sure. Is it ready?
Can we ask technical team to put on the how to treat 001 bifurcation lesion?
Maybe number was fifth presentation. (001).
While she can, yeah. If you want to say.
Yes, I just to give a comment. I think, thank you for everything, but I think that it's not only important to see an angio finding, but the ischemia-driven follow-up is very, very important. And functional, not only invasive function, but also non-invasive follow-up.
Yeah, that's very important. But yeah, it is hard to import everything in the protocol. So we will do the angina scale during the clinical follow-up. Okay. So if you agree, okay,
yes, go ahead.
I will do the second presentation. Yes. So this is a second presentation. Again, very thanks to have chance to me to do this presentation in this EBC. How to treat the 001 bifurcation lesion. Today, I will talk about the 5 contents of a 001 bifurcation lesion. The first thing is how many 001 lesions are here, our daily practice in stentable bifurcation lesion. So last year, Dr. Mamas showed using the E-Ultimaster registry, including 4,000 patients, 001 is 3.5%. So we want to make the bigger registry data. So we call the extent bifurcat registry from Korea, COBIS 2 and 3, and from Italy, the RAIN registry, we include 8,434 patients who underwent bifurcation PCI. And we found that the Medina 001 lesion was 345 patients, so the incidence was 4.1% on 001 lesion during our daily practice bifurcation PCI. So second question is 001 bifurcation lesion, the behavior. Is it benign or malignant? So previously we have this data from the COBIS 2 when you compare the true and the non-true bifurcation lesion. The outcome was poor in true bifurcation in terms of MACE or cardiac death or MI. Also, the true bifurcation lesion is worse. So we know this data. But how about in this extended bifurcat registry about the 001 correct lesion? As the same as previous COBIS 2 trial, So this extended bifurcation research showed the true bifurcation region has a higher MACE rate compared to non-true bifurcation. But how about the 001 region? 001 is a non-true bifurcation region. However, the MACE rate during 3 years, 13.9%. Numerically, the highest MACE rate in 001 bifurcation region. So the anatomically non-true simple bifurcation region looks like, but the clinical outcome is a very complex bifurcation region in 001 region. Third question, what are unique features of a 001 bifurcation region? As we know that the side branch ostium has a negative remodeling, so it means it can be easily recoiled and lesser acute gain after PCI. And also, there is a risk of injury to main vessel when we treat side branch. That is also a very important thing when you do the 001 bifurcation region. And because of side branch is smaller vessel size, so we may use a smaller stent size, and the risk of stent failure will be high. And finally, the most important thing, angiographic 001 bifurcation is not always through 001 region. As we can see, this is angiographic 001 regions, OCR circumflex region. But when you do the IVUS in this bifurcation region, we can detect the ostium of side branch circumflex significant plaque with stenosis. But amazingly, even though angiographically it looks good, but distal left main showed the calcified significant plaque. And also the proximal LAD mild to moderate calcified plaque were extended from the distal left main. So at least it looks angiography 001, but IVUS, it looks 101, or at least 1-on-1 reason. So that's why the angiographic analysis is not enough for the analysis of 001 bifurcation reason. And first question is, what are the treatment options for the 001 bifurcation reason? There is 3 options always. Medical alone or balloon angioplasty. Nowadays, DCB is quite good, and stent strategy. In terms of medical therapy, actually, we know that, Dr. Gu already mentioned that the significant clinical relevant side branch, especially myocardial burden, is not much enough. So usually, medical therapy is highly recommendable. And how about the balloon angioplasty with a drug-coated balloon? Because we don't have enough evidence, but there is a strong and weak point. First strong point is we can reduce the metal burden and preserve the native bifurcation anatomy and reduce the risk of thrombosis and the duration of death. But still, there is a weak point. Risk of recoil on side branch ostium because of negative remodeling, and risk of dissection to extend to main vessel because we need more aggressive treatment before. Oh, sorry. The screen? Okay, thank you. During the side branch pre-treatment, there is a higher chance of a coronary dissection to extend to the main vessel. And then, importantly, there is a lack of large clinical data about DCB treatment. And finally, when compared the stent strategy for bifurcation PCI, 001 lesion, 1 stent or 2 stent strategy. Actually, when you review the 15 years, initially we treated 2 stent strategies frequently because the angiography 001 is not truly 001. But coming to recent data, we approach more provisionally in 001 bifurcation region. And then when compare the clinical data, the 2 stent strategy is more common in main vessel, main or LAD bifurcation region, mostly more than 90%. But 1 stent strategy is around 60%. How about the procedural characteristics? More kissing in 2 stents strategy, definitely we need. And 1 stent strategy, more POT was performed. And how about the QCA data? As you can easily expect, the 1 stent strategy side branch diameter is relatively big. That's why we can apply the main stenting from the main vessel to side branch. And about the 2 stent strategy, that's a user case. The reference vessel diameter of side branch is smaller than the 1 stent strategy. And the main vessel percent diameter stenosis is a little bit higher in 2 stent strategy. How about the primary endpoint? That's MITVR and stent thrombosis. Compared to 1 stent strategy and 2 stent strategy, no difference. So we can select any kind of a stent strategy. And how about the whether opening of a main vessel? Because we put the stent from the one stent, if we apply the one stent strategy, we will stent the main vessel to the side branch, and we can easily think about the risk of protein stent throughout of main vessel ostium. So even though we do not open that region, the outcome was not different. When you do the sub-analysis, any kind of subgroup analysis, there is no difference between one stent strategy and two stent strategy. So ladies and gentlemen, this is my summary slide. The incidence of angiographic 001 bifurcation region were rare in our daily practice. But in recent years, there has been a trend to prepare one stent provisional strategy for treatment of 001 bifurcation region. Although there is no imaging data, the angiographic 001 bifurcation region is not always a real 001 region. So additional intracoronary evaluation like imaging or physiology will be helpful. The clinical outcome after PCI in 001 region appears unfavorable as highest number of mains. So therefore, we have to take a higher risk than our thought. And also, when we decide to treat, it is imperative to consider a various of treatment modality when deciding on the most appropriate approach for each case of a 001 lesion, as like a DCA or DCB. Thank you very much for your kind attention.
Excellent presentation. Open now for comments, questions. Shazia.
Thank you. My question was, I know that the numbers are small, but is there any analysis of, I mean, certainly from my own clinical practice, those sort of lesions I would try to DEB. Do you have any analysis of outcomes in terms of DEB versus stent in a one stent strategy?
Unfortunately, we don't have that data. Yeah. We need some more data in the future.
Thank you, Dr. Chang, for your excellent lecture. But being an advocate for medical therapy, of course, it is a meeting of interventional cardiologists. But in schema trial, we have shown that even 2-vessel, 3-vessel disease patients with moderate ischemia are doing well on medical therapy. I mean, equivalent to CABG or PCA. So why are we running after stent or DEV or etc.? Because the medical therapy has improved so much. So why can't we try medical therapy alone and see in such cases?
Yeah, I agree with your opinion. So, yeah, medical therapy can be a good option for 001 bifurcation in most of the clinical scenarios.
Can we have microphone here? Yeah. Microphone.
Thank you for your excellent lecture. I would just like to ask, do you think that the 001 lesions have bad outcomes in comparison to other Medina classifications because of the nature we treat them, or because 99% of them are osteal LCX lesions, 001? Mm-hmm. So that is why the results are bad whenever we treat the osteal LCX, whether it is with one stent or even with two stent, all the outcomes of MACE are generally at the ostium of the LCX.
Yeah, actually, when you analyze whether the left main, this kind of osteal circumflex 001 compared to non-left main 001, there was no difference whether you use one stent or two stent. But yeah, actually, nowadays, I believe the non-left main bifurcation and osteal side branch rear 001 region, why we use a selected two stent strategy, actually, we don't prepared in that kind of region. But this is a study. Previously, our procedure. Yeah.
Thank you very much.
Okay, thank you.
So the next speaker is Carlos Colette on CT guided PCI and bifurcation lesions.
It's a pleasure for me to participate in this edition of the EBC. Good morning. It's a pleasure for me to participate in this edition of the EBC. In Poland. I wish I was there with all of you. And this year, I'm going to discuss about something that we have been developing for the last 3-4 years, which is the integration of CT in the cath lab. And this approach now guided towards bifurcation PCI. So everything started actually by looking at these type of reconstructions that are available with every CT scanner. This takes actually 2 clicks and you get this automatically reconstructed. And the people that are looking at these images are radiologists or imagers, and when they see this, their question is a diagnostic question, and sometimes they are unable to answer the question simply because the calcium produces a blooming effect and they cannot interpret lesion severity. But when you show these pictures to an interventional cardiologist, there is a complete different interpretation in light of a different clinical question, which is, if this is the next patient on the program on the table, this is going to be is a very calcific disease, is a calcified left main, calcific right coronary artery, and this patient must have advanced lesion preparation before we actually implant the stent. So we quickly realized that when it comes to coronary CT, one single image can have two different interpretations depending on the person seeing the images. And we have learned a lot about fractional flow reserve. And one of the things about CT in the last few years, and what we have able to understand, is that just by looking at this image, again, this is a simple, perhaps provisional PCI with a bifurcation of the diagonal branch, but without calcium. And again, if we contrast this with the previous picture that I show, you see immediately that the degree of complexity of these two vessels is completely different. The other thing that we have engaged is in understanding the advantages of these technologies like fractional flow reserve derived from CT. And beyond the classical significant or non-significant fractional flow reserve, we're actually looking at this in a different way and understanding not only the significance of the disease, but also the distribution of resistance. And then what we have here is on the left side, a vessel with diffuse coronary artery disease that is associated with residual angina after PCI. And then you have on the right side, a vessel with purely focal disease, which is basically the best scenario for PCI. And these have been expanded by the development of this tool called the fractional flow reserve derived from FFRCT, the FFRCT planner, that actually enables you to understand what would be the results in terms of improve in blood flow after a given PCI strategy by putting a virtual stent. And the way it works is very simple. This is an iPad, and then you decide the length of the stent, and then you click on this button called Open Lumen, and then you see what happens immediately in terms of the fractional flow reserve after PCI. Now, I want to also add the morphological component, which is readily available with CT. And what you see now is a different way to characterize atherosclerosis. And of course, all of us are familiar with OCT and IVUS, but also CT offers the possibility of not only looking at the lumen, but also understand the extension of the plaque, the composition of the plaque. And I want to make special emphasis about the ability of CT to assess calcium. So CT is able to assess calcium thickness, calcium arc, and calcium length. And when we compare these tools, this CT assessment, which is on the horizontal axis, with an assessment derived from OCT, you see that CT is perfect to assess length, it's very good to assess arc, and it's moderate accurate to assess thickness. Now, the way that we have integrated this into practice is different. So we're not working anymore with these plain MPRs and crude image. We have actually facilitated the understanding of these geometries by creating a mesh of the lumen, superimposing the plaque in 3D, and then creating some colors to make this intuitive to interpret. And any of us without real experience in CT can easily interpret these type of geometries. But I have to say what really changed the way that we're using CT is the fact that now we're able to embed this in the cath lab. So we have on one side the information coming from the lumen, and on the other side the information coming from the plaque, and this is synchronized with the C-arm, and that helps us, of course, understand not only the lumen, but also the plaque extension and composition during the procedure. And we have learned a lot. We have learned a lot about how the position of the calcium influences occlusion of the side branch, simply because the balloon at the level of the side branch, where the calcium is located in the contralateral side of the carina, expands away from the calcium, and this is one of the factors leading to occlusion of the side branch. Now, we see coronary CT complementing intravascular imaging in a number of ways. You have some of these elements on the screen, but I think we have to also emphasize that the fact that it's a non-invasive modality allowing for pre-procedural planning. I'll show you a couple of cases of the trial. Look at, so we have here extracted the morphology. This is a patient with a double bifurcation, so left main bifurcation towards the LAD, plus a bifurcation, the diagonal branch. You see the distribution of the calcium. Now you see here the physiology of these lesions, and you quickly understand that there is some pressure losses at the proximal, at the ostium of the LAD, and also at the level of the diagonal. And this allows to plan the procedure. We can derive, of course, the mass and understand which is the side branch that require best protection. In this particular case, of course, we wanted to protect that diagonal. And again, we try to understand from the technical point of view which is the best PCI strategy leading to the best functional revascularization, and the other things happening in the cath lab. And CT, again, help us select the guiding catheter. We go straight forward to the PCI procedure that we want to do. And finally, with this software that is in the cath lab allows to measure length and, of course, avoiding, for example, doing overlapping stent in front of the side branch. In this case, we did DK crush. Now, to summarize, this is all the information that we can extract from CT, understanding lesion complexity, selecting devices, and I'm talking about guiding catheter, but also plaque modification tools, tailoring the strategy based on the myocardial mass at the level of the bifurcation, understanding the best angulations to see the ostium of the side branch. This can be done live, and of course, using physiology not only to assess the severity of the disease, but to understand the pattern and predict the results. Everything that you have seen, we're testing in a randomized clinical trial. We have included around 300 patients in the P4 trial, where we're testing this strategy that we call CT-guided PCI against an IVUS-guided PCI, and this is a non-inferiority design with MACE as an endpoint. So to conclude, I think that we have moved coronary CT from a diagnostic tool to a tool that allows for procedural planning, including the assessment of the bifurcation angle, plaque distribution relative to the side branch, and calcification severity. The three-dimensionality of the disease in the three vessels can be extracted from the CT, and we believe that the addition of physiology is just a plus, informing us again about the presence and severity of the disease in the different places in the coronary tree, and again, the introduction of these images inside the cath lab facilitates the interpretation and the adoption of this technology. And with that, I would like to thank you for your attention, and of course, happy to answer any questions. Thank you very much.
Thank you. Thank you very much, Carlos, and thank you for joining us. So this presentation is now open for questions or comments. Do we have any questions? Yeah, Shazia, please.
Thank you. Great presentation. I can understand that CT gives you additional information prior to getting into the lab, which will make the procedure easier. But in terms of the actual data that you get from IVUS, that's going to be the main determinant still of what you're going to do in the procedure. So does the cost and extra radiation that you get with CT, is that justified in terms of the incremental information that you receive? I assume that's the point of your study there.
Those are very, very good questions. And I'm going to tackle this from two perspectives. The first one is that when it comes to the pre-PCI phase, we believe, based on the data, that the information coming from IVUS or OCT can be also extracted from CT. And I show you some pictures about the calcium, but we have expanded this. And we actually believe that the way to interpret calcium with CT is becoming so easy that it's straightforward to understand not only the arc, the length, and the thickness, but also the location in relationship to the three-dimensionality of the vessel. There are more things about calcium where I believe that CT has an advantage over intravascular images, but I think that will be touched by Dr. Okutso in his talk. Now, one of the things that CT offers that intravascular imaging does not is the fact that you can prepare for the case. You go to the case understanding not only the disease you're about to treat, you understand the necessity of plaque modification tools. And we believe that most of the time, having this information beforehand, we will trigger the use of more intravascular imaging. Now, the second part of your question is very relevant because CT is very important in the pre-procedural phase or before you actually instrument the vessel. But after you have balloon, after you have modified the plaque, CT will not help you anymore. And I think this is the time where tools like IVUS or OCT are very important to understand what is the result of the intervention that you have done, and of course, offer additional information about the next steps during the procedure. But I think most of these things, again, from the pre-procedural part, can also be extracted from CT.
Christos?
Yeah, Carlos, I'm watching your work. It's fantastic. It's very inspiring. It is towards the right direction because you have the data, you have to use it. One thing that I have noticed quite often from the early days and still working on reconstruction, you have a different vessel, totally different vessel when you do imaging with angiogram or CT and when you're putting a wire down. Because you have a total distortion of the bifurcation, the planning may be totally changed. You start thinking, for example, committing in a T-standing and then you're realizing that eventually I have to do too a lot because the angulation change depends on the amount of calcium and the flexibility of the vessel. How often have you seen from your experience changing the planning because of change in the anatomy?
Yeah, that's a very good question, Christoph. And again, I think that what is nice about going to the cath lab with a plan is that you know what you're going to face. You know where the calcium is. You know what the potential complications are. And then you have your plan A, you have plan B, and you have plan C. But you have these plans with a lot of information about the disease. So to answer your question, so we do have in the P4 trial, you get a recommendation about treatment. And then we are, of course, following how many times this is followed as we suggest to do and how many times you deviate from that. I can tell you only preliminary numbers because we have a small number of patients still. And I think we are following the recommendations in about 80% of the cases. And in about 20% of the cases, operators decide to do something different based on what happens during the procedure.
Carlos, thank you again for excellent presentation. Looking forward to have you in person next year.
Thank you very much. So this is going very fast. I'm sure all of us have questions, but we are at our last presentation by Dr. Julian Jeff, the POT-PAF sign and angiographic mark of stent malposition during proximal optimization, please.
Thank you a lot for this invitation. I will start with the presentation about POT-PAF sign. First of all, I would like to suggest you, if you have small kids, this reading, because I read it a lot with my children, and it's called What to Do with an ID. And just to tell you the ID, is that an ID of a little boy or little girl following the children, but the child didn't know what to do with it. And we got a simple ID to test, and that was the simple ID. We have this bifurcation, and we needed to treat bifurcation. And we did the POT, which is really important to do when we do bifurcation. And we, just for educational purpose, we filled the balloon with not with contrast, but with pure saline. But the balloon is inflated. And we inject POT, small amount of contrast, and we have seen some leaking of contrast all along the vessel. Then we increase the atmosphere, and we block completely the contrast progression. That was the idea to test. So the idea was, let's compare the POT-PAF sign. If we have contrast going through, we thought that we will have malapposition in the POT zone. If we don't have contrast going through, and it's blocked, it's a negative POT-PAF sign, and we're supposed to have a good apposition in the POT zone. And we had to compare it with OCT. So that was the design of the study. When we think about this idea, we said, okay, 1/3 is of our coronary bifurcations or of coronary PCI involve bifurcations. And if we come to the fractal law, I have some difficulty because my eyes are not precise enough to see and estimate the millimeter of each vessel. I'm not good enough to that. And my brain is not enough smart to do this calculation without material. And last of all, it's not always valid. You can have sometimes positive remodeling in the POT zone, so it's way bigger than the fractal law. It might happen. So this can lead to a suboptimal POT, malapposition, thrombosis, or restenosis. We build from this idea an academic study, multicentric, 17 participating center, and we just perform bifurcation as we are used to do. We just excluded the left main, And we performed the pod puff sign, so inflated the pod balloon, inject some small contrast, record it, and see if the contrast is coming through or not. So if it is positive or negative, and at the end of the study, at the end of the pod puff sign, we just have to do one mandatory OCT to confirm the sign. And the study stopped there. After that, you can improve your PCI as you want, but the study stopped at the final OCT. We did a cutoff of 200 microns, and these are the essential results. So in 17 experience center, the first thing that we have seen is that we have more than 20% of malapposition in the pod zone. So it means that even in experience center, we finish the procedure with malapposition. And OCT confirmed that, so intracoronary imaging is a help for that. And the pod puff sign was really good. We have here the diagnosis performance of this sign, and we have seen that when we have leaking of contrast, you really have malapposition, and if the contrast is completely blocked, most of the time we have complete good apposition. So these are the essential results. More than 20% of malapposition if we do OCT at the end of our procedure without looking for something else. We have a clear reduction of malapposition when we do OCT analysis, when we compare the pod puff sign plus versus pod puff sign minus, with a decrease of more than 60%. And at the end, I will tell you that the bifurcation lesions are frequent. We use everyday POT, and this technique is simple, it's free, and we can do this pod puff sign to avoid malapposition in the pod zone. We did 183 procedures compared to OCT with a great accuracy, and it's a feasible technique to assess malapposition. It's straightforward. So sorry for the spoil. At the end of the book, the idea is not to the children anymore, it's for everybody. And I would like to thank all the community for this fantastic work and idea. It was a fantastic adventure for us. And so the study was published in Neurointervention, and it won PCI Got Talent with the very good skills of Farang and Minfar, and some community sharing in the social network. Thank you a lot.
Thank you very much, Julien. I have to say for the colleagues here in the room that Thierry Lefebvre actually suggested this topic this year. So he still thinks about EBC, and I'm really happy that maybe sometime in future we will convince him to come. And I would like to invite you all, of course, to submit throughout the year any kind of relevant data that you may submit to us to consider for the next EBC. Because we really would like to go level up and open EBC, but open to share data, not only the cases. So this year we had great selection of cases. Next year we would like to have some more data to discuss and share. Francesco.
Thank you very much for the presentation. I think that is a smart idea. In your experience, is this technique less effective into the left main? I mean, into the left main, we have the contrast that has the potential to flow back. So the potential to go through a small malapposition can be a little bit less. So are these cases where there was no correlation located into the left main? That's
a very, very good point, and I would like to thank you for that. We prefer to exclude left main just due to the intracoronary imaging. We really wanted to have this proof of concept, so we said we will not challenge ourselves with intracoronary imaging in the left main, because we really needed to see each strut and each malapposition. In a clinical practice, I use it also in the left main, and I'm clearly convinced about the idea and the technique. I think there is no reason that in the mechanistic you have, if you have leaking through your pod balloon in the left main, I will systematically go for a bigger balloon to try to have the full apposition. But also, I think intracoronary imaging is also a really great tool if you want to have left main to treat if you have any doubts.
Yeah, 2 questions from the audience. Yeah, please stand up so we can see you. Yeah,
yes, congratulations for the great presentation, and it's a very good idea. Just have two questions for you. Just did you experience any malignant arrhythmias during the contrast injection and blocking the LAD, the proximal LAD? That would be one of my questions. And do you use an assist device, or do you have a specific amount of contrast putting in the coronaries, or you just go up as you go until you see no contrast moving towards the end of the vessel?
Thank you. That very good point. We did it in 17 centers. So we had some centers with manual injection, some with automatic injection. What was recommended is when you film the pot, you inject some contrast. It was recommended between 3 and 5 cc, so it's not that much. And we wait for 3 or 5 beats. We did this comparison, but if immediately after 3 beats you don't have leaking, we considered it's enough. So we didn't face any complications, arrhythmias, or things like that, because we don't do a prolonged pot due to this technique.
Please.
First of all, congratulations for the great, excellent idea. I mean, innovation is always welcome, and this is truly creative. My question is, do you think it would also work within a standard filled balloon, half-half, with contrast?
Sure, completely. That was only for the illustration. You can clearly better see if the balloon is filled of saline, but you can use it with half contrast, half saline. It's exactly the same story. We are not looking at what happens in the balloon, but what's going through after.
Dave?
Yeah, very nice presentation. Do you also use this now for ordinary stent implantation?
For stent implantation, that's an excellent point. No, I don't use it for stent implantation because we think, or I think also, if you have a stenosis and you put the balloon on the stenosis, the contrast will be blocked, and it won't say if you have malapposition after or before the stenosis. So in any case, you will have the contrast blocked because you treat the stenosis. And so we are not precise enough to see if you have small malapposition just up front or downstream the stenosis. That's why we really dedicated this technique to the pot. Might be an idea for the future to test, but we didn't challenge that technique for all along stent and all along stenosis.
Okay, if there are, yeah, please. Can we have a microphone here?
That was a great presentation and idea. What was the size of the balloon that you used and the pressures at which you inflated it and then put in the contrast?
Sorry, pardon?
The size of the balloon. Was it 1:1 at nominal pressures or at higher pressures? What?
This is at the operator's discretion. So many centers participated. You do the pot with the balloon size that you want. But me, I prefer really to use the semi-compliant balloon because if I have a positive pot puff sign, so contrast going through, I just have to increase the atmosphere to reach the good size. So that's how we deal with that. I don't know if I clearly answered to your question.
Julian, is it possible to go back to the angiogram pictures and then actually see
Can I
you do
have the slide back?
It may just help, if it's possible.
Sure. So here. So balloon is inflated at 8 atmosphere. It's 3.6 because it was semi-compliant balloon, and it's the same balloon, and went to 16 atmosphere, and I have 4.0. So you see contrast going to the septal and to the diagonal and a bit to the LAD. And when you do more, you don't have this effect anymore. And it's working well with also a half-half balloon contrast and saline, but it's more obvious with pure saline. But it's only to show you the basic of the technique.
Thank you.
I know that Yves Lovar is impressed with this idea. It will be part of his presentation today. And I think this will be the beginning of a real clinical practice. Thank you very much, Julian. Thank you all. Well-deserved coffee break, half an hour, and we meet 11:30.
So please enter from the coffee break. I know that coffee break is a great moment also for sharing experience, networking. But we are ready to start the new session. It's a pleasure for me to chair this session with Marek Ferenc and with Marco Zimarino, clearly. Panelists will be, I'm sorry for my pronunciation of some of your surnames, Nia Mileva, Mila Kovacevic, Christos Borontas, Mohamed Munawan, Nihil Parshur, Rajiv Bakwat, which is good. It means it's really inclusivity, no? And that's very good. So good inclusivity of what I say, sex and ethnicity, and that's the best. That's how we should go. I mean, so the first presentation is from. I didn't see him, so I don't know if it's connecting. Ah, you're there, okay. From Yoshi Ononuma on CCTA intravascular imaging guidance in bifurcation PCI.
Thank you for the introduction. So my talk is about CCTA and intravascular imaging guidance in bifurcation PCI. I will start with the case presentation, which was also presented at the EuroPCR this year, and that was prepared in collaboration with the group of Toulouse. So Bruno Farah and John Fajadet was also in the panel in that session. So this is the case. So 81 years old male, presentation with de novo crescendo effort angina, chronic coronary syndrome, and Canadian class 3. And there's no known cardiovascular risk factors, no previous medical history. Creatinine clearance was 64 milliliter per minute, and echo was, ejection fraction was preserved, but there was a moderate aortic stenosis. Mean gradient for the moment was 23 millimeter mercury. So for this patient, if you look at the pretest probability according to these ESC guidelines, and the patient has a typical angina, the age is older than 70, and the patient is man, so 52% of the pretest probability of this obstructive coronary artery disease. And also, of course, patient has symptoms, so coronary CTA is indicated as class 1B recommendation. So in this case, CT was performed as a first diagnostic test. This is a volume rendering and maximum intensity projections. You can see that there was some calcification in the left main. I think from the anatomically speaking, this is the right dominant anatomy. And you can see that for the right coronary artery, you see this spot of the calcification. You can count 3-4 plaque, but it's not really obstructive in this MPR multiplanar reconstruction. The FFRCT also shows that negative result. Distally, the FFRCT was 0.86. So these are the non-obstructive coronary artery disease. If you go for the left system, however, there was a significant drop already in the distal part of the left main. You can see that the FFRCT of the LAD was less than 0.5, and you see, if you look at the cross section of the images, you can see that there's a significant calcification in the distal left main, almost 360 degree, and there was also the the circumflex ostial plaque, but it's not seems not too much obstructive in these cross sections. So we can see that also the dimension, proximally the left main has a dimension of the 4.3 millimeter, LAD was around 3.0 millimeter. And there is also another plug in the bifurcation of the diagonal with some calcification. First, we calculate the syntax score to look at the indication of the PCI or cabbage. So you see that the right coronary artery, no significant stenosis, circumflex distal also no stenosis, but it is included in the left main lesion. So the point was 24. If you look at the LAD reconstruction, you can see the significant stenosis in the left main and some stenosis in the LAD mid. So the syntax score is 24. By combining these clinical factors such as creatinine clearance, ejection fraction, gender, COPD, etc., we could predict that the 10-year mortality of the after the PCI is 45.5%. If the patient undergoing the cabbage, also the mortality 10 years is 45.5%. So from the risk point of view, the patient could be treated in both ways, but because of the anatomy and after the heart team discussion, patient was referred to the PCI. So you can see that the left main ostium, there was a significant drop in the FFRCT, and we look at the angiographic view. So if you want to see the ostium of the left main, the best viewing angle was the LAO 20, cranial 30. If you want to go for the bifurcation, then the best view is the spiral view, LAO 50 and caudal 35. So that was known before going to the cath lab of the PCI. So the strategy based on the CT was maybe the aorta is not so big, so we can use the 30 EBU 7 French. There was a significant calcified lesion in the left main distal, so maybe we need some modification of the adjunctive device such as lithotripsy or even rotablator. Working angle was already shown, so there's a two working angle, one for the left main ostium, the other one for the bifurcation. Stent selection, proximally it's a 4.3, so maybe distal is 3.0, so we could maybe use a 3.0 millimeter stent, and port was 4.5 millimeter. We also think about the distal lesion, the mid LAD, but this is a PCI planner based on the FFRCT. If you stent in left main, already the FFR is improved in the distal LAD, so maybe we eventually don't need to touch on this mid LAD lesion. So that was the planning. So yeah, so these were also the consensus paper on the calcified lesion published in the European Heart Journal. So in this case, we have luckily the very good quality of the CT, so we could really see this distributional classification, functional severity, CT syntax score. We can have some catheter selection, optimal projections, road mapping, and also we decided to go for the adjunctive device preparation before going to the cath lab. So actually, next slide is the actual case in the cath lab. So you see some calcification on the roof of the left main, and we started immediately from the shock wave. So we did the 12 cycle of the lithotripsy, and then after the shock wave, we have seen some of the dissection in the proximal part of the left main, and we stented with the drug-eluting stent 4020 millimeter. And then after that, we went for this spiral view, which is as predicted by the CT. You see some of the complication in the circumflex, so we converted to the 2 stent. It's kind of the T stenting, and we just put another stent, 12 millimeter stent. Kissing balloon was performed, and the final port was done. We are a little bit worrying about protrusion of the strut into the left main, so we did the OCT. So the next slide is the OCT. You can really see that the ostium of the circumflex was very well open. There's not so much protrusion, or almost no protrusion of the strut from the circumflex. So I think we finished the procedure. So this case just illustrates that how you can use the CT and for the planning of the PCI in this complex bifurcation lesion PCI. In this case, it was the left main, and also the indication of the PCI or cabbage could be also discussed during the heart team based on the CT. So, however, once you start the intervention, sometimes you have a complication or some uncertainty in anatomy, then you have to use intravascular imaging. So our view is that in the near future, probably we don't need a diagnostic angiography, or you can eventually skip the diagnostic angiography and directly from CT to PCI or even to the CABG. So the question is that can surgeon operate the patient solely based on the CT? So we are conducting one trial called the Fast Track CABG trial, where the surgeon tried to operate the patient solely based on the CT without looking at the invasive angiography. Yeah, so the trial just finished. 114 patients were included in this study, and result will be presented in 2 weeks at TCT. The feasibility will be presented at that meeting. So if the trial is very positive, the next step is to really see this approach of the CT and skip the invasive coronary angiography. So we are planning to do this Syntax 4 trial, which will be the patient in 3 vessel disease or left main plus other coronary artery disease. If the patient is randomized to the CT-based pathway, CT will be performed. Additional information such as the cross-sectional plaque, FFRCT will be provided, and her team can decide either the patient is going to the CABG or the PCI, and after that we will see the clinical outcome based on the CT-based pathway versus the invasive coronary angiography-based pathway. So this is still in design, but I think in the future probably we will skip this diagnostic angiography. Thank you for attention.
Yeah, thank you so much. Great perspective, probably. We still have some conflict between radiologists and cardiologists. How is this solution resolved in this problem resolved in your center?
Yeah.
Who is looking for the data? Who is giving evaluation results? Radiologists, cardiologists, both?
Yeah, I think that's a great question. So in this fast track trial, we included 4 centers, and majority of the centers there is a kind of the hybrid cardiologist radiographer, so that they have a dual accreditation of the radiology and cardiology, and these people are part of the heart team discussion. So in those centers there's no issue on the interpretation of the CT. And also in this trial we also provide some analysis from the core labs. So during the heart team discussion, they can also consult the imaging analysis of the core lab as well. But you are right, I think in some of the center there is some kind of conflictual situation between the cardiology and the radiology, and I think the future should be that we really collaborate together, and I think during the heart team discussion, all images should be interpreted collectively with the cardiologist and the radiologist.
Yeah, but the point is that at least in some country, the CT scan has to be reported by a radiologist. It's by law, so you have to have a radiologist writing I think in most of European countries. Then we can discuss about education also of our radiologists, because that's another point.
Yeah.
Are we ready for that? Because I can tell you our experience, and I'm in Milano. It depends who is doing that CT scan. Because sometimes they come with, unpredictable result. I had the case last week. It's a diagonal. It was a suboccluded LED, by the way. So the point is, are we ready for this? Conceptually, it's great. Absolutely. It will avoid a lot of, not indicated coronary angiography.
Yes.
And they are very complex patients sometimes, and so you expose them to a risk, by the way. But the point is the community of our radiologists ready to do that?
Yeah, so this is a first-in-man trial, and of course it's still a clinical trial phase. So I think first our intention is try to prove that it is possible and also can be done safely. And also the other point is that in this trial we use the kind of the new generation of the CT, and also nowadays the photon counting CT and new technology is coming. So I think that will be really changing and moving target. And yeah, I don't know if it's really ready or not, but first I think in the clinical trial setting we have to prove something, then probably the community will accept. So that,
and then reimbursement, by the way, because surgery, at least in some country, is better reimbursed if they have also coronary angiography, and that's big problem also for valve, for example. I don't know the experience of the others in the panel, how it's done in your country's coronary CT scan. It is done before procedure, it's guiding your procedure. Who is reading?
Yes, there's always a conflict, I think everywhere between radiologist and the cardiologist. A lot of cardiologists are training and certified to do CT coronary angiogram, but there are not many. In United Kingdom, we have a pathway during training of imaging, intervention, electrophysiology, heart failure, and devices. So those who undergo imaging can do MRI, CT, and so and so. But we do not have many. To this particular patient, I would like to ask you a question. I saw that you did not do any pre-imaging with OCT or IVUS. So do you think that we have reached that point in time where CT-based assessment is good enough for us to guide our procedure in terms of selection of the balloon size, as you selected balloon for cracking the calcium without IVUS or OCT imaging? So do you think that we have reached that point in time that we are confident from CT that we can take those decisions?
Yeah, thank you for the question. I think in this particular case, we decided already to use the IVL before going to the cath lab. The size of the vessel is sometimes tricky because in the CT, sometimes the nitrate is of course given, but you might see some difference in the cath lab. So we might be a little bit careful, but at least for this case that we know that we need to use some adjunctive device. So that was somewhat useful in preparation of the cath lab. And for the dimension, I think, we should probably look at the angiography as well, so that it's not solely based on the CT, but
okay. Okay, thank you so much. Anyway, thank you so much. Again, congratulations for your excellent. We're going to speak about CT also in the next.
Okay, one comment only about what Yossi has mentioned about the sizing. We have analyzed 186 vessels, much near SIVUS and CTCA. We have significant difference in the sizing, so we have to be enthusiastic about CTCA, but I'm not sure that we are ready to advocate stent sizing based on CT data. We have to use intravascular imaging for guiding procedures. That's my feeling. I know that the research is happening in towards that direction, but my first reaction from 23,000 matched images is that probably we need a little more work on that.
Okay.
Let's
move to the
I'm
next
sorry,
one.
but we cannot admit any reply, so we skip to the next presentation. I invite Masaki Okutsu to have again a discussion about shape of calcification for PCI with a useful kit he's going to propose us. Thank you so much.
Thank you very much. My presentation is about how to evaluate the calcification by CT. And actually, intravascular imaging is recommended to evaluate the indication of the atherectomy device. However, another important point is guide wire bias. The cross bias induced much more calcium aberration. In our hospital data, less than the 0.5 millimeter distance from the guide wire to the calcification is the good predictor of the good aberration by the atherectomy device. Calcification is, of course, have a very good important role in left main disease also. the eccentric and large calcium mass induce and the coronal shift is very easily. Actually, the intravascular imaging is recommended, and CT is not recommended for the evaluation of the calcification because unclear image and much artifact. However, the CT has some advantage of the pre-procedure assessment and no need to pass the region and visualize the calcification overall body. However, the problem is how decide the calcium border from the CT image. In EBC in 2019, we had introduced a new calcium measurement algorithm by using the new formula. And this formula means by using the maximum CT density inside the calcium, from this score, that we can gain the calcium border CT density, and we can check the calcium thickness. And by using this new algorithm, last year we introduced a 3D calcium model. And then this year, we would like to introduce a 3D virtual guide wire bias simulator. As you can see, this red line is guide wire bias simulation line. The simulation algorithm is below. The proximal starting point was placed on the center of the lumen, and the distal end point was outside in the lumen in the curvature point. And these 2 points, between these 2 points, bias simulation line should be created, the shortest course with the latest curvature. And we'd like to introduce the 3 cases of the calcified lesions. This case had a very diffuse type calcification, and from the areocranial view, as you can see, the calcification distribution is inside of the curvature. Usually, like this distribution is thought to have a good guide wire bias. And then, checking the guide wire bias simulation image. The number 1 point is the distal left main and distal left main part, and 3 is 4 is proximal mid LAD part. These 3 points have a good contact to the calcification. However, the LAD osseous part, the number 2, in this point, the simulation line is far from the calcification and near to the carina side. And checking the OCT, the left side is a pre-procedure OCT image, and number 1 and 3, 4, in this 3 image, the guide wire has contact to the calcification. However, number 2, in the osseous LAD, the guide wire was far from the calcification and contact to the current side. And after rotablator, the number 1, 3, 4 figure can be seen the aberration area of the calcification. However, the number 2, the osseous LAD had no aberration area in the calcification, and but the carina side had intimal injury. So this result is matched to the guide wire bias simulation. The next case is left main to LAD calcified region. And this is a 3D guide wire bias simulation image. The number 1 is the distal left main, and number 2 is the bifurcation core. Now, these 2 points had good contact to the calcification, but the more distal part, osseous LAD number 3, and the more distal part, number 4, and the simulation line is far from the calcification. And from lumen view, as you can see, the red dot line circle is a contact point. So this means this region had a good guide wire bias. And checking the OCT, the left side is a pre-procedure image, and number 1 and 2, this is distal left main and the bifurcation core point, and good contact to the calcification. But actually, the bifurcation core had a deep side calcification. On the other hand, the osseous LED, number 3, had no contact to the calcification and the contact to the current side. And more distal part is also not so good guided by bias. And after orbital atherectomy device. And then the left main distal part had a very nice ablation, and after the atherectomy device. And however, the number 3, in our osseous LED, the calcification had no ablation and no ablation sign, and the current side have also intimal injury. So this result is also matched to the guide wire bias simulation. And the final case is the circumflex ostium case. As you can see, the very heavy calcification can be observed from the left main to the circumflex. And about this case bias simulation image, in the left main segment, the simulation line is far from the calcification actually, and the bifurcation core point have a contact to the calcification, but a very short segment, and the more distal part from the circumflex ostium, and the more distal part, the simulation line is far from the calcification, and from the Riemann view, the contact point is the red dot circle. This point actually had a few calcification and heavy calcification, the more right side. So this means not so good guide wire bias. And then checking the IBUS. Inside the left main, the guide wire was far from the calcification, and the bifurcation core point, the guide wire contact to the calcification, but the heavy calcification areas, maybe the 4 or 5 o'clock segment. So the more distal part, circumflex ostium, and the more distal part, the guide wire is far from the calcium side, and this means the opposite side. Then we decided that this segment had not so good indication of the atherectomy device, so we used the cutting barrel and put a stent. In summary, we introduced the 3D virtual guide wire bias simulator in this year. The 3D guide wire bias simulator provides us not only the calcium morphology, but also a contact point of the guide wire to vessel. Although this prototype simulation software is still developing. However, this concept may be helpful to decide the PCI strategy before the procedures. Thank you for your attention.
Yeah, thank you so much. That's very interesting because surely we appreciate calcium from overall CT, but intravascular detection is extremely useful for planning. I have still some concern when we translate this message to rotational atherectomy, because we know from dentists that the burr is tropic towards calcium, and the high speed of the burr selective is attractive and delayed calcium. So I'm a little bit concerned about the message we give through this undoubtedly useful information about an eventual misleading message coming from the burr. I'm sorry, but we already had a few moments. I should, if you agree, give some word to our discussants. Do you have any comment? Yeah, short comment.
Maybe very short question.
Mila, thank you so much.
No, it's okay. Short question. Very useful tools that we saw from the previous presentation and this one as well. As Alida said also already, that we are not sure how it's going to be utilized in everyday practice. This one and maybe the previous presentation with the FFRCT, it's very useful, and maybe it can provide us fast track to surgery. But how it's going to help us in before deciding to PCI, it's maybe doubtful. In my hospital, we have 4 radiologists. They perform CT scan. They're very skilled, and I can rely on their CT scan and the measurements. However, every time we use imaging when we have some doubts. But these 2 presentations are very insightful, and we're looking forward maybe to other new data.
Thank you. Any comments from the audience? I would.
Okay, if not, thank you so much,
Thank you.
Dr. Okutsu. And we will continue the next topic, the effect of side branch dilatation, bifurcation lesion, a sub-analysis from the ABC registry, and Matteo Perfetti. Please welcome.
And he will do in the same also the second presentation, because he's a presenter of the first and second talk, so we will do 2 in a row.
Okay.
Yeah.
Thank you. Good morning, and thank you for the opportunity to be here. I'm going to talk about the result of our sub-analysis of this ABC registry that we've done in order to answer an old but still contemporary question. And that is side branch predilatation a good deal when facing a bifurcation lesion? And what is the role of the side branch disease in this context? Okay, first of all, let's have a see of what is the actual indication about from the ABC consensus paper. So when we have a complex lesion, if it does not meet the definition criteria for true complex bifurcation lesion, we should refrain from side branch preparation and limit the preparation to the main vessel only. Whereas when the complex criteria are met, we should prepare both side and main branch. So we are balancing between the risk of side branch loss with a conservative approach versus side branch the risk of side branch dissection in a more aggressive approach. What we did is to analyze this cohort of more than 5,000 patients from 7 major coronary intervention centers that are from the European Bifurcation Club. And I focused my attention to the presence or not of side branch disease according to Medina definition, so very practical standpoint, and the side branch predilatation present or not. And I defined as a primary endpoint the side branch failure that I described as side branch occlusion, bailout stenting, and any dissection. Then I also consider a secondary endpoint as the individual occurrence of one of them. These are the map with the center from which the data are from. So basically all over Europe, more Japan and South America and Brazil. And the aim of the study was very simple, and was to understand what is the impact of the side branch disease and the side branch predilatation from an intraprocedural standpoint. So when analyzing the whole population, irrespective of the strategy, we see that just the presence of the side branch disease, according to Medina definition, is itself a strong predictor of side branch failure for each of the single outcome, and of course of the primary endpoint, that is the composite outcome. Whereas the role of the predilatation of an unselected population, so a systematic predilatation, is not significant as a predictor of endpoint, neither for primary, neither for secondary endpoint. So we asked if something more was possible to obtain by analyzing, by torturing data, and to understand if some suggestion could come from the differential presence or not of side branch disease. So, sorry. So when analyzing the effect of the predilatation only in patients with side branch disease, we see that is actually a protective factor. So side branch predilatation in patients with side branch disease can reduce significantly the primary endpoint, mainly driven by the side branch occlusion reduction, and also with a trend for bailout stenting, but still not significant. Whereas, of course, when we analyze the population without side branch disease, we can see an opposite effect, and that means that all the primary and 2 on 3 of the secondary endpoint are strongly enhanced when a predilatation is performed over a population without side branch disease. As you can see, there is a bailout stenting as a secondary endpoint, a component of the primary endpoint. So we tried also to restrict the analysis only to patients that were treated with a provisional stenting only in order to analyze this outcome, and we saw that actually there is not a great difference between the data. Provisional stenting was accounted about for 90% of the overall population, and we see that the side branch disease is still a strong predictor of outcome, and the side branch predilatation is present only a difference for any dissection. So for the patient with provisional stenting, the predilatation to the overall population is a predictor of dissection, and but not for the composite endpoint, for the primary endpoint. But still in this population, if we analyze the differential effect of predilatation in patients with and without side branch disease, we can see that the data are the same of the overall population, because predilatation is still a protective still against side branch occlusion and the side branch the primary endpoint. Whereas in patients with no side branch disease is substantially harmful for all endpoints. Study limitations are important to be underscored, of course. It is a retrospective analysis. It is an operator discretion-based data, so with the Medina definition, which are inserted input from the operator. This is an angiographic assessment with no independent core lab, and we are analyzing just intraprocedural standpoint, not a clinical follow-up. This is because the interest of the study it was to be an easy to do choice in intraprocedural context. So the study what we concluded with the study is that the presence of disease is a strong predictor of side branch failure. It is not surprising, but the role of the predilatation is opposite in patients with side branch disease, and that the predilatation reduces side branch complication, whereas it is clearly harmful in patients without side branch disease. So the predilatation is should not be recommended as an unselected basis because of the increase of risk of side branch dissection, also in the provisional strategy. What we try to do is to propose, to discuss a possible approach to implement this data and the utility of side branch predilatation in a real world, because our data are from real world. And we propose a stepwise approach that is what I'm actually using in my cath lab. And it starts from 2 concepts. The first one is not new, is a main branch aggressive predilatation. And this is the function to help to foresee the behavior of the plaque toward the side branch ostium. So to emulate the effect of the stent before implanting it. And then, on the basis of the result that we can obtain from this, we can use a side branch optional predilatation according to the result. So the algorithm that we propose and that may be interesting to study, and we have no still data about it, is to use a so-called main branch aggressive predilatation and then observe the side branch stenosis, the residual stenosis. And if stenosis and TIMI flow are good, we can proceed with the provisional stenting according to standard protocol. Otherwise, we can proceed with side branch optional predilatation that should be done gently with a semi-compliant balloon with a size to balloon vessel less than 1. And after the predilatation, we can still continue to provisional stenting if the result is good, or in case of an adverse event, we can still switch to a two-stent upfront strategy first. If the result is not still good, we can continue with a more aggressive side branch predilatation, for example, using kissing balloon inflation or a non-compliant balloon near to 1-to-1 ratio, and once again do the same evaluation that can let us to proceed toward a provisional stenting, or with a shift to a two-stent upfront technique with a side branch first, or if the result is still unsatisfactory, we can still choose the provisional stenting by using, for example, some technique to protect the side branch, just like the gyrate balloon. This is just images from my cases to show how our protocol works. This is an heavily calcified mid-lug lesion that has been rotablated with a 1.5 burr. And after the rotablating, I performed the so-called main branch aggressive predilatation, and we can see on the right the flow is severely hampered in the diagonal branch. So I performed then a two-step predilatation of the side branch with a good partial result. And then I proceeded with a standard provisional stenting with gently implantation of ADS, pot and rewiring, post-dilatation, kissing balloon, a new pot with a good final result. So what is the point? This is an approach that is very simple, easy to do, does not need new other technique, other costly technique, and it can help us to proceed with provisional strategy and to postpone the choice of the stent implanting technique, because angioplastic is not only the stent implanting technique. So we can proceed with a correct preparation of the plaque and then to choose the stent implantation technique. Thank you.
Just go. You can move now to your second presentation, then we discuss.
It's the overall, because I show the data about the effect of the predilatation and the effect of the predilatation according to the presence or not of the side branch disease.
So you put together the two presentations.
Yeah.
And by the way, you did a great job because you did it very quickly, and now we have we have 11 minutes for discussion, which is very, very good.
Yeah. My first question to you will be, could you explain again for everybody what do you understand under aggressive predilatation?
Yeah, of course. For an aggressive predilatation is essentially, ideally, a 1-to-1 balloon to vessel size ratio with a non-compliant balloon at high pressure. This is an example.
What do you mean high pressure? High pressure is for me 20 plus.
Yes, 20 atmosphere. This is what I've done on the left is a non-compliant balloon 3020. And ideally we have to choose the same size of the stent that we plan to implant. So if we plan to implant a 3O stent, we will use a 3O non-compliant balloon at a very high pressure, so 20 or more, in order to emulate the effect of the stent. This is the concept.
I think this is very interesting. So it means we just predilate and then think how we treat the patients with single or double stenting, right?
Yes.
Not
right.
a priori.
Yeah, the idea is to postpone the choice of stent implantation technique after the predilatation and maybe side branch predilatation. So they limit the use of side branch predilatation to the case where it's necessary, because we have seen that side branch predilatation may be useful when disease is present or harmful otherwise. So to limit the use of side branch predilatation, to optimize the preparation of the plaque of the wall bifurcation, and then to choice for the best stent implantation technique. This could improve also the planning for stent implantation, because we can choose a side branch first, for example, if we see that we need a two-stent technique.
So finally, if we follow your strategy, what do you personally believe? Would we have in the future less double stenting procedures or more?
I think less double stent procedure, because the goal is to increase, to limit the use of harmful maneuver, so for predilatation and to limit the number of stents implanted. So maybe also the drug-eluting balloon can find a role in this case.
But how did you define then? Because this is a retrospective analysis without a core lab. So we are trusting on whatever the people inserted in an Excel form and sheet.
Yeah,
so what was the definition of, because what is side branch disease?
Yeah, what I used is exactly an operator-based definition, because the operator is the person that performed the angioplasty. So what the operation thought that about that side branch. If the operator considered the side branch disease present, he could have the choice to perform a technique like this.
So it's just 1 in 0 if it's diseased. You didn't give a definition of disease of the side branch.
No, I have not other definition more.
So it's just they had to fill in disease 1.
Yes.
It's 0. Which is an heterogeneity of disease, because you can have focal stenosis, you can have a long lesion, you can have whatever.
Exactly.
So these are extrapolation, most probably, and
it's maybe a very rude approach to define a side branch disease, and actually it is. But at the end, dichotomic definition is our work, because we have to decide.
No, but the side branch is not dichotomic. We have learned that is the length of the disease, for example. So if you don't insert the variable length of the disease, this is not contemporary definition.
Okay, so actually, with a length more than 10 millimeters, actual indication of the paper, of the consensus paper, is maybe to prefer a two-stent approach.
It's before the consensus.
Yeah.
But okay, but this is hypothesis generating. We can work on that. There is any question?
Manuel.
Yeah, congratulations for your result. I have two questions. First, you mentioned side branch dissection after predilation. You have data about what type of dissection? Because you have A, B, C, D. In our randomized trial, most of the dissection were type A, so not important, but
no. We unfortunately we have not this kind of data in the database, so we can't get more detailed analysis about this. But we have, on the contrary, some data about the incidence of the dissection-driven bailout stenting. And we can see that about one half of bailout stenting, less than 40% of bailout stenting are driven by a dissection. But if we consider the dissection alone, we just have this dichotomic data without further definition about A, C, B, C, or flow limiting.
And the second question is about in the philosophy of provisional stenting, how many patients were treated with Cyberance predilation and one stent across the bifurcation and nothing else? So it's super simplified technique of the provisional stenting.
Sorry, I didn't catch the. Can you repeat, please?
Yes. How many patients were treated with Cyberance predilation and one stent across the bifurcation, them, and nothing else?
Okay, these data are available. The patient treated with side branch predilatation and provisional stenting with one only stent is present here. So about 1,000 patients were treated with the predilatation in the presence of side branch disease, and 1,014 with a predilatation with no side branch disease. So about one half of the patient was treated with predilatation in the population of provisional stenting, well, about one half. And the side if we consider the provisional stenting, the majority ended the procedure with a one only stent because bailout stenting was present in about 4 to 6%. So
okay. Okay, there's one more question, please.
So based on this data and the case you presented, the diagonal already had disease, so why didn't you predilate that first? And secondly, the second question is, in side branches, particularly in calcified vessels, have you had any experience using scoring, cutting balloon in the ostium of the diagonal, for example? So the two parts to my question.
Okay. You are talking about the case I presented?
Yes.
No. So the case I presented, I treated first of all with a rotablator in the main branch. Then the predilatation was made first with a semi-compliant balloon 2O with gentle pressure with no success. Then with a non-compliant balloon at less than 1:1 ratio, but it was a 2.5 balloon to a 2.7 vessel at 14 atmosphere. And then was efficacy. I didn't use a cutting balloon, any cutting balloon or other technique.
Okay, one more.
Yeah, very interesting data. So I find it really interesting and fascinating that such a high proportion of patients with no side branch disease underwent pre-dilatation of the side branch, more than half of the patients. And it makes me wonder at what point of the procedure in your database was the pre-dilatation actually performed? I assume it had to be after the pre-dilatation or perhaps aggressive pre-dilatation of the main vessel, in which case those side branches that were subsequently pre-dilated were already found to be problematic. So they're already at higher risk, if you understand what I'm saying. Maybe not.
Maybe not.
But this is the retrospective.
So who would, yeah, it's retrospective, I appreciate that. So I mean, how many in this room would pre-dilate a side branch with no disease?
The proportion was not too high.
It's high proportion.
Yeah. Donc side branch predilatation was performed in the overall population. We consider in 400 patients, 10% of patients.
That's more than 10%, right?
440 patients were predilated. No, maybe I inverted some data.
But there were other numbers in the other slides, so I'm a little confused about the numbers.
Okay,
yes,
whatever.
Yeah. Anyways, the point being
the point is why they predilated the side branch in the absence of disease. We don't have this information from the file. I can just imagine the use of kissy balloon predilatation or a sort of protection, but we have not this data. The proportion of this patient with predilatation, no side branch disease, was actually about 10% of the overall, and we don't know why. We don't know the indication of a predilatation of this kind.
I think most of us would pre-dilate the main vessel
we don't have
first.
the information, so we cannot answer. I think we don't have the information. Unfortunately, this was a big effort from investigators that filled in this big Excel sheet with limited data. The last question, and then we have to close.
Did you find the need for a kissing balloon inflation to optimize the side branch result when you dilate the side branch and there's a dissection?
The side branch balloon for the kissing for the side branch is of course an option for side branch predilatation. Is maybe a more aggressive approach to predilate, but maybe sometimes more effective. Yes, is absolutely.
For a small dissection, your kissing would possibly be an answer.
If I have a dissection, if you have a dissection to predilate after a dissection, if you have a significant dissection, maybe we consider to shift to a two-stent technique. So predilatation, if in order to prepare for the stent implantation, not just for leave the dissection
okay,
on
so
site.
thanks. I mean, for all this data analysis, it's a big database and the effort done. Clearly, it's just hypothesis generating.
Yes,
so thanks
of course.
for your presentation.
Of course.
So we will move to the next.
Thank you so much.
The next one.
The next one is going to be online, I think. It is going to be Shengxian 2. I don't know if it's present online. It's connected. Okay. Hi, hello. Welcome to EBC.
Thank you. Thank you for giving me the opportunity.
Please proceed to your presentation, which is fusion of OCT and coronary angiography for the assessment of computational physiology in side branches after main vessel stenting. So please.
Dear Chairman, thank you for the invitation to present at EBC 2023 meeting. The title of my presentation is Fusion of OCT and Coronary Angiography for the assessment of computational physiology in side branch after main vessel stenting. This is my disclosure. Early study from Korea demonstrated lower gel side branch FFR was associated with long-term clinical outcome. However, to measure FFR in gel side branch is technically difficult, and there was also safety concern. We proposed the angiographic-based QFR to calculate FFR from angiographic image. The first generation was based on two projections, and second generation we call it mu QFR or mu-FR. The QFR can be computed with a single angiographic projection, and with this step-down reference diameter, which is expected to improve the accuracy of the computation. So how does the single-view QFR compare to the 3D QFR? So this recent study, we used the reckoning projection to calculate QFR from one of the projections, we call it mu QFR 1 and mu QFR 2, and we also perform the most certificate 3D reconstruction using the main vessel with all the side branch and calculate QFR, because 3D view QFR. So using FFR as the reference standard, as you can see that single view QFR either calculate from first projection or second projection has comparable diagnostic accuracy compared with the 3D mu QFR. There's almost no difference there. We further confirm the accuracy of single view QFR in the recent post-hoc analysis using the flavor study population. So in paired blind analysis with mu QFR and FFR, we found that the accuracy of single view QFR was 90% in 877 vessels in the flavor study population. The technology has been used to perform the physiology assessment after left main bifurcation lesion stenting. As you can see that we found that after PCI there was still significant patient, 13.2% patient have a residual ischemia either in LAD or in circumflex. And the residual ischemia was significantly associated with worse 3 years clinical outcome, as demonstrated in the figure here. Another study recently published by Professor Chen's group also demonstrated after left main aerated crossover stenting, lower post-PCR QFR was associated with a 5 years target lesion failure, as demonstrated in the figure here. Nevertheless, angiographic exposure of side branch occlusion can be challenging after main vessel stenting. So the main vessel OCT allows evaluation of side branch occlusion with higher accuracy. Therefore, combined angiogram and main vessel OCT derive side branch occlusion information is useful for side branch QFR computation. So it proposes a methodology to calculate FFR from the combination of OCT and angiogram from co-registered data. So we automatically co-register OCT with angiogram, and using the combination of OCT and angiogram, we can calculate the new QFR. We call it OCT modulate mu QFR or OCT mu FR. As you can see the figure here, so this segment has OCT pullback, we are using OCT, and those segments without OCT pullback, we are using the angiogram. So we combine them to calculate the QFR and obtain the OCT mu QFR. So in the recent validation study, we demonstrated indeed OCT modulate mu FR at the highest diagnostic accuracy was slightly better than the angiogram-based mu QFR, and both were substantially better than the OCT-derived air stenosis or QCA-derived diameter stenosis. So how about the side branch physiology co-assessment? After the correlation with OCT and the angiogram, we can further angulate and bending the OCT image so then it can be fused with the angiogram. As you can see from the figure here, you can appreciate the side branch occlusion in both modalities. You can see the angiogram side branch is exactly overlapping with the OCT side branch. In this way, you can visualize the accuracy of the fusion between the two imaging modalities. And after that, you are using the combination with the OCT and angiogram to create a hybrid model. And this model you can further use for the computation. This slider further explains the step for the OCT mu QFR for side branch assessment. So after you bend the OCT image, for the side branch, we actually reconstructed this small cut plane perpendicular side branch center line. And based on the reconstructed image, we can further delineate the lumen contour from this cut plane and use them to fuse with the angiogram. So then you can have the side branch occlusion information from the OCT in combination with the distal side branch information from angiogram. And then you can further bend them and calculate the FR from the combined model. So this is still working in progress. Ladies and gentlemen, in conclusion, angiographic physiology provides significant prognostic value in patients undergoing bifurcation PCI. The clinical add value of fusion of OCT with angiogram for side branch physiological assessment need further validation. Thank you. Thank you for your attention.
Thank you so much to you. This goes in a nice direction together with the previous talks about localization of the plaque and integration with multiple images going in the direction of spatial assessment and physiology together. I would ask if you, from our panel of experts, would have any comments or questions.
I have a question.
Sorry.
I have a
Yeah,
question to Dr. Tu. Do you have any gray zone? So which value will be a borderline? Then you say, okay, we have to go with invasive FFR, whatever.
Very good questions. Indeed, I think that as the angio-based or the imaging-based FFR, there are some numerical difference with respect to the wear-based FFR. If you want to address want to define the gray zone, I think the is close to the 0.80. So normally if we have far away from the 0.80, then it's clear. In our experience that we need to look at the standard deviation of the numerical difference. So typically the angio-based, the standard deviation is about 0.6 or 0.7 in some system. Then you can try to escape or try to see that it will make some clinical discordance in the diagnosis. But that's the same for the wear-based FFR. So if you measure the wear-based FFR again 2 times, then you also have some deviation. And the deviation, the numerical difference is slightly smaller. So that I cannot make a conclusion that within this range, then you can make a clear clinical decision. There was some data from, I think, from Newshome in the Favor 2 Europe and Japan study, and they analyzed them. If I remember correctly, I think it's below 0.76, then the decision will not be changed. But if it's above 0.76 to 83 or 84, then the decision can be changed within this. You can define this one as the gray zone for the angio-based FFR.
Okay, thank you.
Salmen, it's Christos. Very, very distinct work. And I'm start getting more and more, let's say, flexible in using these technologies, considering the fact that in the gray zone, whatever you are using, 0.75, 0.85, there's no clear prognostic benefit from the FFR. So even if you are just have 0.83 from the FFR and 0.78 from the QFR, it's not make much difference in terms of outcomes. The question that I have, you moving to OCT physiology derived in the bifurcation lesions by taking information from the OCT, by taking the OCT to the side branch, correct? Or you doing the OCT only in the main vessel and you're trying to get the QFR from in the side branch? You take the OCT to the side branch, correct?
Yes, that's correct. So we take the OCT oxtile or side branch oxtile from the main vessel OCT pullback.
I see. So in that occasion, how you are confident that, let's say, 3-4 millimeters downside away from the ostium of the side branch, you are capturing the information by having the OCT in the main vessel? This is only for very ostial lesions, isn't it? You cannot extrapolate that to longer lesions in the side branch.
If it's long lesion with the angiogram, and normally the angiogram, the difficulty is just at the side branch ostium. I think the beauty of combination with the OCT with angiogram is that you can use the OCT main vessel with the side branch oxtile from the OCT main vessel in combination with the angio side branch. Because if you 3 millimeter distal to the side branch, to the oxtile, then the angiogram can be used for the combination.
And how you account the difference, the diameter? Because the diameter in angiography is different from the angiogram in the OCT diameter.
Very good question. So there's a technical, small technical detail. Indeed, the imaging modality or both two imaging modality has already difference in the sizing, as you point out. So in our algorithm, we try to estimate the systematic difference and try to correct them.
Okay, thank you.
Okay, thank you so much. Thank you to you, Dr. Tu. Many greetings. Thank you for discussion. And we go ahead with presentation of Manuel Pan. Manuel, welcome. So your topic will be gel pressure wire technique for coronary bifurcation lesions, structural damage and clinical outcomes. Welcome.
Good morning. My conflict of interest. In this slide, you can see our publication about the gelled wire technique. The story started almost 20 years ago with a brilliant idea from Alfonso Medina that proposed to gel the pressure wire in 2001. This was a presentation in the European meeting, but nobody cared about this finding, even us. So we forgot this finding and continuing several years later studying the damage produced by the stent in the gelled wire. In 2015, in Revista Española of Cardiología, we published the first study that defined the degree of damage of the wire, and also provide information about the sample size to design a randomized trial comparing polymeric and non-polymeric wire when these wires are used in the yielded position. This study was published in JACC in 2016, but the most important thing was that recently the brilliant idea from Alfonso Medina was resuscitated, and we used the pressure wire in a yielding position in order to monitorize all the process of the treatment of bifurcation lesion with provisional stenting. At this time, we use a new technology, new wire, new index, and publish a pilot study in JACC intervention. And now we continue increasing the number of included patients and compare this data with an historical study with the study published previously in JACC, and is the presentation of today. The aims of this comparison was to compare the structural damage of pressure and non-polymer coated wire after yielded wire technique, and to evaluate the mid-term clinical outcomes of patients with bifurcation lesion treated by IFR guided versus angiographic guided. We use for the study the Volcano Berrata. It's not the last generation, but in this case you can see that the wire have a sensor, a pressure sensor, 30 millimeters from the tip of the wire. The last part of the wire is a hydrophilic, no polymer coated. The methods are summarized here. Single center, non-randomized, prospective study enrolling selected patients undergoing PCI of bifurcation lesion whose provisional stenting was the use strategy. As a control group, we select the cohort of patients randomized to non-polymeric coated group from the previous mentioned study, and for the comparison, we applied a complicated statistical method, a propensity score, the inverse probability of treatment weighting. I am not an expert in statistics, but seems to be the correct method for adjust baseline difference in variable. After the procedure, we analyzed the microscopic damage, and we registered the clinical outcome. The procedure is summarized here. It's a normal provisional stenting, but at the beginning we place the pressure wire at the side branch to obtain a baseline IFR. The main vessel stenting was implanted with a regular technique with POT, and immediately we perform a side branch evaluation of the physiology using the IFR. If the IFR was negative, we perform a pullback of the wire in order to evaluate the possibility of drift. If no drift and the IFR was negative, the procedure finished. And if no drift and the IFR is positive, we continue with side branch post-dilation. So in this series of patients, we have not implanted a second stent because we don't need it. The baseline data is summarized here, a lot of data, but the most important is baseline difference between both groups that have to be adjusted by the propensity score method. We observe differences in clinical presentation, in Medina classification, main vessel and side branch characteristic. Here you can see the result of the statistic method, and the main variable for microscopic damage and for clinical outcome were weighted, And in green, you can see the weighted represented the standardized mean difference that all after the adjusted, after weighted, are within the 10%. So seems to be that this a good adjust, and we can proceed to the comparison despite the baseline difference between variables. Here you can see what we did. So I can see the numbers, but the most important is the complication of drift. In 7 patients after the pullback, we observed the calibration of the wire and needing a new recalibration and a new side branch widening. So if drift did not occur and IFR was negative, we finished the procedure. On the contrary, if the IFR was positive, we have most of the patient was treated with this super simple strategy. But if IFR was positive, we need to rewire and perform kissing and again perform a new IFR measurement. In this series, we didn't a second stent. And here, in this slide, are summarized the results in terms of microscopic damage. We observe a difference in terms of damage. The pressure wire was more frequently damaged, but only in the distal part. The sensor wire was not damaged, and the wire could be used for rewiring in case of drift. The clinical outcome are summarized here. The first finding is that a reduction of side branch intervention. So the procedure was simplified with the use of physiology, with the use of the yellow wire, needing less intervention the side branch, in this branch. And on the right, the incidence of MACE 2 years without any significant difference. So we can summarize the result that less need for intervention at side branch and no difference at MACE at 2 years. So our conclusion are summarized here. The use of the yellow pressure wire technique could simplify the strategy of provisional stenting, although a small proportion of drift was still observed. We hope that the new modification of the wire simplify the technique. Volcano pressure wire was less resistant to yielding than conventional non-polymer coated wire. However, severe damage was anecdotal and distal to the pressure sensor. The use of the gel pressure wire technique resulted in fewer side branch intervention. And finally, MACE rates were similar between the IFR guided and angiographic guided group after 2 years follow-up. Thank you for your attention.
Yeah, very interesting data. So do you believe you simplify the procedure now?
No, in a big group of patients, yes. Because if you have not drift, if you have a negative IFR, you finish the procedure as a non-bifurcation lesion. But we are waiting for an improvement of the technology in the wire. Now the OmniWire is a next generation that is recently acquired in our hospital, and we are studying the new one in order to. The key point is not to have the drift, because if you have drift, you have to start the procedure at the beginning.
Yeah, there was one more question from the audience.
Maybe I missed it, but did you do POT, and was POT performed before you did the FFR, or
yes.
how was that?
Yes, POT was recommended performed in 70% of the patient, but was a strong recommendation. We perform the IFR measurement after main vessel stent implantation plus POT.
What was, sorry, what was the distribution regarding the bifurcation lesions, like LAD, diagonal, left main, RCA? How many of, I didn't see.
You can see this is a very busy slide.
In the term of side branch, whether it is diagonal or maybe...
You have over here, I can see the data.
The answer is on the slide.
In the middle, no?
Yeah. Okay.
Okay.
Okay. So now in the middle you have more or less the low proportion of left main, and most of the patients had LAD bifurcation lesion.
Yes,
Yeah.
I mean,
Okay,
it's normally. I mean, I would like, before the other question, first of all, to congrats for all the work that you did in the past and you're still doing. And I mean, when we have a pillar as you are in the field, we have to acknowledge. So that's a thank for the community to you for all the work. And also having reminded us, Professor Medina, I mean, so that's important. Sometimes to stop and acknowledge what is the past, I think is important. Yeah. So the next question.
Mania, congratulations for the excellent presentation and interpreting the data. Just one question that I wanted to ask. There is data that the optical fiber pressure wires have a tendency to have an extreme low drift at the end of the procedure, even if you have to cross stents once again or multiple times. Do you intend to have maybe Absence or Comet for next future studies for at least trying to have less metal in the side branches? So that would be just one question. It would be very interesting to see and be part of that.
Now we are evaluating the next generation with the same protocol. I don't know. The company say that the possibility of drift in multi-vessel disease and with several use along the procedure is lower, but it has not been tested in bifurcation lesion with in a yielded position.
Okay, thank you so much. And always going in the direction of a memory of Professor Medina, we invite Stanislav Bartus to make his presentation. Thank you so much,
Thank you.
Manuel.
Thank you.
And I have a small task because Goran reminds to me and to all of us that at the end of the presentation, before going to lunch, we have to stay here because here will be done the picture of this year EBC meeting. So, Stanislav, please let us go through this revisitation of the Medina classification with physiology. Thank you so much.
Thank you very much. My presentation was intended to be a just case presentation as an illustration to the previous lecture. So a few words how we did our patient. The patient was 82 years old gentleman who presented to regional hospital due to pulmonary edema and non-STEMI with ejection fraction 12 measured in echo. That was the first presentation of coronary heart disease in this patient. Patient was never treated for any cardiovascular disease before, just penis cancer treated 10 years ago successfully. And I move forward. Oh, yes. And they, in the regional hospital, performed coronary angio. Right coronary was occluded without any possibility to reopen it, which was later confirmed by experienced CTO operator. And the bifurcation of left main and LAD was involved, as well as the ostial left main. So patient was sent to our institution to check viability of the left ventricle, and despite of some segment of the basal, middle, and anterior part of the interventricular septum, everything was viable. So patient was the sent to the heart team with Medina 111 in left main and diagonal LAD diagonal 100 probably. And the heart team qualification was to PCI with left ventricular assist device. So my strategy was to avoid two-stent technique if possible, because patient has very low ejection fraction, what means very high thrombotic risk in this patient, and keep, of course, everything open if possible. So first we started with checking what is really critical, and we found that unfortunately diagonal branch and circumflex artery were critical. So we started with orbital atherectomy because I believed that removing the plaque will help me to decrease the volume of the plaque at the ostium of the diagonal branch and circumflex artery. So probably I will not have to stent these two arteries. After that we performed the OCT, which revealed widely open circ and widely open diagonal branch. However, in some places this calcium was not cracked properly, which you can see here with non-properly opened balloon during the predilatation. So we had to escalate to intravascular lithotripsy, and now you can see very nicely cracked everything in this LAD. So we sized the LAD and sized the left main in the OCT and put the Science Sierra stent to LAD as well in the left main, post-dilatate with 5.0 balloon, which was even oversized, kissing, and then again 5.0 post-dilatation. This is the worst angio after this stenting. You can see some disease in the circumflex proximal. So we put again the wire that was on the table, and you can see unfortunately 0.73. So we had to stent this circumflex ostium and proximal part of it with the same wire. So again kissing, again repot, and OCT showed that we covered the ostium. We also properly opened this stent. Also in LAD, it was nicely opened, the stent, and OCT showed that the ostium of the circumflex was widely open. So we checked the LAD, and we checked also the circumflex, which showed that DPR was almost 1. However, I was not able to rewire the diagonal branch, and at this point I decided not to close it, and that was the final result of this procedure. Because there is completely no correlation between coronary angiography and the functional assessment of bifurcation lesions, and there is strong correlation between FFR and especially in the prognosis, correlation of the prognosis with FFR, especially in the circumflex artery, jailed circumflex artery. So it is really important to use the physiological assessment of the bifurcation. However, this case was to show the balance between the indication to reopen or to open small arteries and the further risk of the complications like the stent thrombosis. Thank you for your attention.
Yeah, thank you. Very well done. case, how was improvement of LV function? Did you observe some improvement after revascularization?
Not yet. Patient was not released from our hospital yet. It was 5 days, no, maybe more a case, 10 days case.
So, thank you so much for this extremely updated case. There is some question also from Mila.
Okay, thank you for a great presentation and great case. I was wondering, maybe this would be the straightforward case for the off-pump Limalad, for example. It's 12% ejection fraction, and as you already performed the coronary physiology, maybe it would be like the nice case for very skilled surgeon like Limalad.
But the patient is 82.
82, okay.
How many surgeons operate 82-year-old? In my hospital, no way. So just by hand, how many in your surgeon are operating an 82? Okay.
Yes, in our hospital, when you ask...
5% of the total, okay.
But, yeah, I agree, I didn't...
With the 22% of LVF and 82, I mean, I think it's very... I mean, I would love sometimes, I mean, they refuse even... much better patient, even 50-year-old with 22%.
Sometimes they operate patients even older, but not with so low ejection fraction.
Anyway, I didn't notice the age of the patient. However, you performed 3 DPR, yes?
Yes.
LAD, circumflex, and the diagonal. But the diagonal is going to be influenced also by the proximal LAD and the left main. So maybe the DPR from the diagonal is not so useful at the beginning. Yeah. Do you agree?
Yes, I agree. And there is no slide because the intention was to be short. However, in OCT, there was widely open the ostium of diagonal branch. But unfortunately, after stenting, I was not able to rewire it again. So,
no, of course, I agree with the technique, everything, but just the DPR from the diagonal maybe was, in my opinion, humble, unnecessary. That's just was my point. I
mean, anything has to be adapted entirely to the patient. This is a patient coming with a pulmonary edema, non-ST elevation MI. I mean, and that's the point. Do you have a threshold of age, for example, for Impella? Because again, 82, honestly, even if we are the larger user in Italy, one of the largest in Europe, 82 would be a cutoff for us. I mean, we don't implant Impella more than 75 usually. So that's interesting. Do you have a cutoff of age, or indeed it's the clinical indication of the patient? You evaluated well the vascular access?
Well, if the survival is longer than 1 year, we believe that it is worth to revascularize. The same situation is with TAVI, where we use, because I understand your point about the vascular complications. However, in TAVI, even we sometimes use bigger bore puncture.
But that's an elective procedure. This is a urgent procedure. So elective means you did a CT scan, you evaluate the access, and not all the 82 are treated, are the ones that are feasible for treatment. So did you check for the vascular? Did you do a CT scan on this patient?
We do. I was not presenting it here, but we, for all the patients, we do CT scan. If there is no access in the iliac arteries, we go through axillary.
A comparison with TAVI is extremely correct, I think, because there we spend much more.
No, but that's an elective procedure. This is an acute, so sometimes you don't have time to do all this.
Yeah, I will end this session with a joke, but it's a new I would say, recommendation from the EBC. When it's simple, you do provisional. When it's complex, you do decay crush. When it's a catastrophe, very complex, you do provisional. Thank you.
I'd like all still.
I'd probably like to close with his statement, but I have that extrapolating on Alaide's comments, extraordinary case. I'm not sure about the appropriation of funds, at least in our setting. This would be way, way, way too costly. I mean, I don't know if this is something that you can afford. We certainly cannot.
The major issue was the impel, I think. But without an impel, this procedure could not be done.
No,
Do you agree?
definitely.
Also, Aida, could you agree?
I mean, we cannot say it could be done. I mean, I'm a believer, clearly, but we don't have the data that says it cannot be done. So by our personal experience, we will feel, let's say, much more comfortable to have an impel on board, but we cannot say we can be done or
but
not. Because we don't
randomized
have
study,
the
Protect 4 studies ongoing, so
we don't have.
We will have data in the future. Thank you so much.
Thank you.
Stanislav. Okay, stay here in the room.
Please stay.
Yeah.
Goran is taking charge. Okay, okay. So
we
move.
stay here, right?
Downstairs.
Thank you for inviting me to EBC 2023. I'm Dr. Doyong-gang from Asa Medical Center, Seoul, Korea. I will present the result.
Hello?
Dr. Ziad, do you? Your microphone is not on. Just.
Morning. Good afternoon. Hi, Greg. Good to see you. Okay, how are you?
So for the moment, I just have Zayad Ali.
is not connected, but we can start the video if in the time we connect him.
No, it's not connected.
Yeah, after you, so just 2 minutes.
Okay, welcome back everyone from lunch. Welcome to the session entitled Latest Evidence from Trials on Imaging. This incredible session is based on several late-breaking clinical trials that was presented at the European Society of Cardiology Congress towards the end of August in Amsterdam. So really, really looking forward to discussing these very, very important clinical trials and how they apply to our daily practice. So my name is Vijay Kunadian. I'm Professor of Interventional Cardiology from Newcastle, United Kingdom, and it's my absolute pleasure to be joined by my dear friends, Dr. Nicholas Amabile and Professor Francesco Barzotta. We also have a fantastic panel together with Dr. Alicia Asano, Dr. Biswas, I think Dr. Rani Matthew. If he's not here, then I think he's probably joining us online. We're also joined by Dr. Nam and Dr. Hikishi and Dr. Ergles. And it's also an absolute pleasure to have Dr. Ziad Ali, Professor Greg Stone, and Dr. Park also joining us on the line. Of course, they will be doing the presentation as well as joining the discussion. So without further delays, I'm going to hand over to Nicola to introduce the first clinical trial.
Thank
Nicola.
you, Vijay. So as you mentioned, the year has been very exciting because of all these clinical trials and especially focusing on the field of bifurcation. And so Professor Christensen will present us the data from the most awaited October trials. I think this is a recorded presentation.
Dear Chairman, dear EBC, thank you for having the chance to share the October trial results. These are my disclosures. So, OCT for procedural optimization has shown to get Better stent expansion result in reduced stent malposition and better scaffolding of the side branch osteum. October trial overview. Patient with stable or unstable angina or non-STEMI with a true bifurcation and a side branch reference at or above 2.5 millimeters. We aim for 1,200 patients randomized 1-to-1 with a primary composite endpoint of MACE at a median of 2 years. Target population, patients with true bifurcation lesions, left main and non-left main bifurcation lesions, enrollment of lesions with high complexity encouraged, and high-risk patient allowed, including surgical turndowns. Indication, stable angina, unstable angina, or non-STEMI. So the techniques could be used was one stent provisional with kissing balloon inflation, or two-stent technique with DK crush, culotte, T-stent, or TAP, published in American Heart Journal 2018. It was an investigator-initiated study with an open label design in 38 heart centers in Europe. We had on-site training in OCT guidance and feedback on OCT guidance in all cases. We randomized 1,201 patients, and we strongly disencouraged use of imaging in the angio-guiding arm, but 16% had IVUS guidance. We had very low loss to follow-up in the trial. The patients were well balanced according to age, gender, and indication for PCI, and a low proportion of diabetes. Bifurcation location, 1 of 5 in the left main, and the rest, the majority, in the LAD diagonal. We had longer stent length in the main vessel in the OCT arm and similar length in the side branch. More balloons, larger balloons were used in the OCT arm, and 2/3 had two-stent technique, reflecting the inclusion of complex lesions in this trial. There were more contrast use, procedure time, and fluoroscopy time in the OCT arm. The primary endpoint of MACE, 14.1% reached the endpoint after 2 years in the angio arm versus 10.1% in the OCT arm. Statistically significant reduction with OCT. And similarly, for the patient-oriented composite endpoint in favor of OCT guidance. The trial was not powered for the components of the composite endpoint, but they were all in favor of OCT guidance versus angio guidance. Subgroup analysis did not identify any significant interactions. So we conclude that OCT-guided PCI was associated with a lower incidence of the composite endpoint of 2-year MACE compared to angio guidance in complex bifurcation lesions. The procedure time, the fluoroscopy time, and the contrast volume were increased with OCT guidance. Implementing routine OCT guiding for PCI of complex bifurcation lesions may be justified, in particular as the effect was shown with a 16% ad hoc IVUS in the control arm, and despite the COVID-19 pandemic affecting the invasive follow-up. We contributed with the results in this updated meta-analysis of angio guidance versus imaging guidance of PCI. 22 randomized trials were included in the meta-analysis with nearly 16,000 patients and more than 2 years follow-up. And the primary endpoint in this analysis was target lesion failure. And we saw significant reduction by imaging-guided PCI, target lesion failure of 29%, cardiac death 45%, target vessel myocardial infarction 18%, ischemia-driven target lesion revasc 28%, stent thrombosis 47% reduction, and for the first time, reduction in all-cause mortality of 25%, and also reduction in any myocardial infarction. There were no statistical and meaningful difference between the use of OCT versus IVUS in this meta-analysis. Thank you for your attention.
So I think, Francesco, what we can do is now moving to Professor Holmes' presentation and then have a common discussion about the October results.
Thank you very much. Can I have my slides? Thank you very much. So, thank you very much for the kind invitation. These are my disclosures. So, October is an imaging trial, meaning that the subsequent data on bifurcation techniques are descriptive and hypothesis generating. We asked the physicians to enroll patients with a need for either one-stent strategy with kissing balloon inflation or a two-stent technique. So in the October trial, it was about 35% of the cases that ended up having a one-stent with kissing technique, and 65% roughly had a two-stent strategy. The reason why we focused on these techniques was that in our previous work, we have seen that two-stent strategies, there was certainly a room for optimization, but also in single-stent techniques with kissing, because we saw that with kissing balloon inflation, we got a good side branch result, but something happened in the main vessel that caused MACE events, even including death. So, when we look at the October results stratified for the treatment, we saw a 50% reduction in MACE with the one-stent techniques. So actually, with 6% MACE after 2 years with kissing balloon, with kissing 1% one-stent technique and kissing, which is very much in line with just regular stent technique results. With two-stent techniques, we only saw a 14% reduction in MACE and was non-significant. And we here in 2 weeks at the TCT will present results with some insights in why we did not see a major effect with two-stent techniques. In one-stent group, the physicians really did a fantastic job following the protocol for OCT guiding, whereas with two-stent technique, we saw more variation, and in particular, as our learning curve was disrupted by the COVID-19 pandemic. So the OCT protocol was based on 4 treatment goals: optimal lesion coverage, no stent malposition, optimal stent expansion, and no unattended stent deformation. The OCT protocol, is spelled out in the supplement to our methods paper that was published in the American Heart Journal, so you can download it there if you wish to read it. Here we had this stepwise approach with a checklist-based evaluation of the OCT scans throughout the procedures. The timing is very important because you can do OCT at any time point during procedure, and that's not feasible. So we recommended to do the first pullback after plaque preparation, but before stent implantation, to evaluate the plaque preparation, establish the landing zone, the stent length, and the stent sizing. And then after each rewiring, to evaluate the wire position, both crossing into the side branch, but also to follow the wire all the way out of the stent to check that there is no accidental abdominal rewiring. And then the final result, to check for lesion coverage, expansion, apposition, and stent deformation. So an example after plaque preparation to the left, no effect as seen after plaque preparation, so the physician decided to go on and perform more plaque preparation here using non-complying scoring balloon. We saw the core lab saw that after the first OCT pullback, there was a need to do additional plaque preparation in about 50% of cases, and the physicians actually performed more preparation in about 41% of cases. So the physicians were also asked to plan the stent to avoid residual stenosis in the edges, avoid major fibroatheroma and major dissections based on the available evidence at the time. And the reference size had to be established based on media-to-media measurements for all segments. But of course, if OCT was not performed, it had to be a angio-based evaluation based on the visual estimation. The reference diameter was also the limit of the largest balloon. The large balloon was larger with OCT guiding, whereas the incidence of perforations was similar in the two groups. So after rewiring, we checked for the wire precision. It was not that granular, so we just wanted to avoid the wire going in a very proximal position as it would cause a long metallic carina. And then we followed the wire all the way out of the stent to check if it was if the wire was abluminal, because of course a dilatation would cause unintended stent deformation. And then just another example of abluminal rewiring. And then the final result, we checked for lesion coverage to ensure that the edges was fine. We have a sub-study coming out on that, try to reproduce the Kang study with IVUS. And then expansion. We know that the angiographic ambiguity is very high in bifurcation assessment. So this is the ostium of the side branch of the diagonal in this case. And you can clearly see the stent is severely underexpanded, which was not evident from the optimal angiographic result. And we used the stent, the reference size that was established at the beginning of the procedure when we evaluate the expansion of the stent. Because if we use a lumen-based evaluation as the AptiView system does, then we can get a relative reference that is overestimated. In particular, if you have diffuse disease in the edges, using a lumen-based reference at this time of procedure can really cause problems. We showed in a publication this summer that is really a dramatic difference in the evaluation of stent expansion. So, and then we aim for no malposition, and yes, really, but it was not like we chased malposition. We just mandated one additional attempt for correction after the final pullback if there was still malposition. You can see there are no references, so it was based on the idea that malposition is more problematic in bifurcations, but also that that patient population would have a higher risk of stopping dual lateral plated therapy at an early time point. So, and then finally we look for unintended stent deformation. Two major causes were accidental cross by guiding catheter collision, but also due to accidental abluminal rewiring. It was clearly related to increased MACE, and if it was identified and corrected, the risk was reduced. So all this combined led to the 30% relative risk reduction. It was based on 3 hours of training before entering the study, and then feedback on the individual OCT-guided cases, at least in the 4 or 5 first cases, and then a bit more ad hoc. We're absolutely sure that we underestimate the true effect of OCT guiding due to the disruption by the pandemic. And is it needed to do a better job? For sure it is. We have just been downgraded to 2A for left main bifurcation PCI, so we need to do our very best to get up again in our quality, and we need to use OCT guiding for that. So in conclusion, OCT-guided bifurcation PCI was associated with improved clinical outcomes. 1 stent with kissing, clear effect of OCT guiding. 2 stent techniques, not so much, more variation in procedural quality. Unintended stent deformation due to guiding catheter collision or accidental abluminal rewiring contributed to MACE. If we corrected, well, we saw virtually no MACE events. Implementing OCT guiding for PCI of complex bifurcation lesions may be justified, in particular as the positive effect was shown, 1, despite 60% ad hoc IVUS in the angioarm, 2, despite suboptimal OCT guiding, and 3, despite COVID-19 pandemic affecting invasive follow-up. Thank you very much.
Yeah, thank you very much, Niels. So these are very interesting and exciting results, and I'm quite sure that the panel and the attendees will have some questions for your team.
Thank you for some great presentations. I think the finding that OCT improved outcomes over angio guidance only in 1 stent techniques, but not so much in 2 stent techniques, is really interesting because it goes against the common thinking that the more complex the procedure, the more complex the lesion, the more that we have to gain from imaging guidance. And then I think with the point you made about the fact that maybe it was due to suboptimal use of the OCT guidance is interesting, because we know from IVUS trials that it's not just using the OCT or the IVUS that makes a difference. You actually have to know what you're looking at and react appropriately to the data that you're given. So I wonder if you had any insights, or was there any interaction between whether the MLD max kind of targets were achieved and whether protocol was followed versus not, in terms of the improvement in outcomes seen?
Yes, so with one-stent techniques, as I explained in the beginning, there's clearly a relation between optimal procedures and then an optimal outcome. The two-stent techniques, we started to see some effects that, for example, in this room, we have 5 colleagues that joined the trial, very high level. They were on top of the learning curve when they entered the trial and did a fantastic procedure, textbook procedure throughout. But we also had a lot of physicians that joined the trial quite late, just before COVID, and maybe was somewhere on the learning curve when COVID hit. And then it was very difficult due to the cath lab environment. I think a lot of people in the room can appreciate that was a difficult time. And then, maintain the skills level with, longer time between, longer pause between the procedures. So we can see that the quality of those procedures were, with larger variation, and maybe even that procedures that should have been staged, simply not finalized because there was a pressure to do short procedures during that time. Maybe another stent should have been implanted to finalize it, and they were simply not staged that procedure, despite it was part of the protocol. If you do not finalize, if you need to do more, you can easily stage the procedure. But that was not done in a number of procedures.
Just one comment. You said the simpler procedure. However, one-stent procedures in kind of patients like that, I mean, a true bifurcation, so with extended lesions in the side branch, is not simple. This is, to me, important to be remarked, because the complexity of the lesion was present in all the patients that were enrolled in the trial. This is very important. And to apply one stent when you have extensive disease is really, something that can be probably done mainly if you have OCT guidance that check that you did it properly.
So Niels, many, many congratulations. It's a fantastic study, and it's not really easy to do, to bring a study to a completion, particularly in the context of the pandemic. So really well done to yourself and the whole team. My question is, we are going to discuss comparison of OCT and IVUS. So what do you think your results would have been if you had a third arm of, say, IVUS? Do you think the curves would have been different, or would they have been on top of each other? So that's my first question. And then you mentioned about the guidelines. So obviously the guidelines were written before all of these trials came about, and we have a recommendation of 2AA right now. So how... you were saying maybe upgraded, so clearly for other patient subgroups, this is, we have different results, so bifurcation, clear results from your study. So what do you think, in terms of the impact on guidelines and clinical practice based on your study?
Yeah, so 2 big questions, but first to the IVUS versus OCT, I believe that we have the IVUS trial very recently also at the ESC showing that there's almost similar outcomes with the 2 trials. They also focused on complex cases. It was kind of all comers, but there was a lot of complex cases in that trial. I still believe that OCT has the upper hand in bifurcation treatment, because when you have more stents implanted and when you want to check for wire positions, the higher resolution do add some ease of interpretation, in particular when we start to use 3D, and we can that can be more helpful also with the next generation systems that we will have. Faster pullbacks, more ease of use, and so on. So I think, again, with OCT, we'll have the upper hand in complex bifurcation stenting. But if you're really proficient IVUS user, you can absolutely also do a good job. It's much better than doing angio alone.
Yeah, Niels, thank you very much, and it's a great study. We are happy, I guess, at least 1/10 of patients are sent in this study, and as you know, we are for so many years together with Nordic program of bifurcations. But actually, regards to imaging, and it is, I guess, for me, it's a very, very important question. And it is not only a question we use or not to use imaging, for me, and I also tried yesterday to dive deep in study, but I didn't find this. But could you say in what is a percentage by based on imaging operator change mind, actually change and pre-treatment, post-treatment, or even use other technique? Because I guess it is most important point. We are not talking about that we need to use intravascular imaging.
So we cannot really answer that question. You know, that has been investigated in other studies. You know, what is your decision based on the angiogram, and what is your, now you get the OCT information, what is your decision then? We didn't detect that in the October trial. We simply asked physicians to use OCT guiding fully. We can then see, of course, subsequently that we asked, for example, here with the plaque preparation, we asked the physician to evaluate that, and then suddenly they did something more. Also, when they did, the final pullback, they thought they were, they should only do the final pullback when they're really sure, now I'm done, and then they had to do something more.
But maybe it's the reason to count it, and actually maybe to go and to analyze this one.
Yeah.
What is the percentage? What is the number when we really use imaging? Otherwise, it's pullback for pullback. It's art for art.
So at TCT here in 10 days, we will present those exact data.
Okay. If I comment on your question, what we observed in the Lemon registry like a few years ago was that the percentage of cases in which the operators changed their mind according to the OCT result where it was in left main intervention was 26%.
Excellent, and that's because I guess discussed this 2 years ago actually in the EBC as well. But this is important, and we need to know because this is the answer why we use imaging.
Okay, so we close here. Thank you, and thank you very much. I think that the October group should be congratulated, and now we move really. I mean, as the host for ABC, I really thank our colleagues connecting from US. We have Professor Greg Stone and Ziad Ali that will refer about the Lumion 4 that was published on Parallel. So we will start with Greg Stone. Thank you for joining. We hear your presentation, and then we look forward to have a discussion with you.
Hi, this is Greg Stone from the Mount Sinai Heart Health System in New York, and it's a pleasure to give you this talk describing the principal results from the Lumion 4 trial, which we just presented at a hotline session at the ESC annual meeting and published simultaneously in the New England Journal of Medicine. And it's a privilege, really. I'm presenting this on behalf of Ziad Ali and Ulf Landmesser, who were the principal investigators for the trial, and I had the privilege to be the study chairman. These are my relevant disclosures. So in Lumion 4, we randomized 2,487 patients who were at high risk because they either had diabetes or one or more high-risk lesion characteristics, which I'll show you on a subsequent slide, at 80 sites in 18 countries. This is the largest prospective randomized intravascular imaging trial to date. And the patients were randomized one-to-one to either OCT guidance using a very specific OCT stent selection and optimization protocol that we developed in Lumion 3 and have subsequently refined, versus standard angiography guidance. And of course, in the OCT arm, all patients had iterative use of OCT, including a final OCT run. In the angiography guidance arm, they only used angiographic guidance, but we actually performed OCT as a final run once the operator said, that's it, I'm complete, I'm finished. And the results of that OCT run were blinded to the operator. We had two primary endpoints. The first was acute and minimal stent area, powered for superiority in the OCT compared to the angio arm. And the second was target vessel failure at 2 years. These were the qualifying lesion characteristics. About 40% of the patients had medication-treated diabetes. And among the complex lesion characteristics, which you can see are all here, the number one was long or multiple lesions requiring greater than 28 millimeters of stent, and a culprit lesion being a myocardial infarction. Now, this is the EBC meeting, and I will point out that we did have an inclusion criteria for two planned stent bifurcations. So where you're going to stent both the main vessel and the side branch, but this condition was only present in 3% of the patients. By core lab assessments, you could see there was a balance between all the characteristics in the group. The reference vessel diameters of the lesions were 2.93 millimeters. The lesion lengths were pretty long, over 30 millimeters. And this was the one thing that was slightly imbalanced. It was about 3 millimeters longer in the OCT group than in the angio group. I'll also point out that more than 30% of the lesions were severely calcified by OCT core laboratory analysis, balanced between the two groups. OCT guidance compared to angio guidance led to the selection of substantially longer stents, larger stents, more and larger post-dilatation balloons. The device sizes were larger. The maximum inflation pressures were also increased. All the things that we've seen from prior OCT and intravascular ultrasound studies. OCT was associated with about an 18-minute longer duration of the procedure, with slightly more fluoroscopy and radiation use, and about 30 cc's more of contrast. Also pretty consistent with prior studies. The primary imaging endpoint was the post-stent minimal stent area by OCT at the core lab, and this was substantially larger in the OCT group compared to the angio group by about 0.36 millimeters squared, p-value of less than 0.001. In addition, when you look at other parameters which have been associated with adverse outcomes, they were also less than the OCT arm. So major dissections were less with OCT guidance. Major stent malapposition was less with OCT guidance. And major tissue protrusion, most of which probably represents thrombus, was also less with OCT guidance. We also had less untreated reference segment disease, and particularly less focal reference segment disease with OCT guidance. There were fewer angiographic complications as assessed by an angiographic core laboratory in the OCT-guided arm compared to the angiographic-guided arm, particularly fewer procedure-related thrombotic events. There were very few catheter-related complications by using OCT, so this was a safe procedure. Unfortunately, the overall primary clinical endpoint of target vessel failure was not significantly different between the two groups. There was a non-significant trend towards a 10% reduction in the hazard of target vessel failure at 2 years in the OCT group compared to the angiographic guidance group, but this was not statistically significant. When we looked at all the different subgroups based on the qualifying lesion characteristics, we also saw no significant interaction between the two groups. And again, this is the EBC club, so I will point out in the small number of complex bifurcations, the results were similar in those lesions compared to the non-bifurcations. So this was quite different than EBC, but again, the number's extremely small, so the confidence interval extremely wide. Now, cardiac death went in the right direction, a non-significant trend towards a 47% reduction in cardiac death, and target vessel myocardial infarction went in the right direction, a 23% a trend towards a reduction, but again, we weren't powered to show differences in these safety endpoints. The reason that target vessel failure was negative was because ischemia-driven target vessel revascularization was identical between the two groups. This rate was actually lower than we had anticipated, and again, absolutely identical, no difference whatsoever, despite the larger MSA in the OCT-guided group. Now, stent thrombosis, obviously, the major complication, a pure iatrogenic complication of stenting, was significantly reduced in the OCT-guided group compared to the angiographic-guided group from 1.4% down to 0.5%. And that was a 64% reduction in the hazard, p-value of 0.02. Notably, death or myocardial infarction occurred in 22 of the 23 patients, or 96%. With stent thrombosis. So all the safety parameters went in the right direction. Cardiac death, TVMI, and stent thrombosis. It's just ischemia-driven TVR and TLR that were not different. Why might this be? We don't know for sure, but one of the very possible things that happened was the COVID pandemic. About 80% of the patients were enrolled and followed up mostly during the COVID pandemic. And in the pre-COVID period, you can see there was about a 30% reduction in target vessel failure, at least the trend towards that, as we had anticipated. But in the COVID period, you could see the curves were superimposable. And the biggest difference here was in target vessel revascularization. And remember, TVR is a decision. It's not an actual event. And what we suspect happened was that during COVID, cath labs were closed and physicians and patients were electing, even if they had recurrent angina or a positive stress test, not to come back for repeat revascularization. So that might have led to the very similar ischemia-driven TVR rates during COVID. So in conclusion, OCT guidance of PCI resulted in a larger MSA than angiography guidance with greater stent expansion. OCT guidance led to fewer major dissections, major malapposition, major tissue protrusion, and untreated focal reference segment disease. OCT guidance reduced angiographic complication driven by fewer intraprocedural thrombotic events. The 2-year rates of target vessel failure, however, were not significantly different between OCT-guided and angiography-guided PCI. Consistent with prior intravascular imaging trials, there were numerically fewer cardiac deaths and MIs with OCT guidance, and OCT guidance significantly reduced stent thrombosis by 64%. However, despite enrollment of high-risk patients and complex lesions, the 2-year rates of target vessel revascularization were lower than expected and nearly identical with OCT and angiography guidance, a finding that was possibly impacted by the COVID pandemic. Thank you very much for this opportunity.
Thank you very much, Greg. We will hear also the other presentation, discuss together the entire trial.
Can you bring Dr. Ali's presentation, please? Or I don't know if he's doing it live.
I'm going to go live.
Okay.
Okay.
Over to you,
Hello,
Ziad.
Hi. Can you everyone hear me okay?
Yes, we can hear and see you very well.
Great. So I'll get started. Well, always nice to chime on what Greg talked to you about from the clinical side. I'm going to talk to you about what we didn't really talk about either at ESC or in great detail in the New England Journal of Medicine, which is the optimization protocol. These are my financial disclosures. Now, I think we should step back and remember why we designed Illumian 4. And that was on the premise of a series of trials called the Illumian series of trials. We designed Illumian 3 because up until Illumian 3, all previous studies comparing stent sizing using a lumen-guided OCT strategy to either IVUS or angiography by any strategy led to a smaller minimal stent area or minimal lumen area by OCT guidance. So OCT was disadvantaging itself by using the lumen compared to IVUS, which was using different sizing measurements, and even to angiography where operators were guessing. So we designed a novel stent sizing protocol where we used OCT guidance to try to match IVUS guidance and be superior to angiography in achieving a post-PCI minimal stent area. And the rationale was behind this was that the minimal stent area remains, as we've seen over and over again, the most important long-term predictor of clinical outcomes. In Illumian 3, we had 3 arms of 150 patients each, OCT, IVUS, or angiography. In the IVUS or angiography arm, you could basically do PCI like you normally did. But in Illumian 3, we asked the OCT group to follow a specific implantation and optimization protocol. And essentially what we did in Illumian 3 was ask the operators to find arteries that had at least 180 degrees of external elastic lamina, if they could use that, to use the smallest mean EEL diameter. And if they couldn't, because there was diffuse disease, to use the lumen, but to downsize based on the lumen. So this was EEL and downsize and lumen and downsize. And then we use the OCT automation. For optimization, what we would do is ask the operators to implant the stent, see if there was angiographic success, and if there was not, do a post-PCI OCT. And if we didn't achieve the target minimal stent area, we asked them to enter into this loop of post-dilation with bigger and more iterative post-dilation balloons. And OCT, in regard to the primary endpoint of the study, did end up becoming non-inferior to IVUS. So this was a major finding because it was the first time that OCT matched IVUS in terms of the MSA. But we didn't find a difference and we didn't have superiority against angiography guidance. We did have a trend, but we didn't meet it. So we stepped back after Illumian 3 and thought, well, why could this be? Why wasn't OCT better than angiography for MSA in Illumian 3? Well, it turns out when we took a deep dive into the study, we found that only about half of the operators followed the protocol for OCT guidance, and half of them simply didn't. And this clearly could have impacted the findings of the MSA in the angiography guided group. As Greg showed you in Illumian 4, we iterated not only the OCT guidance protocol, but also the type of patients that we were going to include in order to optimize the likelihood of benefit in the most complex patients and complex lesions. Essentially, Illumian 3's OCT guidance protocol is what developed into what is now known as MLD Max, where we asked the operators to focus on morphology, length, and diameter for the pre-PCI strategy phase, and for the post-PCI optimization phase to focus on medial dissection, apposition, and expansion. And really, these were the things that we had found in Illumian 3 had abnormalities and were correctable. So what we did is we decided, first of all, to split up the artery, unlike we did in Illumian 3, which was splitting the artery in half, into segments. And that segment took into account any bifurcation that was 2.5 millimeters or larger. Now, instead of saying you need to see at least 180 degrees of EL, we said as long as you can make a measurement across from the vessel wall, you should use the EL. And moreover, because we learned of the safety of lumen-guided stenting, we now asked operators that if they were going to stent by the lumen, that they rounded up rather than round down. We asked the operators to use the distal measurements to provide stent and post-dilation for the distal half of the stent, and in the proximal half, we asked the operators to do exactly the same exercise to preemptively pick their proximal optimization balloon, irrespective of whether it would be a bifurcation PCI or not. And if the operators ended up with an underexpanded stent, to simplify things, we simply asked them to follow the same algorithm in the segment of stent that had underexpansion in the post-PCI OCT. So essentially, it was a repetitive and iterative scheme. Now, what was new from Illumian 3 is that we made expansion both acceptable and unacceptable. Rather than being greater than 90, we went to 80. For improved efficiency, the stent diameter, length, and post-dilation balloons were all chosen immediately following the pre-PCI OCT. We had larger lumen-guided stenting. We divided the stent into segments rather than halves to account for the pot technique and to account for bifurcations. Reference segment optimization was specifically discussed. You couldn't leave focal disease at the proximal or distal edge. And we minimized the number of OCT acquisitions required. We actually said there was a minimum of 2 runs, which were the pre and final, and a maximum of 3 OCT runs without continuous cycling, intermittent and iterative post-dilation. We asked all of the operators in this 3-hour training session that we provided to understand that the expectations for success are basically on the attempt to do post-dilation rather than actually achieving an acceptable expansion. As you see, including all data, now including 3 new trials, the likelihood of you achieving the target is somewhere about 50%. Greg showed you this study. We had about 1,200 patients in each arm, which had a valuable OCT data. So what did we learn? We learned that OCT did exactly what we expected it to. It increased the stent length, increased the maximum stent diameter, the post-dilation balloons used, the maximal device size, and the maximal inflation pressure, and pre-procedurally it increased the use of atherectomy, advanced lesion preparation by 2.5-fold. And this worked because for the primary imaging endpoint, OCT led to a significantly larger MSA. Importantly, in this situation, we had incredible adherence to the protocol. Akiko Maihara was the core lab and gave real-time feedback in, 48 hours after operators submitted their cases. Also, we had 2 roll-in cases, but you'll see that the rate of optimal and acceptable was similar, but our adherence to protocol was excellent. And really what this translated to was about half of the post-procedure major dissections in the OCT group compared to the angiography-guided group, about half of the post-procedure malapposition in the OCT group compared to the angiography group, and about a 30% reduction in major tissue protrusion in the OCT arm compared to the angiography arm, and same about a 20% reduction in the treatment of focal reference segment disease in the angio-guided arm compared to the OCT-guided arm. And so this translated directly to angiographic complications from the core laboratory, which you could see were significantly lower in the OCT-guided arm. So ultimately, did it work? Absolutely. This iterative post-dilation strategy, which was simplified and serves as the basis for MLD-MAC, did in fact increase the minimal stent area as we saw in the primary outcome for imaging. And we know that the minimal stent area continues to drive long-term outcomes. We're going to take a deeper dive on this at TCT this year and the predictor analysis on Monday, and we'll hope to see you there. Thank you very much.
Great. Thank you very much. We really appreciated these presentations, and it is open for discussion. Who want to start? Go.
First of all, thank you very much, and Greg and team, and this fantastic study as well as October. And I guess it is really, really important to go forward with imaging, and as well, I'm really happy about your meta-analysis, which was presented in ESC. But could you maybe to speculate a bit that 2 years, it's too short term, and actually if we are looking on meantime interventions, and specifically if we are, for example, we have 10 years syntax study follow-up, I guess that 2 years it is a too short actually time period for follow-up. And what do you think, do we need to extend this or studies like those?
Most prior studies have shown a clear differentiation in the curves by 1 year, and they continue to spread at 2 years. So we certainly expected to see a difference then. In fact, the longer follow-up you get, especially when you're looking at endpoints like target vessel failure, you can get dilution of effect because of progressive plaque events from untreated lesions. We actually, as you saw, the curves did somewhat spread between 1 and 2 years in Illumian 4. But then if you look carefully at those Kaplan-Meier curves, they actually started to diverge a little bit at 2 years. So I really do think that we've seen what we're going to see out of this trial. And as we showed you, the pre-COVID curves were spreading and looked like they might be continuing to spread a little bit at 2 years. And that trial would have been positive had we seen that 30% reduction in effect that we saw in the pre-COVID era. But in the COVID era, there was absolutely nothing, and the curves were superimposable through 2 years, and that was about 80% of the follow-up years of the patient. So I don't think the results would be substantially different with longer-term follow-up.
So if you have questions, please do stand up. I see there's a colleague at the back.
Hi, it's Stuart Watkins from Glasgow. Ziad and Greg, what proportion of the patients that got into the study got into Illumium 4 on the basis of just being diabetic? And do you think this contributed to not meeting the primary endpoint? Sorry about my throat.
Ziad?
Yeah, so 40% of the patients were diabetic patients. And Stuart, you're absolutely right. We, as did the Renovate PCI investigators, did not see a major interaction in diabetes. So your question is very valid and very important. But 40% of the patients that were enrolled in terms of high-risk qualifying characteristics were actually diabetic. And our baseline characteristics, 40% of the patients had diabetes.
Yeah, but remember, most interaction tests are looking at relative interactions. And we know diabetics have higher event rates in general for a variety of reasons. And so you're seeing a similar relative effect in diabetics and non-diabetics, which frankly is what I would expect.
So thanks, Ziad and Greg. Again, going with the same discussion, why? We've just heard Niels and his colleague present the October trial, and you had less than 10% bifurcation. So perhaps if you had more bifurcation, do you think the results would have been different? And what is the reason behind a smaller percentage? Maybe it wasn't specified specifically in the protocol, because you specified multivessel disease and diabetes in your study.
Well, we had only 3% of two-stent bifurcations, and that was one of the qualifying lesion characteristics. We actually had a substantially higher percentage of planned one-stent bifurcations, and we're currently analyzing those data, and we will report them in the near future.
Okay, thank you. We have a question from a colleague.
Question or maybe a comment, because you published in the supplement of your publication in New England that the 90% of stent expansion was achieved in 25% of patients in angiographic group and in 40% of patients in OCT group. So my question is not why in angiographical group it is so bad, but my question is why in OCT group the stents were not post-dilated and the result was not achieved in 99% or 90%. This is the question.
So as I showed that slide in terms of which I titled goals for success, no study achieves their target when using intravascular imaging. In fact, the target is a fake target. We could tell people to get to 92 or 95 or 86 or 80. What it really does is it drives post-dilation to get to the minimal stent area. So we had 42% of patients achieve 90%. We had 63% of patients achieve 80%. And really the limitation is the plaque. There's, remember these measurements are made compared to the reference segment. So there's nowhere else for the plaque to go. You further don't get any expansion. In fact, in Illumian 3, we found that if you go back over and over and over again and use bigger and bigger balloons, you only get a 3% improvement in expansion, even if you use a balloon that's oversized to your reference. And that's basically because there's nowhere else for the plaque to go.
Yeah, especially with 30% of the lesions being severely calcified. You just can't expand these plaques further.
Hi, Ziad. I just wanted to ask, in real-world registries, we see that calcified lesions are almost 1/3. In this trial, we enrolled only complex patients, but still severe calcification was only seen in 1/3. And in one of the slides, which Dr. Greg showed, there was significant, I think results were significantly better in favor of imaging in the severely calcified group. So do you think if the proportion of calcified patients is very large, it can be a positive trial for imaging?
Yeah, we're going to look at specifically the calcified group and report that separately. But yes, while there were no significant interactions, including not in the calcified versus non-calcified groups, in terms of their relative benefit, it did tend to be somewhat better in the calcified group. And whether that is due to better lesion preparation or other features of the procedure that are different, we're going to look into in detail. I suspect it can be made even better than that, frankly. And I do think, personally, that calcified lesions are one area that can really benefit from intravascular imaging, particularly by OCT, because this is where you can really see the depth and extent of calcification and see the effects of lesion preparation.
Also, just one observation from the data that you showed is the stent thrombosis was different, and they all seem to be occurring in the early stages, and after that, it's pretty flat. So the impact of OCT is on preventing stent thrombosis is much earlier than downstream.
Yeah, that's a really important point.
Every study, 70% of the stent thromboses are always within the first 30 days for the most part. Although the curves did spread a little bit over time, and there were almost no late events in the OCT arm and a few late events in the angiographic guided arm. But you saw OCT also had the benefit of reducing intraprocedural thrombotic complications and major tissue protrusion, which is, again, related to thrombus in most cases. So I think all of that relates to early stent thrombosis. And so, yes, that is the biggest benefit, that plus the lack of dissections, lack of MSA. At TCT in about 10 days, Ulf Landmesser will be presenting a detailed OCT analysis looking at the predictors of all major outcomes, including stent thrombosis. And I think it's going to be very interesting in that regard.
Great. Thank you so much, Greg and Zian. Many congratulations on this great trial.
Thank you.
Okay, we will move on to our final imaging trial, the OCT IVA study, particularly on the bifurcation subgroup, which will be presented by Dr. Kang, who's online at the moment. So I think you've already recorded your presentation, so we'll hear that.
Thank you for inviting me to EBC 2023. I'm Dr. Do Young-gang from Asa Medical Center, Seoul, Korea. I will present the result of the Octavus trial. Intracorneal imaging guided PCI with IVUS or OCT showed superior clinical outcomes compared to the angiographic guided PCI. Each intracorneal imaging modality has different imaging technologies, lesion applications, advantages, or limitations. However, data on the comparative effectiveness of the two imaging modalities for PCI guidance for a broad range of the patients with the clinical outcomes are still limited. So we compared the clinical efficacy and safety of the OCT-guided and IVUS-guided PCI in patients who underwent PCI for significant coronary artery disease, and we hypothesized that OCT-guided PCI would be non-inferior to IVUS-guided PCI with target vessel failure at 1 year. The trial was designed pragmatically, and 2,000 patients was randomized one by one to OCT versus IVUS-guided PCI strategy. We included all coma patients, just excluding semi-severe renal dysfunction without renal replacement therapy, or cardiogenic shock, or decompensated heart failure with severe LV dysfunction. The primary endpoint was target vessel failure, a composite of cardiac death, target vessel MI, or ischemia-driven TVR at 1 year. Secondary endpoint had the individual components of the primary endpoint and bleeding event and contrast-induced nephropathy. We assumed a 1-year event rate of the 8.0 with a 3.1% of the non-inferiority margin. The details of the imaging optimization and the process of the imaging-guided PCI will be presented by the next lecture by D.W. Plunk. We randomized 2008 and OCT-guided PCI versus IVUS-guided PCI. And over 99% of the patients underwent 12 months clinical follow-up, and 100% patient was included in intention to treat analysis. The key baseline characteristics shows that mean age about 64 and 33% of the diabetic patient and 23% of the acute coronary syndrome. And about 12% had the left main disease, and over 50% have the any bifurcation disease, and about 10% has the aortic ostial lesion, and over 5% has a CTO. And mean syntax score was 15. And major patients underwent PCI by radial access, and over 97% underwent drug-eluting stent implantation. Mean stent number was 1.6, and mean stent length was 47 millimeter. And total amount of the contrast media used was higher in OCT-guided PCI. However, the total PCI time was shorter in OCT-guided PCI group. This is the primary endpoint of target vessel failure. 2.5% of the OCT-guided group and 3.1% in IVUS-guided group at 1 year. They showed hazard ratio of the 0.80 and showed non-inferiority of the OCT-guided PCI compared to IVUS. And there is the detailed list of the primary and secondary outcome that showed no significant difference between OCT-guided and IVUS-guided PCI. And also, we had the CV outcomes during the entire follow-up period of the median 2.0 years, ranging 1 to 4.8 years. The primary composite outcome was the 5.8% versus 6.1% that showed comparable clinical outcome between groups. And also in secondary outcomes, there was no significant difference. And this is a key subgroup analysis by the clinical factors of the age, sex, DM, Oke-Coronary syndrome, all showed no significant difference between groups. And there was also no significant difference by anatomical factors of the left main, diffuse lung disease, calcified lesion, or syntax score. This is the subgroup analysis by the bifurcation. In patients with any bifurcation disease, over 52% that showed event rate at 1 year, 3.1% in OCT-guided group, and 3.7% in IVUS-guided group, they showed no significant difference. And when analyzed only true bifurcation disease with the side branch disease, and about 21% has the true bifurcation disease, and OCT-guided group has a 3.8% of the event rate, and IVUS group had 5.2% and not significant. And also there was no interaction between true bifurcation disease and imaging guidance. And there are some limitations of the study. It was not possible to match the imaging modality from the patient and investigators. So there is the possibility of ascertainment or selection bias. And the observed number of the primary outcome events was lower than expected. And there would be the possibility of the discrepancy, on-site determined, and core measured imaging interpretation. And the generalizability and reproducibility of our trial findings may be limited due to geographic variability in the use of intravascular imaging in daily practice. And our trial did not include an angiography-guided arm. This is a summary. In OCTIV's trial involving patients who are undergoing PCI for diverse coronary artery lesions, OCT guidance was non-inferior to IVUS guidance, with the composite of deaths from cardiac cause, target vessel MI, or ischemic-driven TVR at 1 year. And OCT and IVUS-guided PCI also showed comparable clinical outcome in any or true bifurcation lesions. Thank you for your attention.
Okay, thank you very much, Dr. Kang, for an excellent presentation, and congratulations to you also and to the whole team for this very important clinical trial. Now I invite Dr. Park to take a deep dive into OCT IVUS trial.
Thank you for inviting the EBC 2023 meeting. I'm D.W. Park from Asa Medical Center. So my talking is about the OCTIPUS trial. It's a deep dive into OCTIPUS trial optimization criteria and protocol. And looking at the background and the intracoronary imaging, IVUS or OCT is recommended in selective patients for optimized stent implantation. And the US and the ESC guideline recommended, especially in complex region. Our OCTIPUS trial included 2,000 patients, one-to-one randomization OCT versus IVUS, and primary endpoint was target vessel failure at 1 year. Our inclusion criteria, we would like to include a broad range of the patients, native or restenosis, and treated with contemporary drug-eluting stent. And minimal exclusion criteria was applied. Looking at the imaging guided PCI procedure, conventional PCI method was used, and the conventional device for IVUS or OCT was used, and the stent size and length optimization. The segment was determined use predefined common algorithm on the basis of EAPCI. And looking at details of our optimization criteria, regardless of IVUS or OCT, we use the distal lumen reference-based diameter or EM reference-based sizing strategy. If you're going to use the lumen reference size, we are the up rounding of stent size, the reader, and if you're gonna use EEM, we are downsizing on nearest 0.25. We would like to avoid the landing zone in the large plaque area, and the relative stent expansion more than 80% we would like to achieve. Some patient, some region with a non-evaluable reference lumen area, optimal stent expansion was defined the absolute instant minimal stent area more than 5.5 by IBUS and 4.5 by OCT, and the core registration was used. So, and for diffuse long region and more flexible approach, lumen and the middleware or EM was allowed by physician discretion. For left main disease, minimal stent area for distal left main is more than 7. Proximal left main 8 was recommended, and the extensive stent malposition is tried to be avoided. Our trial is one-to-one randomization nearly at 1 year, more than approximately 90% was completed follow. This is the baseline characteristics, and the age is 64. Male gender was predominant. Diabetics is 30%. It's quite the comparable between two groups. And our trial included the complex coronary region, left main 20%, any bifurcation region, approximately half of patient, true bifurcation region 25%, and the CTO diffuse region, ISR region also included. So overall, the procedural outcome, imaging basis, the procedural success was achieved. There is a 48% in OCT-guided PCI, 54% in IBUS-guided PCI. Overall procedural complication is lower in OCT group 2.2 versus the 3.7. And this is core analysis, region level analysis. Minimal stent area is lower with the OCT than IBUS, and looking at the optimization, imaging guided PCI criteria. By region level analysis, all stent optimization criteria was met, achieved in the 53% in OCT group and the 60% in the IBUS group, and the optimal stent expansion was larger in IBUS, and the meta position and the larger dissection was much detected in OCT group. The reason why the overall the proportion without the major meta position large dissection is quite low in the OCT group. Primary endpoint is target vessel failure. As everybody knows, no difference error is non-inferior. So, and each type of cardiovascular outcome, there was no difference in the target lesion failure and mortality, myocardial infarction, contrast-induced nephropathy, and stent thrombosis is quite few. And the pre-specified key subgroup analysis was consistent in various clinical factors, also consistent in various anatomical factors, left main, bifurcation, long lesion, multivascular, and each syntax score category. This is a post-hoc analysis by optimization criteria and the presence or absence of all PCI optimization criteria. Each component of optimization criteria, overall finding was consistent without the significant statistical difference. In summary, our Octopus trial OCT-guided PCI was non-inferior to IBUS-guided PCI in target vessel failure at 1 year. However, study population was selected, and lower than expected event should be considered. And the last slide is the benefit of intracoronary imaging. The largely depend on off-rate interpretation and the reaction to imaging finding. There would be possibility discrepancy on on-site determined or correct measured imaging interpretation. Full optimization PCR result was only achieved in approximately half of patients. Therefore, further study are required to confirm the validity of such predefined optimization criteria. Also, and the new study was required to propose the new practical optimization criteria. Thank you for your attention.
Okay, thank you very much, Dr. Park. If there are any questions, please do yes, Nicola.
Yes, Dr. Kang, Dr. Park, thank you very much for this presentation. As I was reading your manuscript, I was surprised by the percentage of osteal lesions in both groups, which was between 9 and 10%. And in our experience, the ostial lesion that could be in right coronary artery or left main are not very good candidate to OCT imaging, but they are very excellent candidate for IVUS imaging. So I was wondering how you overcame this difficulty in your trial and the recommendation you provided to the different teams.
Okay, Toyo.
Yes. I'm sorry in advance for the background noise because I'm attending other conference. And as you said, the ostial lesion is not a very good candidate, especially for the OCT because it needs contrast filling. So the ostial lesion was not only for the very ostial lesion, but including the ostial and very proximal disease that covers the stand up to ostial lesion. And even there was some difficulty, especially with the OCT, but there was some techniques that could overcome the difference. We have used some guide in and guide out technique, or sometimes we use some guide excision catheter to evaluate the ostial lesion exactly. However, still I think that even the subgroup analysis shows no clinical outcome difference between OCT and IVUS even in ostial lesion. However, for the procedure, practically, I do not strongly recommend OCT for the ostial lesion.
Thank you.
Okay, Alicia?
Yes, thank you for your presentation. I have a question for Dr. Kang. About the result that you have shown, the target vessel lesion, it seems to be a bit less for the bifurcation, for the through bifurcation lesion in the OCT guided PCIs versus IVUS guided. Do you have any idea why it is happened? And this is just a tendency, is not significant, but I think is relevant and interesting to understand why it is happening. And then another question is, this is even shown that target vessel failure was a bit less in the group with syntax score low, with the low score or syntax. Despite we said right now that with complex bifurcation or through bifurcation is already complex, so we expect to have higher syntax score.
Thank you for your excellent question. That's a very difficult question, and we have so many considerations how to explain those differences. But it's actually not very different. So there are some tendency. But first of all, it can be by chance. It can occur by chance. And second would be that the complication was a little bit lower in OCT guided group. We think that more aggressive balloon expansion and larger sizing with the IVUS could make some such a kind of the complication in IVUS group, and even in the also in the true bifurcation group with the side branch treatment that could make some difference, I think. But still, this is not just a hypothesis because it's not very different between groups, and so we are undergoing the further evaluation with the bifurcation patient and true bifurcation patient, and with those thorough evaluation with the imaging analysis, we could show you more detailed data.
So the Octopus trial initially designed as a pragmatic trial in the real world, in the many centers in South Korea as a very familiar is a post-imaging modality and imaging in IVUS more than 10 years. But it's absolutely many expertise, imaging guided PCI. So, and in our trial, we'd like to include the broad range of the patient, but it's beyond our initial expectation. Even though we try to include the very complex, diverse the patient, overall mean syntax score is quite low. It's 15 and 50.6 in both groups. So that is the reason why the primary endpoint event was absolutely low than expected. This is the major obstacle to demonstrate to confirm the real non-inferiority of our Octopus trial.
Great.
And there can be some another hypothesis that can be got in by the syntax score, because even a high syntax score, we actively use the physiology FFR guided PCI. So the anatomic syntax score is not same with the treated vessel. And also there was some case with the staged PCI in high syntax and multi-vessel disease. So we did the subgroup analysis with the index multi-vessel PCI. However, syntax score is not 100% correlated with the index region PCI.
Thank you. I think Dr. Christensen
I have a question, if you can hear me.
Yes, we can hear you.
Yeah. Thank you. I have a question to the Octavus team about the strategy in the OCT arm in the calcified lesion, where the operators, because of the identification of the depth of the calcium, push to more aggressive pre-dilatation or post-dilatation?
Absolutely. Okay.
Yep.
Okay, your comment is so important. In our trial, in both group, and the overall proportion of the severe calcified region, 7.6% and 7.6%, less than 10%. Also, looking at the detail of the pre-region preparation, and we use the compliant or non-compliant balloon, 75% and 75% in both group, and the scoring of a cutting balloon just use the 1%, low tabulations, they use the 1.0 versus 1.5%. Overall use of the atherectomy and some debulking method was quite low. So, and absolutely, I fully agree, OCT absolutely better to determine the calcium severity. But there's overall the use of the debulking method is quite low, and in the next step we would like to see there would be some difference in the further analysis.
Yes, and we recommended a very strong post-dilation and further optimization by imaging. So over 90% of the patients underwent post-dilation with the mean post-dilation balloon pressure 22 atm is a mean value. Very high pressure was applied. And there is a little bit difference in supplementary material. You can see that adjunctive post-dilation was a little bit higher in OCT group. 92% versus 89%, 7%. Small difference, but a little bit significant. And it can be from the difference of the detection of the post-myro position or the calcium. So we need more further analysis of the cause. Thank you for your great opinion.
Okay, thank you so much, Dr. Kang and Dr. Park, and congratulations again on your trial.
Thank you.
Okay, now I'd like to invite Davide Capodanno, who I think has already sent in his presentation, to discuss the impact of all these studies on clinical practice.
Dear chairpersons, let me thank the EBC board for giving me the chance to comment on the latest evidence from imaging trials at the end of this session, and I will give you my perspective on the impact of these new evidences for our practice. This is my disclosure of financial interest. As you know, in 2018, the ESC and the ICTS issued a number of recommendations in support of IVUS and OCT with Class 2A level of evidence B or C. And you may say that the class of recommendation is only 2A and the level of evidence is only B or C because these guidelines from Europe were outdated. They are 5 years old now. However, even in the more recent guidance from our American colleagues, we still see class 2A level of evidence B or C for IVUS or OCT. So what do we need in order to get the class 1 level of evidence A for intravascular imaging? According to the ESC charter, for a class 1 recommendation, we need evidence or general agreement that a given treatment or procedure is beneficial, is useful, is effective. And for a level A of evidence, we need data derived from multiple randomized clinical trials or meta-analysis. We now have the randomized clinical trials, however, the results were mixed. In Illumian 4, there was no difference between OCT and angio-guided PCI for patients with diabetes mellitus or complex coronary artery disease in target vessel failure at 2 years. However, in the October trial, the primary endpoint was actually met. Cardiac mortality, MI, and ischemia-driven revascularization was significantly reduced with the OCT-guided PCI approach versus the angio-guided approach at a median of 2 years, from 14.1% to 10.1% in participants with the complex bifurcation CAD. It is of no surprise sometimes that trials in the same scenario end up with different results, especially when the type of patients and lesions that are included are different. For example, in Illumin 4, which was a larger trial, by the way, the proportion of patients who received treatment of bifurcations with 2 stents was 3% versus 64% in October. The stent length was also different, with the longer lesions treated in Illumin 4, 41 millimeter versus 23 millimeter, and the reference diameter was also different, with smaller vessels in Illumin 4, 2.9 millimeter versus 3.3 millimeter in October. I would say that a key difference was also the performance of the angiography-guided PCI group, the control group, 10.1% of event in Illumin 4 versus 14.1% of event in October. So the result was different, with no difference in Illumin 4 and 30% relative risk reduction in October, as we have listened. And this is the network geometry of the meta-analysis presented by Greg Stone at the ESC. Essentially, there are many connections between angio and IVUS, angio and OCT, OCT and IVUS, and there was also one external node given by the Renovate complex PCI trial that compared OCT or IVUS at the discretion of the operator versus angiography. So now we have quite a few trials, and of course the interest for a network meta-analysis is pretty obvious. The beauty of network meta-analysis is to make direct but also indirect comparisons between the different nodes, and of course we are quite happier when we see consistency in the results of the direct and indirect comparisons, which never happened in this meta-analysis essentially, although the p-value for consistencies were non-significant. But you see that in the intravascular imaging versus angiography meta-analysis, the network benefit was all direct, which is positive in a way. The same for the IVUS versus angiography network meta-analysis. However, when you look at the OCT versus angio and OCT versus IVUS comparisons, you see that the benefit seen in the OCT versus angio comparison on the network meta-analysis is all indirect, 50% of benefit, and in the OCT versus IVUS comparison, there was even no benefit in the network meta-analysis and arm in the indirect meta-analysis. These indirect comparisons benefits or arms tell us that there was no real transitivity between the OCT trials and the IVUS trials, so we need to be quite cautious here in extrapolating these results to a whole population. In terms of the other endpoints, I think this is another difference that comes obviously from the meta-analysis. The benefit of the intravascular imaging versus angiography comparison is essentially attributable to the IVUS versus angiography trials, where there was no benefit in OCT versus angio, as well as in OCT versus IVUS trials. This meta-analysis doesn't include the results of Octivus, and it's a pity because these are 2,000 patients with significant coronary artery disease and PCI, so it would have been a beautiful fit to this effort. And you see that in this trial there was essentially non-inferiority for the OCT-guided approach versus the IVUS-guided approach. Although we must say that the number of events that were counted in the IVUS group was much lower than anticipated. The proportion was 3.1% versus 6.2% anticipated by the investigators. In this scenario, it's important to recognize that the lower than anticipated event rate may bias the trial towards non-inferiority. In other words, it's easier to reach non-inferiority when you have less events than expected, because your non-inferiority margin would be too generous at that point. However, if we recalculate the non-inferiority margin for this trial based on a better statistical assumption, essentially we end up with the same results of non-inferiority. This is because the trial had actually very similar rates of events in a relatively simple patients and lesions, as you can understand from the number of events overall. If we include the results of Octavus into the pairwise meta-analysis of OCT versus IVUS, we end up with 5 trials, and again, a neutral result in terms of target lesion failure. The relative risk is 0.82. The confidence interval is still quite large, which means that we simply need more randomized evidence for this comparison especially. In summary, I would say that supported by evidence from clinical trials and meta-analysis, IVUS consistently showed substantial reductions in cardiac events. This foundation, in my opinion, supports the elevation of IVUS to a Class 1A recommendation, at least in cases involving complex bifurcation lesions, such as left main or non-left main bifurcation lesions. The evidence for OCT is definitely accumulating, but as of today, it is mixed, and in my opinion, remains less persuasive, at least for non-bifurcation lesions, as October was actually positive. IVUS and OCT, however, should be seen more as complementary rather than mutually exclusive techniques, so each operator should choose the technique he is more confident with. And finally, remaining questions include who are the optimal candidates to IVUS or OCT, the strategic timing of their application, which technique is preferable, and the perspective of healthcare payers and regulators, particularly in countries where intravascular imaging is not reimbursed. With that, I would like to thank you for your attention.
So I think that Davide really summarized very well the results. Are there any other remarks from the trialists that we have connected? Just okay, Greg.
Yeah, well, thanks. Davide, as always, does an excellent analysis, but I do have to try to convince him that we have enough data where the results of OCT guidance look really similar to IVUS guidance. I will share my screen for a second, and I'll show you the one slide which is the updated analysis, and Davide showed you his background, but this is the full network meta-analysis of OCT-guided PCI versus IVUS-guided PCI, and these are all the different endpoints. We have 5 clinical trials with 324 patients, and if you look at the direct estimates actually all favor OCT. None of them are significant, but they actually all favor OCT and not, inconsequently. TVMI 0.63, stent thrombosis 0.67, et cetera. But that only leads to about, anywhere from 30% to 50% of the evidence. Here are the indirect evidence, and then that's the percent of the indirect evidence. So here's the overall network estimate. And the bottom line is when you look at this network estimate, they're very, very similar for every single endpoint between OCT and IVUS. And the hazard ratios are not, or the relative risks are not that different. I mean, they're reasonably tight. They could always get a little bit better. But for TLF, the primary outcome, 1.08, 0.89, 1.33. So I think that the data that we have so far, at least for all lesion types that have been enrolled in these trials, is that the results of OCT and IVUS guidance are pretty similar.
Thank you very much for sharing these new results. So I think that now the session can be closed, at least with this slide. I think that we can say that the evidence seems enough to say that OCT is comparable, effective with IVUS, and regarding the search for the patients who may benefit more from imaging, there is still some work to be done. Thank you for your attention, and we go. Thank you to the trialists for connecting. It was wonderful, really. Thank you very much. And we go to the other session. Thank you.
Thank you.
but equal up. So I think that there should be a Yes, yes. Go.
Okay, good afternoon. Dave, please join us here at the stage. I think when our friends outside hear that we started, they will join us. We had really excellent session on image guidance. I think the most expected one from the EBC 2023. And now we go to Medtronic Symposium, and we will really discuss some very up-to-date and future technologies, as well as the results, updated results of EBC Main 3. So we focus, as always, on provisional, and we try to further improve it. Cooperation with the Medtronic and the Visible Heart Lab really helped us to improve several steps of our bifurcation PCI, especially provisional. And one of the lead authors in that process is Francesco. So Francesco, please share your data.
Okay, so we will try to assess the main vessel stent confirmation in different stepwise provisional sequences. These are my conflicts of interest. So these are the typical lesions where we know that actually stepwise provisional should be attempted. I mean, there is no measure disease in a branch, but there is tight disease in one, and the branch looks really both big. So I think that these are the typical sequences, conditions where you may consider not just to perform the POT and consider performing some ballooning after. So what we know and should not forget about side branch dilation. You see that in this simulation that really changed my mind on bifurcation, the fact that you balloon across a stent changes the conformation of the stent itself into the main vessel. And indeed, what we have is a malposition here, and we have this deformation inside. So this is very important not to be forgot, because if we do something like that, we should keep in mind that we should not jeopardize the result we achieved before into the main vessel. So enkissing has been developed to avoid the main vessel result worsening during side branch dilation. So this should be as the polar star here. I want to go on. Okay. What we learned about the limits of kissing balloon inflation? I think that the EBC group, Murasato, showed the fact that by a simple bench test, there is really the possibility to create just selecting long balloons, measure deformation inside the kissing balloon the balloon after kissing balloon inflation. And this is why the French group led by Dr. Finet proposed the post hypothesis a simple and perfect procedure. It is, consisting, we know the steps, and it has been presented at EBC as well. However, the bench test comparison with kissing that was indeed tested without the POT on top showed that it is really very effective also not only in preserving the Finet law, but also the flow. And however, into the practice, what was also learned later on, and this is important study by Derimé, the fact that POT seems to be a simple procedure, but it is highly dependent on the position of the balloon we are placing at the carina, and only when the POT balloon has a perfect location, all the benefits of POTS and repot are obtained. And in particular, we had also independent bench test studies performed showing that if you take the risk of being not precise in your POT, going close to the carina, you may really jeopardize the results strongly into the side branch. So this is the problem. And this is why into the EBC into the EBC recommendation, you can still find a recommendation about kissing that, coupled with the POT, can really be very effective. This is the sequence of short balloon after POT and repeat POT performed. And you may see that the Onyx stent can really adapt very well, and you will not find a measure oval distortion into the entire stent, and the oval distortion is mainly related in the polygon of confluence. So on top of this, we designed the Krabbe study that was aimed to compare the stent configuration obtained by two different side branch optimization techniques after main vessel implantation, and the sequence were POT, kissing POT, and POT side POT. The technology was the visible art. I think that all the EBC group is exposed to that. And the study consisted into harvesting and the reanimation of the porcine hearts. Then what happened in the beating heart was to perform the 30 PCIs on bifurcation coronary arteries with large side branches. In particular, we selected as entry criteria reference diameter in the side branch more than 2.5 and reference diameter in the distal main vessel more than 3.25. And the sequence was that we performed crossover stenting, then POT was applied, and then there was randomization onto POT side POT or POT kissing POT. In the case of distal rewiring was attempted in both procedures, and honestly, due to the fact that there was also the angioscopy, it was successful almost all the time. And on the opposite, there were, according to randomization, there was kissing or side, and then re-POT was applied with the same balloon in all the cases. So what happened after was the fact that there was the possibility to observe the results by three modalities, independent modality, angioscopy, angiography, and optical coherence tomography. And also we performed in post-reanimation phase micro-CT. The study endpoints were in the entire bifurcation area close to the takeoff, where as the primary endpoint minimum stent expansion at the distal main vessel in both the highest resolution modality that are OCT and micro-CT. And secondary endpoints were minimum stent expansion in the other segments, malposition, stent eccentricity index, and side branch osseous scaffolding length. That is this area where the stent can protrude after our side branch intervention into the side branch. So looking at the target bifurcation, I mean, you really see that they were very comparable to what is large bifurcations in our human practice. You see that proximal main vessel was more than 4.0, the distal main vessel 3.5, and side branch 2.6. So large bifurcation were enrolled, and no other differences in terms of balloons used into the two groups. Side branch optimization followed the practice. The length of the stent was comparable, and also there were no differences in any of the side branch interventions balloon performed. And this is the primary endpoint. You may see that there was no significant difference into all the area, except for the area of the distal main vessel, where there was a significant higher main cross-sectional stent area achieved with POT kissing POT. So this means that POT kissing POT is associated with better results into the distal main vessel. That is probably related just with the fact that the POT balloon cannot entirely correct the deformation induced by the side branch ballooning, especially when you have large balloons like that. These are the other secondary endpoints regarding the mean stent eccentricity index. There was a difference, but it was in favor of PSP that was confined to the bifurcation core mainly. And regarding the side branch scaffolding length, Pot kissing pot seems to be able to stretch much more the main vessel stent, protruding more inside the side branch. This is very important, especially in the case you have some disease that you have to deal with, or you need to implant another stent in that area. And regarding the malapposition distance and area, so all the measures, there was a signal for significant improvement with pot kissing pot. If we look at the results by multimodality image, this is what happens with pot side pot. You have this floating area here that is created probably by the fact that you have induced some modification that is not systematically corrected by the possibility of performing the RPOT. And here is also the micro-CT showing the different scaffolding length inside the side branch that you achieve with the two different modality of side branch intervention. So this is the first prospective randomized trial inside this unique preclinical environment. Bifurcation PCI were conducted with different configuration, despite that it is provisional. And PSP has better preservation of the circularity in the proximal main vessel, especially in the bifurcation core. However, pot kissing pot has better expansion and apposition at the level of distal main vessel, as well as at better side branch scaffolding. So what's next? Honestly, we decide to move forward to the humans, and we are performing the human phase of this trial, exactly the same protocol. Micro-CT will not apply, but we will stop for sure at OCT, and I hope in the future we will have the results. So if we come back to the two cases I opened with, they've been randomized in the trial. This is the patient randomized to pot kiss pot, and this to pot kissing pot, sorry. The results in this patient were fantastic at angiography, fantastic in terms of expansions with the pot side pot. However, you see here at the three-dimensional image that there was a similar aspect of some protrusion of the stent struts inside the main vessel. In the other case, that is really very easily performed following all the steps, you see that there is the central position of this part. So this is really one more the evidence that what we see in the visible art seems to rehappen. We will see if we will have the similar statistical results. However, it seems that the phenomenon may occur during our intervention. Thank you for your attention, and thanks my fellow.
Thank you very much, Francesco. Excellent, and looking forward to listen to your results. Dave, can we now discuss EBC main 3-year update?
Okay, so I'm going to give you some update on the EBC main study and a couple of cases if we have time. I'm not going to talk about the results in too much detail because Sandeep Arunathayaraj is going to talk about them in more detail later. Here, in brief, are the results. And the thing I'd like to draw your attention to is the fact that the revascularization rate at 1 year was very similar, but between 1 year and 3 years, in the provisional group, there's hardly any increment in adverse outcomes, whereas in the systematic dual stenting group, there's quite a substantial increment. And that contributes to the main, if you like, positive finding of the study, which is a statistically significant difference in TLR rates between the systematic dual, which comes out worse than the stepwise provisional. Sandeep will be talking about that in greater detail. So in terms of conclusions and then impact of this study, okay, twice as much TLR. Crucially, only 20% of patients in the provisional group required a second stent. So all of these patients were patients that the operator was quite willing to do an upfront dual stent strategy. So they're prepared to put in 2 stents, but in fact,
when they were randomized to the provisional group, only 20% of them actually needed a second stent. That's a really crucial finding, and it's replicated in other similar studies. So for me, one of the most important messages that I try to get out from this study is that you shouldn't really decide, I mean, I put it slightly kinder here, it's not necessary to decide the number of stents before you start. You could go further, say it's a mistake to decide the number of stents before you start. As Jens Lassen likes to say, he's not here this time, but he will be next time, if you start with 2 stents, you can't end up with 1. So what's the impact of the study? Well, I think EBC main probably redresses the balance a little bit that we've seen over the last 5 years. For the left main, the more complex intervention has had the upper hand. That's different to the situation in non-left main, where pretty much everything has been consistently shown that there's no systematic advantage for a more complicated strategy. That's not the same in left main, where the DK crush studies in particular have advocated the more involved approach. And I think we have to question, you know, the aesthetically satisfying treatment has really been in the ascendant. You know, it allows the cardiologist to feel jolly clever and, you know, very pleased with themselves. Well, look what I did. It looks beautiful. I've done a fantastic job. But is that actually what the patient needs to have a really good result? I think, hopefully, DK crush, which was, in my view, prematurely placed into the guidelines as a specific technique, I think it should no longer be specified in the guidelines. And I think if that happened, it would be helpful. And you may wonder, why has Dave got it in so much for DK crush? It's purely and simply because it's an obligate 2-stent strategy. You start with the cyber. If you look at the thing and say, I'm going to do DK crush, you are committed to 2 stents from the start. And that, as we've shown, is not necessarily the right thing to do. And actually, for our geography in the EU, very few patients actually meet sufficient complexity criteria. In fact, in EBC main, I think the definition 2 criteria was only 5%, slightly less than 5%. So I think we should pause again to think, is the aesthetically satisfying stent result at the time the one that gives the patient the best outcome? And very commonly the answer is no. And we should also think, as we are thinking, if 1 stent may be better than 2 stents, all other things being equal, then could it be that no stent is better than 1 stent? So that'll be roll on EBC DCB. And if I have a couple of minutes, I have a couple of cases to show you. These, you know, there's selection bias going on here. I accept that, but these are 2 cases. So 78-year-old man with a new diagnosis of lymphoma, and he's anemic. And you can see quite a messy angiogram with, he's getting a lot of angina, at rest, has come into hospital. You could look at this fairly ugly angiogram and think, oh, okay, and start planning in your mind some complicated strategy. But you know, if you just take these things stepwise, systematically, step by step, and stop when you've got a good result, you can surprise yourself. So what we did in this particular case, he's not trying to get off the table. He's got intractable hiccups from his lymphoma. What we did, in fact, in this case, is he had a drug balloon, as I recall, to the mid-LAD, and he had predilatation from the left main into the obtuse marginal. It's not a traditional direction, but in this case, it was probably the right one. Stent, pot, and now I would do the pot puff, actually. I rather like that. I would try that here. Result, finish, back to the ward, and actually he's been fine since. So, you know, complicated anatomy with a fairly simple solution. And here's another one. Okay, it's going to be broadly along the similar lines. Here we've got quite a complicated, possibly trifurcation-ish type anatomy, some calcification, This patient has treatment to the proximal LAD and then the LAD back into the left main, has proximal optimization, and then, oh, okay, we seem to have lost our intermediate, or whatever you want to call that vessel, very high diagonal, and the circumflex. Patient doesn't like it that much. And you could immediately be thinking, oh, stent, but just take it step by step. So pot, rewire, kissing, and okay, great, we're doing better. The circumflex is still lost, but we've got the intermediate now. Okay, same again, rewire, kissing, and actually that was all that was needed. And that was in 2016, and he's been fine since. So, sometimes we should do less rather than more, and trust also partly to the magic of the human body, which is nearly always greater than the magic of the interventional cardiologist. Thank you.
Fantastic. I think you should do it in front of the FDA in order to help our colleagues in US to use bifurcation provisional more. Now we go to new technologies. Dr. Hikichi, yes. You pre-recorded your presentation or? Already. Yeah, okay. So let's listen to role of physiology using the cut works in bifurcations.
Good afternoon, everyone. I will discuss about FFR angio. This is my disclosure. In Japan, wire-based FFR was approved for insurance in 2016, and since then, the use of wire-based FFR has gradually expanded. From 2018 onwards, providing myocardial ischemia became a prerequisite for performing PCI on CCS. From that point, the number of PCIs has been gradually decreasing. At the same time, among the devices used to evaluate myocardial ischemia, the frequency of using wire-based FFR in particular began to increase significantly. Wire-based FFR is gold standard. Meanwhile, coronary CT machines are widely available in Japan, and introduction of the FFR CT utilize their capability is also being promoted. In this context, my hospital chose FFR angio, which was approved for insurance at the end of 2020. Wire-based FFR has several challenges to address. First is the cost, as drug for wire and rod are required. The procedure time for the diagnostic catheter is extended. In some regions, measurement can be challenging, and in case of complex lesion morphology, the frequency of complication became a concern. CT-based FFR also has a challenge. First, a volume of contrast agent. Caution is necessary depending on the renal failure. And what I'm concerned about is the reduction in the training opportunity for young doctors due to the decrease in catheter case. If appropriate angiographic images are obtained, FFR angio will provide FFR value. In practice, there are 4 steps to derive result. And while I don't fully understand all these steps, by sending appropriate tri-directional angiographic image to the device, and skilled radiological technician will analyze them. Regarding reliability of the result obtained. Many credible reports are available. High correlation between wire-based FFR and FFR angio have been shown, with high sensitivity and specificity and good overall accuracy. In research from the Gifu Heart Center in Japan, similar results have been obtained as in preceding FFR studies. In the group with FFR angio positively who received additional PCI, and in the FAME2 group with FFR positively who received additional PCI and medical treatment, it can be seen that the subsequent outcomes are very similar. I have listed some requests here, but young doctor quickly memorized them, and high-quality image can be obtained. We minimize contrast agent use during exam by creatively adjusting angle and using an automatic injector. The first case is simple RCA. The total amount of contrast was 8 ml. Both wire-based FFR and FFR angio were performed, and both yield reliable results. Moving on to bifurcation. It is a lesion at the bifurcation of the LAD and the diagonal, and it appears there is no lesion in the diagonal ostium. Regarding long lesion of the LAD, severe ischemia was confirmed in both the LAD and the diagonal after measurements were taken using the both wire-based FFR and FFR angio. I believe what everyone is particularly interested in the post-treatment value. In this case, we use OmniWire to check the FFR value for the side branch after main vessel stenting. After the stent implantation into the main vessel, stenosis appears at the side branch ostium due to carina shift. In this case, there is a discrepancy between the result of wire-based FFR and FFR angio for the side branch. The reason is not clear, but it might be due to the influence of the FFR wire in the side branch. Let me present another similar case. The diameter of the side branch is not large, but it has a broad dominant. The strongest stenosis is right after the bifurcation in main vessel, and FFR angio evaluate has a positive for the main vessel and negative for the side branch. The same result was obtained with wire-based FFR. It is a diffuse region, and two stents are placed. After treatment, good blood flow is maintained in both the main vessel and the side branch. In this case, we measure the value by threading the FFR wire toward the side branch. First, the need of the side branch expansion was confirmed by FFR angio. Then, wire-based FFR was added, and both were similar negative. If these utilities are proven, it could become a groundbreaking method for decision-making in bifurcation treatment. Lastly, let me point out that the current version has its limitations. Stenosis is observed in the left main shaft and the middle part of the LAD. He is asymptomatic, and I would really like to know whether there is ischemia or not. This is another angle. FFR angio recognized the presence of the stenosis but was negative. For caution, wire-based FFR was performed and it turned out to be clearly positive. Ad hoc PCI was performed to verify the region of the left main shaft, and severe stenosis was confirmed with an IVUS image. You should be aware that the current version of FFR angio does not support left main. This is my conclusion. I expect FFR angio to be especially useful for evaluating ischemia in main vessel and side branch before and after coronary bifurcation treatment. While there are still limitations, the speed of version update is fast, and I anticipate it to become a valuable adjunct for coronary bifurcation treatment in the near future. Thank you very much.
Thank you to all three of you. Dr. Hikichi, how do you see in the future use of this technology in bifurcation treatment, pre, during, and evaluation of the jail side branch, or you still believe that impact of main vessel disease may impact also the numbers that we achieve in the side branch?
Yes, exactly. I think the total contrast, we usually use the bibrand machine. The total contrast, left coronary artery has only 10 cc additional volume, and after then we check the main vessel and the side branch. So especially the after treatment, as implanted main vessel, we can check to use the side branch. We have better expansion or not. It is a very important point.
Okay, thank you very much. So on behalf of the EBC, we really thank Medtronic again for setting up this symposium and for continuous cooperation with the Visible Heart Lab, and also for allowing us to use new technologies. Provisional remains our gold standard, but we still identify spots to be improved, and pot side pot versus pot key spot is probably one that is left unclear, and I hope that we will be able to get one more answer in our consensus. And they, of course, at the end, thank you very much for putting wording that we will use in the next couple of months, trying to convince people that EBC main at 3 years really shows a wonderful trend towards the reduction in events. Thank you very much all. Thank you. Invite Valeria to join me here. So we have another symposium, which is actually continuation of the session on imaging, and I'm really delighted to share this podium with Valeria Paradis. And we have our expert, Dr. Kevin Croce, connected online, and we go even a step beyond the results that we saw previously in the session, OCT versus IVUS, both versus angio. Now we really have a privilege to see demonstration of the new version of the Ultron 2, and really amazing possibility to further standardize and simplify the use of imaging. And maybe that's the way to go to relieve the operator from some important decision-making process during the PCI, and let our artificial intelligence help us make the proper decision. So Kevin, thank you very much for dedicating time and did really wonderful case. And I hand over to you. We start this by showing the case, and then we will discuss. There is great audience here from the EBC. You know, people from EBC, we like to discuss, we like to ask questions. So please go ahead.
Yeah, I've long watched some of the wonderful contributions of your organization. And so it's a true honor to be here and be invited to kind of have part of the discussion, share a little bit of our experience with Ultrasound 2.0, and I think show a case where some of the power of artificial intelligence, both for case planning and also some of the neat, case assistance menus and the way that we've been using this tool recently. And so again, it's an honor to be here, and I look forward to discussion. The case I have has a kind of a neat, lead-in and clinical scenario that I'll go through. Maybe I'll present the details and the baseline angiograms. I'd love to open it up discussion among yourselves, Valeria and Goran and colleagues there, to talk a little bit about what to do. A lot of the fun part about these types of discussions is there's a lot of different ways to approach things. And I know there may even be some geographic differences in terms of how we do bifurcation stenting, US, Europe versus Asia. And so I'm happy to be here, discuss and learn from colleagues. So again, thank you very much for the invitation. I'll bring my slides up now. And they coming through okay, Goran?
Yes, we can clearly see them. Go on.
Great. So, we've started in the US, and I know in Europe also, is to apply an algorithmic approach to image-guided PCI. MLD Max is the algorithm which I think has taken off, at least on our side of the pond. I'm interested to hear about the European experience with this. But I think, to try to increase adoption of image-guided PCI, colleagues, myself included, got together a couple of years ago to try to make image-guided PCI simpler. And this is originally applied to OCT, but at least in our center, MLD Max is the roadmap of how we do IVUS-guided stenting also. And I won't belabor this because I'm sure it's familiar to many in the audience. We can have touch points about it if it's helpful. But you really pretty much boil the case down into two parts. You do a pre-PCI imaging run to assess morphology, length, and diameter, to really outline the map of what you need to do to optimally treat a lesion. And then once the stent is implanted and post-dilated, we look to make sure that the stent is optimized by absence of medial dissections, assess apposition to the extent that it can, affect recrossing and retreating patients, even though it may not drive outcomes as long as the stent is well expanded, and then really focusing on expansion as the main predictor of why stents fail in patients. And so, we looked at MLD Max's behavior in a workflow study called Light Lab. And if you use the OCT information, both pre-PCI and post stent implantation, to assess how the stent has gone in, we see demonstrable changes in physician behavior when they use the imaging compared to what they committed to doing just looking at the angiogram. The type of lesions, decisions about vessel prep, stent diameter, stent length, they're all measurably affected when you use imaging to guide the case. And if you use the imaging to guide your case pre-PCI, there's actually a lot less impact of the imaging on the post-PCI optimization. We think because you get it right when you use the imaging up front. And so this was helpful to me because it really showed, at least in my experience being an operator in the study, that I'll say I'm going to do one thing based on the angiogram, and when I use an imaging catheter, it changes demonstrably what I do in the case in important things like stent diameter, vessel prep, and dealing with underexpansion. And so this has always sort of been a beacon of why I image in cases, and this was taught to me by being part of this study. So without further ado, we're going to talk about a 72-year-old female that I had the pleasure of treating quite some time ago, elective evaluation for CABG versus PCI, which is why she was sent to me and one of my surgical partners. Past medical history is known CAD with an RCA CTO that had been long-standing since 2017, bilateral carotid endarterectomies in 2012, lung disease, type 2 diabetes. She unfortunately was admitted 3 months before I met her with a recurrent gastrointestinal bleed and a type 2 myocardial infarction, which was complicated by congestive heart failure. At that point, she had active bleeding in her proximal jejunum. This was cauterized and clipped. and a diagnostic cath was done which showed multivessel CAD. Unfortunately, the diagnostic cath at that time was complicated by a right MCA stroke, which was procedure related. This is actually treated with TPA, and she had very good recovery, but they deferred any treatment of her coronary disease with either PCI or CABG, both because the stroke was the main issue and it was a type 2 MI, so they were hoping to defer, let her recover from the stroke, and then reassess. At the time I met her, she was having class 3 angina requiring regular nitroglycerin. I'll share with you the data we had. Her creatinine was 0.69 with a relatively preserved GFR, and a PET stress was done, which showed substantial abnormalities. 39.7% of her myocardium was ischemic with a sum stress score of 27, a sum difference score of 15 with medium-sized, moderate to severe ischemia in the mid to distal LAD, and large area of hibernating myocardium in the distribution of both the PDA and PLV. Her echo had an EF of 50%, which had improved from 40% on medical therapy from her prior hospitalization. And she had moderate aortic stenosis with a mean gradient of 20 with trace mitral regurgitation. These are the diagnostic angiograms which were done 3 months before at the time that she had her embolic CVA around the time of her gastrointestinal bleed. They were unable to engage her right coronary artery well because there's a pinhole sort of functional TO at the ostium. This was known to be present since a long time ago. They tried a bunch of different catheters, but these were the best pictures that we got. This is the left system, which shows intermediate severity LAD and diagonal disease, a well-collateralized RCA. And in the caudal view, you can see probably best here that there's an obtuse marginal chronic total occlusion with left-to-left collaterals. So we submitted her to our heart team. Her syntax score is 37. Clearly, at least from a TVR or target vessel failure standpoint, you'd suggest there's probably a benefit to CABG versus PCI from a revasc standpoint. However, when our surgical team looked at her STS score based on frailty, recent stroke, PVD, et cetera, she had substantial risk of a CABG with an AVR. And so our heart team clinical decision-making was the indication was class 3 angina with a recent non-STEMI. CABG versus PCI, our surgical team felt that because of the recent CVA, stroke, her peripheral arterial disease, her being frail, having had vein stripping and poor conduits and moderate AS, they asked us if we would consider PCI for this patient with the idea that she could get a TAVR in the future when her aortic valve progressed. So our plan was multi-vessel PCI, for which we have possibly an LED diagonal bifurcation. The PET was abnormal, but you could consider based on those intermediate severity lesions whether more information is needed. A left circumflex JCTO1 and RCA CTO JCTO4, which had been long-standing since 2017. So with that in mind, I just have sort of two stills up of the left system and the LED, and I'd sort of ask, if we're going to do PCI in this patient, maybe Goran and Valeria, thoughts about revasc percutaneously, and then if you're going to do that, where to start, how to start. There's a lot of open options. There's 3 potential targets: treat the right CTO, treat the circ CTO, or potentially treat the LED diagonal as shown here. So with that in mind, I'll let everybody discuss, and I'm happy to answer any questions, and we can go through what our approach was.
Yeah, perfect. Thank you very much, Kevin. Of course, I start with Valeria. What would your heart team discuss and consider in such kind of patient? But I also invite colleagues here in the room, if they want to comment or have different opinion. We have microphones. Please just raise your hand. So what is your consideration for 2 occlusions, intermediate, true bifurcation LED diagonal, really, 1-1-1, but or 0-1-1, but with 2 occlusions and really frail patient? What would you do?
Yeah, it's a complex case. First of all, we have to acknowledge that this is a high bleeding risk patient with a recent bleeding, but also a recent stroke. With a 2 CTO, intermediate lesion in the LAD that we want to assess. I think we want to know if that's significant. The SPECT probably is not really helping in identify which is the area at risk, and at least in the LAD because of 2 CTOs. when we consider the functional assessment of the LED, we have to also take into account that the LED supplies a large territory of 2 CTOs. So that's also a limit. And of course, the moderate aortic stenosis. So probably if the patient hasn't had a recent stroke, that would have been a good candidate for surgery and a concomitant valve treatment. But this is the case. So I think my heart team would have said, okay, proceed with PCI. And I think my next step would have been assessment. And I think it's open for discussion. Functional evaluation of this LED, or you think it's angiographically significant?
Yeah. Anybody wants to comment on this? Dr. Duval, CTO expert. Eve is there. Okay, let's listen to words of wisdom.
So yeah, I agree that with Valeria that this LED is sustaining also the right and the distal marginal. So I think this lesion, even if it's not very spectacular in LED diagonal, has to be treated. I think this is the first thing to do. It will be quick, it will be quite easy. We'll do a provisional strategy there, treat or not the diagonal branch. And after that, if it's done in, let's say, 20 minutes, then we can go to see better how is the right CTO is probably difficult, but see better how is the CTO as a marginal. And to know that, I will come close to the occlusion with a microcat and do a local injection, just to see, not to do hydraulic treatment, just to see how it is tapered or not tapered and so on.
Thank you very much. Yeah, okay, Sudhir?
Yeah, so I kind of agree. And I think the pressure wire assessment of the LED is not going to help here because it's supplying the collaterals to the occluded RCA and circumflex. It will be overestimated. So I think we go to treat the LAD in a provisional fashion and then treat the circumflex and decide on the RCA CTO needs to treat on this sitting or next sitting.
Yeah, so, yeah, Dr. Ivelic.
If this is an old lady with a high bleeding risk, can we maybe just treat the LED with the DCB, and that is, we can just do the 1 month on the depth, and maybe because she's living with the CTO RCA for 5 years, as I saw, maybe not to touch now the CTO of the RCA and the marginal to see what will be in 1 month, 3 months or later, and then maybe to decide to do the RCA or marginal branch.
Okay, thanks. Kevin, could you see, or I don't know if you can see us, but I'm sure you can hear the comments and suggestions. So I hand over to you back to see your opinion and actually show us how you proceed.
Great. I can both see you on stage, Goran, and I can hear everybody exceptionally well. So I think all the points raised are wonderful. And, you know, what I was actually expecting was a lot of times in CTO conferences, when we talk about whether to treat the open artery or go after the CTO first, or in courses that I run, I'll ask people to raise their hand. There's a lot more disagreement of which to go after first. And so I'm sort of, you know, solaced by the fact that the experts there agreed to probably start with the LED, which is what I decided to do. And I think the comments about the impact of the accuracy of physiology, given the amount of myocardium subtended by the LED with CTOs, is right on. And so I looked at that as all important parts of this case. And I'll show you what I went through, and maybe we can have a little bit of an idea of a discussion. So our plan was a physiology-guided PCI of the LED, and then fix the left circumflex CTO, possibly in a stage fashion, I think just as was discussed by one of the colleagues there. And then our most recent commentator, I'm sorry I missed your name and couldn't see you. It was one of our female colleagues. I took the same approach, that the right coronary artery had been there for a long time. And although certainly treatable, I would leave that as the last thing to do and just take it step by step. The one potential hazard of treating the LED first is I might make it a little more difficult to go retrograde to get to the right coronary artery, but we can usually get through septals, and I think these are big and they're not angulated. Even if they were stent jailed, I was pretty certain I'd be able to go retro if I had to. There did seem to be a pinhole, at least on the prior pictures, antegrade for the right, but if an antegrade wire escalation strategy to the ostial right coronary artery didn't work, I'd be comfortable trying to go through stent struts in the LED if indeed I decided to stent it. And so great comments, and I'll show you how the case went through as we move forward. And so the first thing we did was we did physiology. This is the data I pulled just to talk about this with my fellows. I was kind of aware of this, but as we were discussing this case, as mentioned by several colleagues there's a lot of myocardium coming off of this LAD. So what this study did is it looked at the impact of the change in either IFR or FFR in the LAD for indeterminate severity lesions before and after you fix the RCA CTO. And on average, the IFR doesn't move very much. This is on average, 0.86. It goes up to 0.9 when you fix the RCA CTO for intermediate severity LED lesions. So there is some movement. And although on aggregate, most patients don't move very much, there are a couple cases in the scatter plot where the patient goes from 0.5 to 0.8. So I sort of look at this as a scaling issue. You know, if the RFR, IFR is 0.7, in most cases, it's unlikely to normalize. But if it's hanging around 0.86, 0.87, those are the cases where fixing the RCA CTO may actually normalize the LED. And so I'll just bring this up as a point for discussion. Maybe I'll show you the physiology, Goran and Valeria, and ask if there's any interest in discussing this particular point. And if not, we can go on to the image-guided treatment for this patient. Similarly, the FFR moves from about 0.76 to 0.79 on average, with most patients not moving very much, but a couple bumping up substantially. So we did this, you know, I sort of have this in the teaching deck, but the guide was a little bit in and out. So we stabilized with the wire in the circ, did a careful normalization of the wire, and went ahead and did the diagonal RFR pullback. And it was substantially abnormal at 0.73, with the majority of this drop-off coming across the ostium, I think, as you might expect. And similarly, this is the LED RFR, with again, the majority of this drop-off happening through this region here, where you can see there's intermediate and then moderate severity disease. So I looked at this as being, you know, abnormal enough in both the diagonal and in the LED, where if I had fixed the CTOs, I would not have anticipated that these would normalize to a place where I would see, all right, now the patient doesn't need their LED diagonal treated. One of the things I like about image-guided PCI is, you know, you got to get a second check of the physiology. And a lot of times in my experience, when the physiology looks this bad and the angiogram looks not so bad, I then do either an OCT or IVUS and see that there's a really substantial plaque there. And so any thoughts or comments on kind of rationale for using physiology as outlined here, Valeria or Goran, or would you like me to move on?
Well, I just want to comment that's a really smart indeed use of physiology. In this case, the resting index can provide some information, some insights when we cannot probably rely the FFR, considering the large territory supplied by the LED, but the resting index can give some insight about the highest jump. So the pullback is really informative. And I think in this patient with a recent non-STEMI, we can use also the imaging. So in a complementary role, looking maybe for some features for high vulnerable plaque, because we haven't identified any vulnerable plaque in this patient with a recent non-STEMI.
I think there is general agreement, Kevin, in the room regarding the role of physiology, and I suggest to proceed with imaging and discuss the imaging.
Excellent. So, you know, I think standard to our protocol, we're looking to assess the morphology of the lesions, determine the length of stenting, hopefully finding a normal segment, and then assessing the diameter with imaging where we know it has a dramatic impact in terms of choosing stent and balloon sizes. So this is the MLD application of MLD Max. So here is the Ultron 2.0 OCT pullback of the LED. It plays a little bit quickly here, but you can see I'll call out in this next panel and then I'll go back. Here's the cursor on the OCT. Here's the lesion at the bifurcation. You can see there's a mild amount of calcium with a relatively small lumen area for an artery that's this big. This is the part that was most physiologically significant on the pullback. And one of the nice things about the new Ultraon 2.0 system, this is using in the flexible mode. And you'll see here that the AI assists with many things. And so in this particular case, the EEL is visible and is called out by the computer. And I set my margins for landing and choosing stent size based on the proximal bracket here and the distal bracket downstream. For those of you that are used to using AptiView as your OCT software, the newer Ultraon versions have actually flipped such that proximal is on the left and distal is on the right. Those of us that are avid prior software users, it takes you a couple cases to get used to this, having done it the opposite way a bunch of times. So I just have that as an orientation feature. One of the most pleasant new features of this software is on the lumen profile view, the computer calls out graphically the external elastic lamina as this little white line. And so when we go to define the MLD in morphology, length, and diameter of MLD max, it really helps you because outside of seeing the bottleneck of the lesion here, you can start to identify normal segments readily because the place where the lumen and the EEL on this longitudinal view are close together almost always means that there's not much plaque there. And it allows you to say, oh, there's little difference between the EEL and the lumen. That's typically a normal segment. And within the bracketed areas I chose for this case, which is about 28 millimeters long, the computer is smart enough to let me know the luminal dimensions and the EEL dimensions there. It was unable to find the EEL proximal, so you still have to do a manual measurement. And you can see in places where the EEL is not visible, the artery tends to be a little bit more diseased. So I'm just going to go back to the OCT pullback, and I'll try to grab it here and get it to play a little bit more slowly. The other difference you'll notice between the older OCT system and the newer one is the playback typically goes from proximal to distal as opposed to distal to proximal. So a couple of things to get used to as you're starting to use the new software. But you can see the M in MLD max, there's a little bit of swirling, but we don't see major amounts of calcium, and there's a relatively nice normal landing zone here. And so I define a distal segment, which looks good, a proximal segment, which looks relatively good. There's a little bit of intimal thickening. And therein, for me, it tells me I'd be happy to place a 28 or so millimeter stent. And on the computer, we actually have the places where that is. So it helps me to co-register stent placement along the lines of how we're going to do the angiographically. Because I don't have a workstation available to show you, there's actually a feature where you can have this particular still up on the right when you're working, and it will bring in a live angio. So you can be positioning your stent on this part of the OCT screen, looking at where you want to place it with a little call out on the right. And so there's some really nice features of this from a case planning and case execution, which makes things much easier. You can also see
Kevin,
that
if I may just interrupt for a second, what I personally liked very much is automatic identification of the side branches, and you have the white dots which really help you with co-registration to know precisely where you are. And I mean, for bifurcation PCI, this is extremely useful feature.
Yeah, exactly. And then it also helps you, if you're going to choose a length of a stent, if you want to go a little bit longer, there might be a hazard of crossing a side branch. And so if we were thinking landing distal to proximal to get more normal, you know right where the branch is. And so a lot of this is really integrated from a case planning standpoint to make things much, much easier. Other comments for Larry or colleagues?
Well, I just want to underline that basically in one image you have MLD, so you have morphology, length, and diameter, and it seems like straightforward, but in the cath lab when you're performing procedure, having all this information in just one image, it helps in speeding up the procedure, I think.
Just a question for Kevin is that do we plan to cover the first septal branch, because you have two septal branches going to the right coronary artery, and are you obliged to cover the first one? Are you obliged to cover the first one or not?
So I'll try to, it's hard to get an OCT to run slowly on PowerPoint, as you probably know, but let's look at that question. The septal is right here, and so I'll try to get it to pull back slowly. And I think to Garon's point earlier, in terms of integrating normal, you can land here, I think, reasonably. It's reasonably normal versus maybe pulling back a little bit and getting to more normal. So if you're a CTO person that's saying, hey, I want to preserve that first septal for retrograde access to do the right later, it's certainly reasonable to say you're going to land right here. Can everyone follow that? Mm-hmm. As opposed to what I chose to do is to get to a little more normal by going proximal. And this is where I made my measurement. And this is actually the measurement I made for an approximated EEL, because the EEL was not visible because of the extreme amount of atherosclerosis. So this measured to about a 375 by 290-degree views. I'm getting 367 and 4.0. But you bring up a great point, because as much as computers may replace some things in medicine, this still takes a little bit of judgment. You're judging access of the septal for the right later versus getting to a more normal segment proximal. That's a very good point, and I think a nuanced part of how you could plan this case. Excellent.
One more question from Francesco, and then we really need to go through the procedure.
So, according to our experience, where there is no healthy vessel, like here in the proximal part, the safest landing zone is represented by an area where there is no huge plaque burden and a round-shaped lumen, because when you will arrive with the stent, you will be able to perform, let's say, a POT that allows you just to oppose the stent to the vessel wall. If you have oval shape and similar minimal lumen area, you take the risk to have a huge malapposed or risk of dissection.
Yeah, it's a great point. And I think especially in the proximal LAD where it tapers a lot, so thinking about pot, balloon tapering length is important. You can look at getting to this segment where the EEL is visible. You might say that you want to put in a 33 millimeter stent because you like this landing zone better. It's more normal, it's larger, and there's more EEL visible. So these are the kinds of conversations we have in in-case planning. It's normal landing zone versus length of stent. All great points.
Kevin, should we go through the procedure, because we are almost at the end of time? Sorry.
Perfect. Quick OCT look at the diagonal. I'll get through that quickly, just to know that we planned the case there. There's a little bit of chatter initially. I'll skip through to show you the plaque at the ostium of the diagonal. It's quite substantial. So our MLD guided case was the LAD lesion was about 25 millimeters long. We measured about 4 proximal, 3.5 distal. The diagonal sizing was 275 based on the OCT, and the lesion was 18 millimeters long. So our MLD wax workflow is a 2.523 in the diagonal posted to 275, and a 3.528 in LAD posted to 3.5 distal, 4.0 proximal. The nice thing about image guided is you can actually make all these decisions and do a lot of it without taking more pictures. We took a DK crush strategy. I know there may be some difference US versus out of US. I'd be interested in colleagues' thoughts about that. We pre-dilated the diagonal. We pre-dilated the LAD. I took a scout angio to make sure I hadn't extended any dissections. We went ahead and put a 2.523 in the diagonal as shown here, 7 French radial with a crush balloon present. Put the diagonal stent in, took a scout angio to make sure there was no distal dissections, crushed it with a 3.5 balloon, rewired the diagonal, opened the strut with a Takero, did a 2.5 NC in the D1, a 3.5 NC in the LAD, kissing balloon inflation per standard DK crush protocol, 3.528 in the LAD. I did cross the septal, to colleagues' point about the fact you could have gone a little bit more distal, but you'll see there is some moderate plaque there. Stent deployed, scout angio there. In this particular case, I wanted my fellow to learn how to use a Sasuke recross. You didn't need to do that because we did pot, but effectively there's a Sasuke dual lumen microcatheter to make sure we're center lumen as we access. I had more than enough room to pot, obviously, in this particular case. Takero to open the struts, 275 NC high pressure in the diagonal, 35 NC high pressure in the LAD, kissing balloon inflation, 4.0 pot. How did we do? Post PCI of the LED is shown here. There's a small intimal dissection proximally, not clinically actionable. Quite tiny, right there.
Yes.
Yep. Apposition is shown by this apposition indicator. I know it's excellent. You can check it. Our expansion is 98%. Minimal stent area is 98% based on the tapered mode using the OCT. To Valeria's point earlier, the lumen profile in about 4 seconds, you can get a very quick assessment of how you did. No major dissections, excellent apposition, good expansion. We made a similar assessment of the diagonal. The pullback is here in the diagonal. You can see we've got relatively good sizing and no distal dissection. It calculates it at 96% expansion. It's a little tough for the computer to do this because it goes from a big LED into a smaller diagonal branch. Good expansion, good apposition, no dissection. This is the 3D bifurcation view, which is present in AptiView. I have a video of it, and you can see the co-registered angiogram. This is really cool. You can actually take this, go back and forth. You get the co-registered angio. You can see how your stent struts look, and you're able to actually interrogate the work that you've done quite nicely. This is a fun feature that we've been using in the past couple cases. So this is the final angiogram. Our Circ CTO I decided to do staged, and question about DAP duration. I think that was brought up earlier, I think by Valeria or one of our colleagues. It's nice to know that you have a well done image guided PCI. So if this patient with GI bleeding doesn't need to be committed to ultra long dual antiplatelet therapy. So one of our colleagues points earlier, this is probably an integrated wire escalation CTO. We did an OCT guided Circ CTO PCI about a week later, had a nice result, good expansion. And I offered to do the RCA, but both the patient and the referring physician said she felt so well, she never came back for it because that had been long-standing, to a colleague's point earlier, and she felt great with the work that we'd done. So thanks for giving me the opportunity to present this. I'd be interested in questions. And I think just for my learning, culotte versus DK crush, I know there may be a difference. Please educate me on your approach because I'm interested in how colleagues that are so expert there would have taken the stenting strategy for this particular patient. Thank you.
Yeah, thank you, Kevin. It's really fantastic case, challenging case. I like to ask Eve, what would be your strategy, culotte, DK crush, or simple provisional? Yes? Provisional and then probably kissing. But we don't focus here on the specific stenting technique. I think it's very impressive, the whole workflow, starting from risk evaluation, discussion of the individual surgical versus PCI risk, and then I think the best decision in the interest of patient, stage procedure, LED diagonal, and then the Circ. Anything to add, Valeria?
I think that was an excellent case of how to plan and optimize the procedure. And I think that's also contribute to our discussion about consideration about depth, because if we optimize the procedure in a high bleeding risk patient, we can probably be safe with the abbreviated DAPT duration.
Thank you very much. Kevin, great case. We wish to have you in Europe for the next EBC meeting with more experience with Ultrion. It's really impressive. I enjoyed very much your demonstration, and I like that 3D bifurcation view is back in the Ultrion too. So have a good day, and greetings from Warsaw.
Thank you, my friends. Be well, everybody.
Thank you very much all. A well-deserved coffee break.
They have for the FFR, but not for the IVUS problem.
General information for this evening, pickup is from the lobby at 8 o'clock. Please spread among everyone. 8 o'clock in the lobby.
Ladies and gentlemen, very welcome to this very hot topic, I think. Now we have lots of data, we need more data, but according to this study, we will see what the fact we have and what is news which we will achieve from this EBC meeting. So we can start, I think, with the first yes. That is Jacek Legutko. So is it better angio or intercoronary imaging guiding procedure?
It seems to be the easy job for me after the previous sessions and previous discussions to convince you that intravascular imaging is indispensable for achieving optimal result of bifurcation treatment. But it is never easy if you need to debate with Yves Louvard, who is the master of research and education in bifurcation treatment. So I will start with simple things and the rules which were established how to treat bifurcations within the European Bifurcation Club. Keep it simple, understand and the original bifurcation anatomy, optimize function and flow, and to limit the number of stents. And it's easy, we know that, but if we go for the reality and when we use only angiography, it is quite difficult to appropriately assess the vessel dimension, to assess the stent size, balloon size, as well as to know about the plaque distribution and morphology. And of course, if we use intravascular imaging, it becomes much more easy. We can appropriately assess all those parameters which are necessary to perform so-called optimal angioplasty. And we can do it both by intravascular ultrasound and by OCT. And it was presented during this meeting in different lectures. What is very important for me is the underestimation of calcifications by angiography. We have discussed how it is possible that we achieve optimal results so early, in so low number of patients. I mean, stent expansion in angio guidance in Illumin 4, it was 25%, in OCT guidance 40%. Even with intravascular imaging, we probably underestimate, and we need to be much more careful in this, and we should be much more careful in appropriate lesion preparation before stenting, and I believe intravascular imaging is exceptionally helpful for this particular reason. However, what is most important afterwards is to check for optimal result of stenting. Angiography very often is not enough to assess this stent expansion. Of course, you can use stent enhancement systems, I believe that what you really need, especially for complex cases, is intravascular imaging because it will tell you not only about stent expansion, but also about what happens at stent edges, the most important reasons for stent thrombosis, undiagnosed dissections, not covered plaques. We can see also with intravascular imaging protrusions. We can see stent malappositions. And we can also diagnose what is very often missed by angiography only, so-called stent deformations. When they happen, of course, they increase the risk of MACE, and in fact, especially in left main, the presence of stent deformation is one of the major predictors of MACE at follow-up. So we all know that, and it was discussed also during this meeting, but the most important are data. And of course, for left main, for many years, we have collected a lot of registry data, and the meta-analysis is showing us better survival after imaging-guided PCI in comparison to angio-guided PCI. We have less myocardial infarctions, less stent thrombosis, less revascularizations. Of course, there was a debate. Those are only registry data. This particular registry was not included in the meta-analysis. However, the results are absolutely the same from the British registry. We have, again, mortality benefit with the intravascular ultrasound optimization. And what is most important, because this we discussed many times during EBC and past editions, that, of course, experienced operators, they do good enough job without intravascular imaging. Here we see that the most advantage of intravascular imaging guidance for left main PCI was present in the lesions treated by most experienced operators, probably also the most difficult lesions. And nowadays, we have the randomized trials, which were really necessary to finally decide on what on use or not to use intravascular imaging. First, Renovate complex PCI trial dedicated to complex lesions, published at New England Journal of Medicine on April, and then dedicated trial to bifurcations, to complex bifurcations, October trial. Both of them were positive, so we can say now that we have randomized trials. And what is most important, and was also presented by Greg Stone, this network meta-analysis based on more than 10,000 patients showing us that with intravascular imaging we can significantly lower the risk of cardiac death, all-cause mortality, more than 50% reduction of stent thrombosis, and also reduction of target lesion revascularization. It seems like there are no differences between OCT and IVUS. However, this is the next debate, so I will not touch it. Let me go for a while to another field, heart failure field. And as you are aware, 2 trials on the use of fluosin in heart failure with mildly reduced and preserved ejection fraction were published in New England Journal of Medicine 2021-2022. Both were positive according to the primary endpoint, which was death and rehospitalization due to worsening of the heart failure. In fact, there was no difference in death. Most of the benefit was related to the lower risk of rehospitalization due to worsening of the heart failure. And what happened next? It is amazing that the group of people concentrated on that topic decided to release just 2 years after the publication of the Heart Failure European Society of Cardiology guidance, the update. And it was really difficult even to enter the room in Amsterdam. Thousands of people were interested to see this document and to acknowledge this, that after publication of these 2 studies, both fluosins have now class 1 indication and should be used in all patients with heart failure with preserved ejection fraction and mildly reduced ejection fraction. Today, we are at European Bifurcation Club, and I believe that taking into account all the arguments, and especially the new research which was published this year on the topic of the use of intravascular imaging, we should really acknowledge that intracoronary imaging is indispensable for achieving an optimal immediate and long-term bifurcation PCI result, and we should really advocate for class 1 indication for the use of these devices. And please don't worry about the cost. The cost of the IVUS or OCT catheters nowadays is the same as the cost of only 1 year treatment with fluosin, which are prescribed for life to our patients. Thank you very much.
Okay. Please, if you have the more difficult part of this controversy.
Sorry, I need some put my glasses. Okay, so my talk is there. Yeah, so first, dear Chairwoman and Chairman, thank you very much for inviting me in this controversy. The title of my presentation is Intracoronary Imaging is not indispensable for achieving optimal bifurcation PCI result. After multiple publications on this topic, including 28 meta-analyses between 2007 and 2023, we are invited to see today 3 big randomized trials showing that intravascular PCI guidance is better than angio guidance and so justifies the cost of the product. Here we go to Element 4, a big trial published in New England Journal of Medicine. Element 4 is a very big trial comparing OCT guidance with local standard practice. Remember, angiographic guidance. Here is the primary and back. So it's black. I have to put the lumen. Yeah. Okay. Back. Yeah. So here is the primary. No. Illumin, it's here. Illumin is very, very big trial comparing, I said that already. So here is the primary endpoint, as you have seen, cardiac death, target vessel MI, and ischemia-driven TVR, showing no difference. The only primary endpoint, positive primary endpoint, is the difference in minimal stent area. And when you convert this area in diameter, this is 2.7 millimeter versus 2.6 millimeter. So OCT is not better than angiographic guidance. Is IVUS guidance providing superiority? Because this is the reference imaging, intravascular imaging over OCT guidance. We have also a big trial, Optivus, to compare OCT PCI guidance versus the IVUS reference. 1,000 patients in each group. A follow-up at 1 year, and as it is a non-inferiority OCT trial, here are the results. Yeah, sorry. Oh, here is the result, which is absolutely showing that OCT is non-inferior to IVUS. So maybe the failure of showing something positive is related to the fact that most of the lesions were not bifurcation lesions. So if we look at the specific bifurcation lesion, maybe different because this is more complex. Why is it more complex? Because there are 3 diameters. October trial is October trial is a dedicated trial to coronary bifurcation lesions. A big trial again, 1,200 patients, 600 in each group, and comparing OCT guidance and angio standard guiding. Remember standard guiding. And the result, no difference. And no difference. There is a clear advantage of OCT guidance in terms of usual primary endpoint at 2 years. What is the standard of care? What is the standard of care? They said standard of care of OCT guidance in terms of What is the standard of care for bifurcation stenting if you don't have intravascular imaging? Can you stop the automatic slide, please? So on the left you have this Opus trial. On the left you have a phantom on the left with a defined lumen area. Then you have the same phantom measured by OCT, which is exactly the same area as in the phantom. IVUS is oversizing. On the right, this is diameters. Well, you can see that IVUS is oversizing the result of OCT, which is the reference, by 9%. Stop it, please. Go back. 9% of their sizing, and angio is 5% undersizing. It's easy to understand and to remember that if you measure with a dedicated QCA, you add 5% and you have the diameter. Then we are going to, this is the work of my associate, Thomas Ovas, published in 2013. He's telling us that when you are expanding your stent, and at 14 atmosphere, there is a difference between 5 seconds versus 25 seconds. And the difference is 0.2 millimeter. 0.2 millimeters, stop it, please. 0.2 millimeters is 200 micron. 200 micron is malapposition, yes? So you can avoid that. Second point, the balloons are elastic. This is ideal to deploy a stent at the diameter you wish. So this is the curve provided by a company. First inflation, you saw that the diameter is under the provided curve. Second inflation, this is overlapping the provided curve. And a third inflation, you have oversizing of the balloon regarding the provided curve. So it means that in Massy, since that times, we are always inflating 30 seconds and at least 2 times 30 seconds. Easy to remember. And when you look at this, I have to change my place. Knowing this, you can select your balloon for QCA from QCA using the 5% supplement. In case of diffusely diseased segment, like here in the left main in the middle, you can use a formula that was given us by Gérard Finet. You can calculate the true diameter of the diffuse disease in the left main. This is also easy to perform. Sorry. Now, stent enhancement, especially with injection, is helping you to oppose the stent. And it is said by Akiko Maehara and Gary Mintz that there is a very good correlation with IVUS. So we have an IVUS. And finally, you have seen this morning, pot puff. So you inflate a balloon in the position of the pot, and you look if you have some contrast is going on. It is on the right. On the right, you see that the contrast is not going on. So this is blocked. Not on the right, sorry. Is blocked. So when you inflate your balloon, you have no contrast crossing, you are well opposed. You can use also this technique when you deploy a stent as a crossover. You block the distal bed, and you see very well the contrast going to the side branch. You see the position of the carena. You see the risk of a closure with the carena shift. So, were these tips and tricks recommended in the angio arm of Illumen 4? I remember that the cause of absence of difference in Illumen 4 was related to the COVID. The operators were not taught properly for the treatment, but it was the same for the angiographic guidance, you know. So what is the recommendation for OCT and angiographic guidance? OCT a lot, angiographic guidance not a word in a supplement, not a word. If you look in October, you have the description of the steps of OCT guidance, not a word about a guidance with QCA. So for me, October is not a fair comparison between angio and imaging guidance. You have to redo it. Thank you very much. Sorry. I'm sorry. I forgot what Francesco sent me. He sent me something very interesting. It's another trial coming from Korea again. It was in a small room in Amsterdam. So the hypothesis is visual guided PCI remain largely unchanged over 40 years, despite many limitations. We hypothesize that the QCA guided strategy with incorporation of lessons learned from IVOS, I would say OCT, I would say simulation, I would say bench, may help to optimize the stent deployment and offset the benefits of IVOS guidance. Here are the receipts for QCA guidance for IVOS guidance. At the top right, you see the correction of the QCA diameter measured. It's not a dedicated QCA. Dedicated QCA solved the problem. And in this trial, bigger than October, there is no difference. It's the same endpoint. And you will say, this is not a bifurcation study. No, there is only 2/3 of bifurcation and 50% of left main. So remembering lessons learned from bench, QCA, IVUS, or CT and simulation, intracoronary imaging is not indispensable for achieving optimal bifurcation PCI result. Thank you.
Thank you, Jacek. Thank you, Yves. So I have two questions. One is to who, and the second one is whom, to whom. So there is a lot of problem how to read the results with OCT. So according to the first question, who is the expert who should read the OCT and after how many procedures? And the second one, to whom? So which means, should we use this IVUS or OCT to every kind of bifurcation lesions, or to complex lesions, or to left main, or to some LAD diagonal branch? Which kind of lesion is really target for the OCT or IVUS? So let's discuss.
So may I answer that? I think the way to improve the deployment of the stent, they are known since a long time. Gerard Finet formulas, we know since the beginning of the meeting. The plastic nature, not only elastic, but plastic nature of the balloon, which is increasing in diameter at each inflation, is known since for 5 years, maybe more. And stent enhancement, especially with injection, is known also. And the pot puff is certainly new, and it can be used not only in the pot, but also for crossover stenting. You know that the distal main segment is occluded, and you look at what is occurring in the side branch. So you can manage the inflation of your stent. You know, it's easy and very quick, and it's very easy to perform. So I think with this, and the QCA, modification of QCA, we know that QCA is giving a diameter which is reduced, and we have some explanation for that. It's a bit complex, so I won't spend time on this. Of course, it is better with dedicated QCA, because dedicated QCA is giving the true diameter immediately proximal to the side branch, and the true diameter immediately after the side branch, distal to the side branch. If you do the regularly tapering vessel model, then the diameter proximal to the side branch is reduced, the diameter distal to the side branch is increased artificially. This is not the good one. You have to know that this has been repeated and repeated and repeated in this meeting.
Maybe I can give the direct answer to your question. For me, definitely all left main PCI procedures should be done with intravascular imaging guidance. There are no doubts about it. And my other indications are also complex bifurcations, especially in calcified lesions and especially in patients at high bleeding risk that I need to achieve really optimal result. And I believe that this discussion is really important because I didn't touch, within 7 minutes it's not possible to tell everything what you want to do. But the most important problem which we face in interventional cardiology is that especially in patients with chronic coronary syndromes, all the trials were not positive for interventional cardiology. Those dedicated to heart failure, patients with heart failure, we have ischemia results, and we have ongoing debate to do revascularization or not. And I am really sure that if we want to convince people and really help our patients, except of treating their symptoms, but just to improve their outcomes, we have to do optimal procedures. So it means that if we have so many data, if we have this meta-analysis showing us that with intravascular imaging, we can improve survival, we can improve, lower the risk of stent thrombosis, lower the risk of TVR, we should use it more liberally. If we use it 10-20%, then it means that on country level, like in Poland, we have full reimbursement for intravascular imaging for the last 6 days, and on country level, still it is 5% of the penetration. Of course, there are centers doing it with 30, 50%. The same happened like 15 years ago with radial approach. First, centers were using, and they were convinced, and all other centers, they were using only a limited number of cases because they trusted in femoral approach. Then the data came on mortality benefit, and we switched. We use in the CAD lab those methods which we use routinely. If intravascular imaging is not a routine, it would never be used in more than 5–10% of cases. This is my answer.
Okay.
Some comment from the. I have another one. This is the last, and this is the worst. I'm very sorry. I'm very sorry, but you remember in syntax, we are speaking about syntax. Yeah. In syntax, in the world, there was one country with non-inferiority to surgery, and it was France. This is the only country where we were non-inferior. And it probably was related to the quality, not only the quality of our surgeon, with a very high rate of arterial revascularization, but also by the fact that we were understanding the 3 diameters and preparing the treatment with 3 diameters. And in our group, sometimes some IVUS were performed, and it was recommended for the beginners, the newcomers in our group. But after that, we learn the lessons, and we don't need any more.
Let me remind you that in the syntax trial, the penetration of intravascular ultrasound was only 5%. And we took it into account, and Professor Sirois established the syntax 2 trial with 85% penetration of intravascular imaging. And as you know, the risk of MACE was more than 50% lower, and the mortality was close to 40% lower in the publication. Of course, it was not the direct comparison, but it is a strong signal that with intravascular imaging, we can really improve outcomes of our patients.
So if I like to comment that manual cars are doing very well, but automatic are better. And still manual can reach 130 kilometers, but automatic is the beauty of the eye is that it gives you details, and so some cases, of course, you cannot generalize to every place. I come from a country that it's reimbursed, but only in limited cases. So like left main, you don't estimate the size. You need more details about that. But if it is going to make you to slow your pace, for example, in acute cases, you don't have IVUS immediately, and the case is acute, then you don't need to do it. We still do it, but of course, perfection is demanding.
May I answer to this about the amount of reimbursement? So, to the audience, if you don't have IVUS on OCT, are you following the rules? The rules have enumerated. Did you know these rules? Are you using them? Standard announcement with injection, correction of the QCA measurement, dedicated QCA if you have, that's okay. Several balloon inflation. Several balloon inflation. Not 5 seconds that we hear in many live cases. We see on, we hear on. And 5 seconds later, click, it's finished. This is the malapposition. 200 micron was shown on my slide. This is malapposition. If you inflate 3 times 30 seconds, your balloon and your stent are on the wall.
Well, one more comment maybe. We also were part of October study and including 120 patients, and I can say we learned a lot, although we have quite experience with bifurcation starting with Nordic 1 from 2004. So, and yeah, and I think other point is also if you are doing quite a lot of imagings, it helps also you in case where you don't use imaging, you have better understanding, and so.
Yeah,
so.
Of course.
Yeah.
Okay.
Well, I think the question is, does intravascular imaging help most interventionalists improve their outcomes in bifurcation lesions? The question is not, does it help every interventionalist improve outcomes? So I think we have to go for the majority. But I think the training's really important because the October trial had a lot of training in it. And perhaps it was the training that was really important because just putting an imaging probe in a vessel doesn't do anything. It has to lead to a result. So I think the training has to go along with the use of the intravascular imaging. And that's the important thing that we need to do.
That was my first question. Who should perform IVUS or OCT? After how many procedures?
Eve, I'll just ask you, I think that one advantage of OCT is especially looking at very eccentric calcification kind of hanging down from the roof of the vessel wall, which I don't really appreciate from the angio, but I do appreciate that from OCT. What do you do in those cases when you just...
Are you doing 100% of OCT?
It's not a lot. I agree with
not. So
your point
please answer
well
me.
taken.
Please answer me. So you use QCA, or if you use angio. Maybe you use angio without using QCA. If you use QCA, do you make a correction? Have you a dedicated QCA? Yes or no?
No.
No. So you make a mistake. You have to correct.
Your points are well
taken.
taken.
You have to correct. Normally you have stent enhancement. For sure you have stent enhancement on your machine.
Yes.
Yeah.
But
injected stent enhancement. You see the wall, you see the struts.
Correct. But I don't when
and
I have
puff, you know the pod puff?
When I don't have when I have very eccentric calcification, I can get stent apposition at the calcium, but not at the sides, at the shoulders of the calcium. That I do not get. And I can only see that with OCT. I understand it's not a lot of patients.
To all of you who don't have intravascular imaging, please use the simple rules. They will be on the site of the EBC soon.
One comment about pod-POF technique, because it was described many years ago during live cases as a IVUS for poor people.
So we are poor people in France, we are not people.
Thanks. May I see the result of the poll? So, if no. You obtain an acceptable result.
This is significant.
Okay.
So if not Eve, it would be 90-10.
Okay. We have to move for the next controversy. Is OCT versus IVUS. Is the new gold standard for bifurcation intervention? The first speaker is Peter. Peter, whenever you want.
Thank you very much. And I think Eve did pretty well, actually. That's pretty impressive. So can I get my slides up? Great pleasure to be here, friends, ladies, gentlemen, chair and panel. I think it's 1-0. It's always good to go in at half-time 1-0 up. We like to win these things. I've always lose debates, so I think I'm going to win this one. And I'm a simple guy. Okay, I'm not going to give you a whole data tranche. I want to just tell you why I think OCT is really good and what it brings to the table, literally to the table. In my centre, we have access to all imaging devices across a range of different vendors. They all bring things which are unique to bifurcation PCI, and I think they can all have a role. But we've been discussing this all weekend, and I think the sessions have been really fascinating, and you've heard from a variety of different speakers. And in my opinion, it's fairly clear that in 2023, OCT is the really choice imaging catheter we should be using for bifurcation. So that's what I want to tell you. I'm going to share that with you, and we're going to beat IVUS in this particular case. Okay, just today. So when we do imaging for our bifurcations, we're looking obviously to get very accurate measurements. You can use QCA, but I think imaging is better. Lesion preparation, that's key to any success in all PCI, and you get it much better from imaging and better from OCT, as I'm going to tell you. Measuring the pot, making sure there's no abluminal wiring, checking where you're crossing, these are crucial things, making sure there's no carnage at the end of the case, and getting numbers at the end of the case that prove you've done a good job. So if we take the first one, or the first three, so this is a recorded case, very fast for you, but just shows the workflow. Co-registration, massive advantage. This is app to view, it's old software now, but it's simple to use. This is really easy. This was a calcific LAD lesion involving a bifurcation with a diagonal. A lot of it calcification, as you can see. You can't see this on the angiogram, not so clearly. We've already done orbital atherectomy in this case, so it's required a bit of modification. But you see, simple workflow, all done with a handheld control at the side of the table. It is speeded up, but it still takes just a few minutes. Fractures there, calcification still present. Move on to IVL for this case, because that's what we would do in this sort of situation where we've got deep, thick calcium. You can't see it on an angiogram, and I don't think IVUS is as good. What about where you've crossed? Can you see that on angiogram? Definitely not, but on IVUS, no, not as good. Here we've got a proximal cross in a provisional case. We don't want to do a balloon or kiss there, it will damage the stent, and maybe that's why the trials of kissing without imaging are going to be neutral. What about the mistakes that can happen during PCI? We all make the mistakes, but you can see very clearly with the enhanced software, if you've cleared, the pot's very good, but sometimes you need to kiss, and you get a really nice side branch appearance. You can see it all with OCT. You won't see it so well with IVUS. And what about this? When you've put the stent in and you've optimized, here's back to that same case. There's the stent. Within seconds, you can see it. The stent expansion's great. It's about 80%. It's good enough, particularly with calcium. We can measure the distal dissection. We can look at the proximal edge. It's all very clean. We've landed in very healthy tissue. This stent's going to last a long time. It's done well. We can focus on the bifurcations. You're going to see in a second. We can toggle up and down. It's really nice workflow. We can see where the bifurcation is. We can see what the ostium looks like. We can decide whether it requires any more modification, any modulation. We can look at this, the 2D images, moving back and forth. And you can see I've got Helen with me, helping me. This is she's doing the case. And together we look at this and both say, this doesn't need any work. It's fine. Great job. Leave it alone. And that's really good, insightful. So let me take you on this journey. This is a more complex case. This is the left main bifurcation. Now, provisional, I use a lot, but in this case, I think we've got some criteria here for a 2-stent bifurcation strategy, and I think from definition criteria, it meets probably DK crush is reasonable. So upfront atherectomy, because there's clearly angiographic calcium, it's too tight for an imaging catheter. So we perform that first, and then we use some kissing balloons just to create some space, and then we can adjust. Now, this patient gets randomized in October, as Niels and Evald have shown you, great result. So this was a simple thing from October. What's going on with the first runs? What about your lesion preparation? What about the vessel? Get some measurements, work out where you're going to be landing your devices. You get all that information. But have we done enough with atherectomy? No. There's still loads of calcium. It's deep, not modified enough for a 2-stent. We've got to go and do some more. Pick any algorithm you like. This is one that's published, ICR3. We go back with Shockwave. That creates a really good expansion. We go back then with our OCT as per protocol. We check it's adequately prepared. We're ready now to think about stenting. A lot of work's gone in, a lot of runs, but we know what we're doing. Stent to the circumflex. In our normal crush technique, we're going to crush that out of the way with our balloon. After we make sure it's properly expanded, we may have to go back and do that. And then this is a crucial step in the DK crush, as you know, the pot. Because if you don't properly crush it, you're going to wire back in the abluminal in a different spot to where you want to be. Dual lumen catheters, we use these extensively throughout October, even in the angiographic arm, because we didn't want to, as the next phase was to make sure we knew where the wires were. So that was tricky, and as Niels has shown, it's not always so straightforward in real practice, but we got better at doing it because they were teaching us as well. Then we're ready now, after our first kiss, to go in and put our main vessel stent in, choosing the right platform. Again, key steps, really important. Doesn't matter whether you image or not, but this is important stuff. And then you do another pot, of course, and then we have to go back. We have to rewire again with dual lumen, and then again using our OCT to check our wire position before we can go on and do our final stage kiss. So quite a lot of steps, a lot of OCT runs, catheters getting a bit fatigued. But now we're at the point now where we think we've finished. We can do this is the third step to really understand, have we got really nice result. We've done LAD, we've done circumflex, all looks very good, nice expansion, nice carina. I think we're pretty happy. We're looking for any kind of damage, any longitudinal stent deformation. There you go. For 4 key things, these have all been mentioned today. They're really important, and you get it all with OCT. Really straightforward. The data's there to support it. That's the final result. It improves outcome. Why aren't we using it? It's the key technique. Technical superiority, first-class unique data, and refinements to the technology that's going to make it better and easier to use for the majority of operators. All the information on one screen. Very, very simple. I like to travel, and I've got different ways of traveling. But when I'm here at EBC, I'm rooting only for one team today, of course. And I'm a pleasure to be here, and let's watch the rugby later and celebrate. OCT is going to win.
Cool.
Okay, so that it's very hard to say no following the Peter's elegant talk. Okay, so I think this question is very relevant to me because that my personal usage of IVUS versus OCT in terms of intravascular imaging is IVUS 99%. So basically, I'm the IVUS person. But while preparing this talk, I'm thinking about what's the beauty of OCT over IVUS, and you know that in terms of luminal visualization, plaque vulnerability, short level resolution, clinical evidence, big, beautiful randomized trial. So I've almost converted to OCT while preparing this talk. But today's my duty is to defend the IVUS, so that let's just one by one. So this same reason, OCT, IVUS, so you will easily recognize that OCT is better. So we should use OCT rather than IVUS. But the question is whether I need to convert to the OCT from IVUS. But personally, I feel that the IVUS can provide us enough beautiful information for bifurcation PCI, not only luminal narrowing, but it can provide us a very important element in terms of amount, character, and distribution of plaque. And this plaque information is more important for the bifurcation PCI because that the luminal narrowing mechanism is different between the non-bifurcation and bifurcation PCI. And for this side branch lesions, two lesions, one is plaque, mainly plaque plus positive remodeling, and the other is small plaque plus negative remodeling. Of course, the specialist can recognize the vessel, but it's not a usual one. And for this case, can you click this video? Okay, may not working, but this illustrates this is pure negative remodeling case. Of course, that this can be also recognized by the OCT. So that in terms of lumen visualization, OCT may be better, but I can defend IVUS while saying that the IVUS can also provide enough information, at least to me, and even better in terms of the plaque characteristics and plaque quantity. And OCT is very famous for its discrimination ability for TICFA or plaque vulnerability, so that again, the same cross-section OCT IVUS, you see that the beautiful images of OCT, cap thickness, and lipid arc, so that you can discriminate TICFA or not. But again, we have to understand the importance of plaque itself as a vulnerable feature. You know that Prospect 2 trial, in both trial, not only the lipid amount, but the plaque amount was the key element for the plaque vulnerability or patient events. So that I don't want to bother you with this complicated slides, but the one thing I'd like to mention is this is the features we've analyzed in terms of plaque vulnerability while combining all the quantity and quality metrics, and we found that the quantity metric is more important in terms of plaque vulnerability assessment, so that the plaque quantity really matters. So for plaque vulnerability, OCT may be better to define TICFA, but while plaque burden, which can be better assessed by the IVUS, can be at least non-inferior vulnerability feature. The other thing that cannot be beaten by IVUS is that the strut level OCT-guided bifurcation PCI. So we've seen beautiful images from Peter and our Japanese colleagues, so this cannot be done by the IVUS. But I'd like to raise this question that those struts really matter in terms of clinical outcome. So I really have this question several years ago, and that's the reason why with this simulation model. So in this slide, as you can see in the right side, we made two models. One is strut obstructing the ostium of side branch. The other is a perfect side branch angioplasty while leaving no struts there. So we worried about that low osseous area, but we know that the FFR flow reduction, that strut does not make a big matter. But it is interesting to see that when we calculate the percent area of low osseous stress, there was no difference while having some struts there and having those struts there, because that this osseous stress, low osseous area and flow disturbance is mainly determined in the main vessel area, not the osteostrut area, and this was also assessed by the other studies. And as you can see here, side branch contribution on the total low osseous area is very minor, so that strut doesn't matter in terms of clinical outcome. And that's the reason why in this very large sample size, 5-year follow-up, even though this is not a randomized study, side branch opening was not translated into the clinical benefit in terms of leave it alone strategy. And finally, evidence. We have a beautiful October big randomized trial, but we also have a great number of meta-analysis results, even though this is not specific for the bifurcation and also the no randomized trial, but the decent number, more than 6,000 and around 5,000 meta-analysis results. And we also have almost 10-year follow-up results. So when we think about all these metrics, I should say that I have to convert it to the OCT because OCT is better in terms of all these elements. But when we think a little bit more, my answer is still no, even without talking about contrast. Thank you very much for your kind attention.
All right. Thank you very much, both of you. So I'm a real OCT girl. So I perform OCT a lot. I'm better with that than with the IVUS, and I go sleep better after some procedure when I perform OCT. But I still have some confusion about it. Even in this great randomized trial, only in 20 to 80% the great target, the main target were achieved. So do we need another measure which will be gold standard to achieve in this OCT procedure or not? This is a question for Dr. O'Kane.
Sorry, could you just give me a summary of your...
Do we need another measure to achieve in this OCT procedure? Because in this study, it was achieved in 50%.
Yeah,
in some another 20 to 80. So what is good? What is great? What is good enough?
Yeah, I think, I mean, the challenge in doing randomized trials with any device is the operator experience and operator skill set. And I think this is why we see such variance in the results of all trials. And I mean, the team who put October together, I think, did an incredible job to actually get everyone trained and give constant feedback to make us better at doing what we were doing. But despite that, there was still a lot of protocol non-adherence, particularly in the two-stent group. And I think that's a consequence also of the hardware. The OCT catheter often kind of gives up after about 4 or 5 runs. And some of these cases, you had to do many runs. So I do think that we probably be nice to try and streamline and perhaps there'll be more insights into how we can do this in a more, less runs, more systematic. What are the key features of the technique with imaging that gives us the benefit? And I don't think we know that from the results, but we may find out.
A question for both. Do you think that the left main or not left main bifurcation can change the technique to evaluate the bifurcation, OCT or IVUS, or IVUS and OCT is for both?
So for generally, we know that for osteo left main, it's difficult to be assessed by the OCT, but we also know that the OCT specialists can do beautiful work with the left main procedure with OCT, so that I think that except for left main ostial lesion, but there's no big difference between IVUS and OCT in terms of feasibility.
Yeah, I agree. I mean, I think the ostium is still, it's still work in progress for OCT in the sense that you may get away with it sometimes, but you may not see that very proximal strut, which you could have deformed. Obviously, the core lab has all that information. So, I think IVUS is probably easier for those ostial lesions.
Just a small point. Preparing the meeting, I have seen a paper by Patrick Sarri's team where there was a mixed catheter, IVUS and OCT. Maybe it will be a good solution for you.
So my question to Bon. So you said you are IVUS banned for a long time. So now there had been advance in IVUS itself. It is not like 10 years ago and 5 years ago. So what before and what now is the percentage that you did IVUS and still you need to do OCT? And the other thing, for Peter, do you think that having 5 modalities that may also make you confused, or you have a standard that you do the routine work, you better rely on 1 or 2? So this is my question.
Yeah, so I agree that the IVUS has been stationary for several decades, but now it's evolving. Maybe it's stressed by the OCT appearance, but we have a high definition, 60 megahertz, and the fast pullback, and maybe it will facilitate the automation and co-registration, so that that will be helpful a lot for the IVUS lovers.
I have a question. Now there is a consensus statement by European Bifurcation Club and CTO. So there probably intravascular ultrasound in a CTO setting. How do you do an OCT?
No, you can't. I also have a question for both of you. When you look at a lot of the American trials, and also the American meta-analysis is done with operators that don't have that much experience. The average number of PCIs for an American operator is 40 PCIs a year. Now, not all do like in South Korea, where you do hundreds of PCIs a year, and in Europe but even in Germany, many PCI operators, they don't do that many PCIs. So what would you recommend using OCT or IVUS if you don't do that many procedures a year?
So I'll try and get all those questions in. So having a lot of equipment in your lab, I think, is quite useful. For me, I find it helpful because every bit of equipment has strengths and weaknesses, and I think certain cases you really want that information, i.e. things like co-registration. Sometimes very nice to have it. Some of the IVUS systems don't have it. Some IVUS systems are super quick. In the middle of the night during a STEMI, you can get it out, super done, get the information. You may only want just a vessel diameter or simple things. So I think that's how you can niche it. Then going up to your question about sort of how do you train, who do you train? I think the next generation, I think the equipment's going to be so good, like with Ultron 2.0. When you get all the information on one screen, people are going to go for that because it's like having an iPhone 15. It's just so quick and easy. You're never going to go back. Once you've seen it, and that's how you're going to learn how to do PCI. It's going to change the game. And then to your question about CTO, for me, CTO IVUS, because I don't want to inject loads of contrast. But you could do OCT, but I think IVUS is what I'd use in CTO. But luckily, this is a bifurcation, so we're okay.
Yeah.
Oh, okay, but you're making it hard now. No, I think I think you could use either, but I think IVUS I'd probably go for, to be honest.
Yeah. No, I agree with Dr. Dugal that in bifurcation with CTO, the injection may induce more dissection. So IVUS is completely more useful. No, in this context, I think the advantage of IVUS is clear. Do you think so?
Yeah. So that the Octavus, they have to exclude the renal failure patients, but I think it also depends on the level of experience, so that the OCT specialists, they understand how to manage the contrast amount, but the general user, I think it really matters. But I agree that in case of huge dissection, contrast injection may cause aggravation of dissection flap.
Yeah, but in general, in CTO, the number of injection is reduced because the jet can increase the dissection induced by the wire, by the wire, and by everything. No? Okay. Any other comments? So we can see the vote.
Yes.
The winner is Peter. Okay, so we can conclude, no?
So we can conclude at the end. Thank you very much, all of you. So I think the winner is OCT, but I really think that we need another measure, and that we need a concrete measure in the terms of a very point of bifurcation lesion in the terms of carina, on the terms of side branch, which is a real position, apposition, and where is the what is real good scaffolding. So I think that we are looking for that result. So thank you very much again.
Stop the music because there is no break actually, so that people can. Okay. Okay. So I know that have been a long day, but we have this very last session that is extremely interesting since it's focused on the news on left main. So,
hello everyone, and we can welcome Dr. Satoru Mitomo for the first lecture today, Definition Criteria Bifurcation. Thank you.
Thank you so much. Thank you so much for giving me this wonderful opportunity to present to our study. I'm very honored to be here as one of the presenters for this wonderful session. Today, I'd like to talk about the real-world data of the PCI for the definition bifurcation region. So first of all, let me share one case with you. 78 years old male presenting a stable angina. He had multiple coronary risk factors. Here now we have the hereditary bifurcation region, including the diffuse disease side branch with tight stenosis. So how would you treat this complex bifurcation region? Provisional strategy or systematic double-stent strategy? The definition 2 trials showed that for definition bifurcation region, the systematic two-stent strategy was associated with significantly improved clinical outcome compared with the provisional stent strategy. Well, what is a complex bifurcation region? The definition criteria consists of two components, major criteria and minor criteria. If a region had one major criteria and at least two minor criteria, at that time we can say that the region is complex bifurcation region. So this time we conducted New Tokyo definition study, which was retrospective observational study. We reviewed all the PCI cases performed in our center from January 2015 to December 2021, from 10,712 cases. After excluding these cases, finally we got 574 cases which met definition criteria, and then compared provisional versus systematic double-stent strategy. This table showed the baseline characteristics. Their comorbidity and medical history were well balanced between the two groups. Regarding clinical presentation, around 80% of cases with stable angina in both groups. This table shows region characteristics. More than 60% of our region were made in the 111, and LAD bifurcation were mostly included in both groups, but distribution of the region were different between the two groups. Moderate to severe calcification was found in around 1/4 of the cases in both groups. Regarding the procedure characteristics, it should be noted that intravascular imaging guidance was performed for more than 90% of both groups. And regarding the stent techniques, mini crash was mostly taken for the systematic double stent group. On the other hand, TAP was mostly performed in the provisional stent as a barrel stenting. Both with high pressure non-compliant balloon was performed at high percentage of the cases in both groups. And then clinical outcomes at 3-year follow-up, clinical follow-up, there was no statistically significant difference in TLR rate between the two groups, 6.3% versus 5.8%. Regarding the TVR rate at 3-year follow-up, again, there was no statistical difference between the two groups. In our study, there was only one diagnosed of MI case in the systematic double stent strategy and no cardiac deaths in both groups. After that, in order to adjust their background, we conducted the propensity score matching using these variables, and then we got 151 pairs. Even after propensity matching, a TLR rate at 3-year follow-up was comparable between the two groups. At this point, let's see underlying differences between the two studies. The original study was a randomized controlled trial, but on the other hand, our study was retrospective observational study. In the original study, PCI procedure was predefined, so the crash and curate was strongly recommended for the systematic two-stent strategy groups, and also there are some differences in the clinical and angiographic protocol between the two studies. If we look at the clinical outcomes, our New Tokyo definition study was longer follow-up period, comparable clinical outcomes between the two groups, and less incidence in both groups. How about the differences in the PCI techniques? As I already mentioned, the stent techniques were completely different between the two studies. Intravascular imaging guidance was performed at extremely higher percentage in our study, and both was equivalently performed in both studies. In order to partially explain why there was differences in the clinical outcome between the two groups based on the differences in their technical aspect, let me show you two representative cases from our study. This is a case of a ready to bifurcation region which was treated with mini crash technique. For this region, we put the two stents like this, and this is final angiography. And then 18 months after the index procedure, we performed coronary angiography for recurrent angina. We showed that significant restenosis at diagonal ostium. Then, if we look at the magnification, we can clearly appreciate the gap of the stent between the main branch and side branch, which was also confirmed with IVA separation. So we had a geographic miss, resulting in a significant TOR at the ostium of diagonal. And this is another case of the ready true bifurcation region, which was treated decay crush technique. For this region, we put these two stents with a decay crush technique, and this is the final angiography, looks pretty good. And then 24 months after the next procedure, we performed follow-up angiography, which showed still excellent result. And then if we look at the magnification, for sure, the side branch ostium region was completely covered with side branch stent, which was also confirmed with IVA separation. Actually, in our study, we had 8 TORA cases in the systematic double stent strategy, and 6 of them were associated with this kind of geographic miss. So actually, this is just a hypothesis, but if we treated this region with decay crush, at least we can avoid this kind of geographic miss, and maybe there might be the possibility to have a better clinical outcome in this systematic double stent strategy, but this is just hypothesis. So in our large cohort of real-world definition bifurcation region, we had comparably clinical outcome between the provisional versus systematic double stent group. High percentage of intravascular imaging guidance might contribute less incidence in both groups, even at 3-year follow-up. As systematic double stenting, decay crush might have advantage to overcome variation of complex bifurcation morphologies, including a bifurcation angle, the cell size discrepancy, or a certain plaque distribution around the side branch ostium. Thank you so much for your kind attention.
Questions?
From my part, congratulations, because that's a good clinical practice example. That's my opinion.
Some explanation, Dr. Sheban. Some explanation about the difference between results in trials and in registries.
Difference are based on retrospective study and randomized study for one side. The second is, as he underlined, that in decay crush, in definition, decay crush was systematically used in one study. In the other study, you have different approaches, which more probability of bias in technique. So I think this is the fundamentally what is the difference, why this difference between results.
Yes, I agree with you.
And do you think that the mini crash could have played a role? Because that was the favorite technique in your study as compared to the definition, right? And for instance, I correct me if I'm wrong, but I think I remember that in the October trial, for instance, mini crash was discouraged because you cannot be sure that you can oppose the carina, the stents, and guarantee a perfect scaffolding. Do you think that this could be also a factor influencing the discrepancy between the trials or the studies?
Yeah, so basically, in my opinion, especially for Japanese people, we thought that if we have the multi-rated stent strat, it should be worse. I mean, it can result in worse clinical outcome, causing restenosis and stent thrombosis. That's the reason why previously we performed much more mini crash technique. But as I showed you, sometimes if we have the shallow angle, it can result in a geographic miss. Also, it can lead to high restenosis and even the stent thrombosis. So now, after reviewing these data, and we have a lot of data, especially including the bench test. Now, I'm more comfortable to perform DK crash than me crash.
Okay.
You did a lot of imaging, and maybe you said it, the results are good because of that. Did you have many changes of your decision on how to treat regarding the imaging? Because on the first case that you showed, you didn't do the imaging, and you can see that there was a little bit shadowing on the ostium of the diagonal. So maybe because you did all those images, it changed your decision to how to treat. Not just the definition criteria.
Yeah, so actually, if we are talking about the indication of the PCI for the side branch, especially side branch, we have a lot of the methodology, for example, physiology and the intravascular imaging. But at that moment, we didn't perform the physiological assessment to evaluate the ischemia in the side branch, but according to the significance of the region, we decided to treat the side branch with the two-sense strategy. But after that, we honestly appreciated that we had a geographic miss, even at the index procedure. But what we could do for that situation was just from the addition. We wanted to avoid to put another stent or just to cover the geographic miss. So especially for that case, the choice was very limited.
What about lesion length in both groups? Was similar on side branch? Side branch lesion length?
You mean systematic double stent strategy and the provisional?
Yes.
Yeah, almost the same. I didn't show you.
No significant difference.
No.
So that could be another point. I mean, that could be another point in the difference in outcome, because I think one of the major factors influencing the outcome is the length of side branch of lesion on side branch, and I think that should be considered in your study.
Yeah. Thank you so much.
Thank you. So we move forward. Next speaker is Maid Protti, Temporal Trends in In-Hospital Outcomes Following Unprotected Left Main PCI, Analysis of 4,522 cases from BCIS database.
Thank you. I'd like to thank the organizers for inviting me here today to talk to you. The title of my presentation is The Temporal Trends of In-Hospital Outcomes Following Unprotected Left Main Stem PCI in the UK. This is an analysis of the BCIS database, including about 14,500 left main PCI cases. My name is Mash Protti. I'm one of the PCI fellows in South Wales in Cardiff. So the work that I'll be presenting to you today has been published earlier this year in Circ Intervention, and I would urge you to look at this paper because it'll have a lot more data than what I'll be able to present to you today because of the time limitation. It was a national collaboration spearheaded by Tim Kinned. So to give you a bit of a setup, so the aim of the study was to examine the annual volume of left main stem PCI done in the UK, and to look at the change in the in-hospital outcomes over the study period from 2009 to 2017. And to do that, we used the BCIS database, which is the British Cardiovascular Interventional Society database of all PCI carried out in England and Wales. We excluded emergency presentations from the cases that we identified in this database, and that included STEMI and cardiogenic shock. So none of the cases that were analyzed had any immediate clinical need for revascularization. And we identified and studied, therefore, the final number was 14,522 left main PCI procedures. We looked at the baseline procedural and outcome variables. We looked at them unadjusted, and then we adjusted for them with multivariate modeling. So to look at the crude numbers, first of all, during the study period, the panel on the left-hand side here, from 2009 to 2017, there's been a rise in total number of PCI from 60,000 to 75,000. And that was mirrored by a rise in the number of left main PCI done during the study period to more than doubling from 1,000 to 2,600. Now, on the right-hand side panel, when you look at the proportion of PCI that was done for left main, that also rose from 1.8% of total PCI to 3.4% of total PCI during the study period. But it wasn't just the numbers that increased. It was also the complexity of the patient and the procedure. So during the study period, there was older patients, 70 versus 71. There was more diabetic patients, 22 versus 28%, more valvular heart disease, more patients who've had a previous PCI, and more number of vessels diseased as well as attempted in the cases. And in terms of the procedure, there was more uptake of intracoronary imaging during the study period, so it rose from 40 to 58%, and I think yesterday we saw more contemporary data showing the rise of intracoronary imaging in left main in the UK to more than 70%. More use of rotational atherectomy and cutting balloons as well as microcatheter use. So there's an increase in the complexity both on the patient level as well as the procedure level. Now, if we look at the crude outcomes, first of all, the panel on the right-hand side, if you look at the risk of any procedural complication, then that's been declining during the study period, down from 9% to 5%. When you look at some examples of complications, you've got less coronary dissection, less slow flow, but there's no difference in shock induction or side branch loss during the study period. Now, these are crude data, so let's come to the adjusted data. Now, we were interested in the trends year on year, so we adjusted for all covariates and compared them to the reference year of 2009. And again, when you look at the risk of in-hospital MACE on the right-hand side corner, then there's a year-on-year decrease in in-hospital MACE. That was not driven by in-hospital death, but it was driven by in-hospital per-procedural MI. When you look at the risk of any procedural complication, that again had been coming down after adjustment, but there's no risk in in-hospital major bleeding, no difference over the years. And the last thing that we did was to look at which covariates could independently predict poor outcomes, in-hospital outcomes, following left main PCI. So anything to the right-hand side of this line of no difference is associated with adverse outcomes. Anything to the left-hand side is associated with better in-hospital MACE rates. And you will see, for example, age is associated with worse outcomes. So for every year older, there's an additional 2% risk of in-hospital MACE. Female sex was also associated with worse outcomes. And baseline comorbidities, specifically peripheral vascular disease, chronic kidney disease, and ejection fraction less than 30% were also associated with worse outcomes. There are some procedural elements as well that were associated with worse outcome, for example, using a dedicated bifurcation two-stent strategy, 2B3A inhibitors, or mechanical circulatory support. In terms of the variables that were associated with better outcome, and we've shown this before in this data set, an older version of this data set, intracoronary imaging. The slides were shown by previous presenters. That led to better in-hospital MACE. And the year of PCI, we saw that in the latter years, as I showed you earlier, year on year, there's been an improvement in the outcomes. So more contemporary data showing better outcomes in left main PCI in the UK. So we discussed why that is in the paper, but basically to conclude, we have seen increasing number and complexity of unprotected left main PCI in the UK over time. And there's a significant trend for lower in-hospital MACE and complication over the study period from 2009 to 2017, which is the data that we managed to get our hands on. In our discussion, we try to see why that is, because remember, this is retrospective data, so we don't have the fine granular details as to why that is, but we believe it probably reflects improved technologies, techniques, as well as greater operator experience. But ultimately, this data is important to inform procedural planning, to guide the patient in terms of their choice and consenting to the procedure, as well as involving the heart team discussions and empowering them. Thank you very much, and I'll be happy to take any questions.
Questions?
Excellent demonstration, thank you. There's one thing that I wasn't very attentive at your presentation. Why did you exclude the acute coronary syndromes in your?
We didn't exclude acute coronary syndrome. We just excluded STEMIs.
Okay.
So the idea is that if a patient comes in at 3 a.m. with a STEMI involving the left main.
I mean, these are the procedures that PCI is doing its best. So maybe it's a fair comparison to include those one also.
Well, most clinical trials will exclude a STEMI as well from left main particularly, and we know that they have poor outcomes in general as a population. So we didn't want the data to be skewed in that direction. Same for cardiogenic shock. And also, I've worked in centers where there are operators who don't do left main PCI, but they will admit that if a patient comes in the middle of the night with cardiogenic shock and it's 3 a.m. and they are the only operator on site, they will crack on and do it despite their lack of experience in left main PCI.
So congratulations. I think it's a great result because as we see the complexity of the patients is increasing. They are older and more risk factors and so on. I would like to ask you which parameters did you choose to adjust your multivariable analysis? Did you include all these differences in clinical parameters?
Yes, we included all the parameters that were available to us in the database, and we've done this in other papers from the same database. That seems to be a reflective adjustment and hasn't over-adjusted in our experience. So all of the variables that you've seen on one of the graphs were adjusted for.
So it's great results to improve the MACE with this worse profile of the patients. Yeah.
Absolutely.
I also, congratulations for the excellent analysis of such a large database. I'd like maybe to comment on some findings that probably are just a marker or more severe disease, like the intra-aortic balloon pump or the use of circulatory support, Impella, or the two-stent techniques, and so on. I guess during the study period, this circulatory support, the so-called protected PCI, which is currently a common trend nowadays in unprotected left main, was probably at that time anecdotal.
Yes.
And I guess that, I don't know, probably you don't have this information, but probably has been rising.
It has been rising. It is in the paper that we had there, but you're absolutely right. So one of the variables that predicted worse MACE is the use of 3 or more stents. Now, we don't think that's because you're putting 2 short stents together. It probably reflects the lesion length, the complexity of the disease, which is not something that we can measure. So, for example, in this database, we don't have the Medina classification of the disease. We don't have the amount of calcium in this. But we could use other surrogate markers, as you said, for example, 3 stents or more, dedicated 2-stent strategy up front, mechanical circulatory support as a reflection of the complexity. And sure enough, we've published that before in a different data set, all-comer PCI, showing that these predict complex high-risk indicated patients, the CHIP cohort, including mechanical circulatory support.
Have you tried to see if there are any difference between in outcome among different syntax scores?
We don't have the syntax score data on this database, unfortunately, which is always something that the reviewers come back with. The reviewers always come back with, what's the Medina's classification of all these 14,000 cases, and what's the syntax score? And this data is not recorded routinely in the BSIS data set. But that would be another interesting finding.
Sure.
And
You showed that down here.
Oh, yes, I see.
You showed that the risk decreases by year. Now, what do you think the year is a proxy of? Is that increased operator experience, and how much is it exactly?
How much is the operator experience? Or
No. The improvement by year.
Yeah, so I showed that earlier. So everything was compared to the reference year of 2009. And since then, there's been a year-on-year improvement.
How much is it per year?
I'll show you the slide if you can give me the slides back.
And my question is, do you think, year doesn't really tell us anything.
No.
But it must be a proxy for something. And
Absolutely.
could it be proxy for increased experience?
So increased experience is definitely something that we suggest in the discussion. So we saw that there was 1,000 left main PCI in 2009, and that rose to 2,600. So I don't think there's been many new consultant appointments during that time. So it must be the same people who were doing it in 2009 that had gathered greater experience. And we've previously shown a volume relationship version with that. You commented about operator volume, I think, earlier, and we've seen that for left main PCI. So that's one of the things that we think could have influenced this. The other thing is newer technologies or better understanding of bifurcation techniques, angled microcatheters to access side branches that might be more difficult to access. I think all of these things are probably contributing to it, but if I have to pin it down on one or the other, it's difficult without all the granularity of the data.
Any data about the concomitant other coronary artery disease and eventually also the revascularization, the adequacy of complete revascularization? So
we do have data on the lesions and the disease pre, and that was adjusted for as well. The adequacy of the revascularization is not something that's recorded, like extent expansion, for example, or the MLA or the MSA. It's not something that's recorded, unfortunately. But this is real-life practice, and it just shows what we've been doing over the years.
Okay, thank you very much. We're going for next presentation. Clinical outcome of PCI on left main trifurcation stenosis. Mila Kovacevic, please.
Thank you. But this is broken, I think.
this one. Dear Chairman, dear ladies and gentlemen, it is my pleasure to be here and to present some overview about left main trifurcation lesions and clinical outcomes. Let me see just, okay. We all know that left main trifurcation has some specificities. For example, like there are 2 side branches, at least 4 angles. We cannot say this bifurcation, it's trifurcation angles. And also the Finnett's law is different. Regarding the left main trifurcation classification, we all know that there are several classifications. First one, and very well known, Medina classification. There are also Shamas classification and ABCD. Of course, we are well known, we are much familiar with Medina classification. What is known so far about left main trifurcation lesions and outcomes in these patients? All the data comes from the small observational trials, and you can see, just maybe, okay. All the data come from small observational trials, with the largest one being MITO registry or Milan New Tokyo registry with the 84 patients. And regarding the MACE, you can see and you can appreciate that there is like variability between 9% in Tamburino and 34% at Shamas study. However, there was different definition of MACE in Tamburino, for example, registry. They didn't include target lesion revascularization compared to other studies. What can we say about the impact and outcomes on left main trifurcation lesions? First, we have to speak about impact of anatomic complexity, then impact of stenting strategy, and what do we know about left main trifurcation versus left main bifurcation lesions. Regarding the impact of anatomic complexity, as you can see, the true left main trifurcation lesion was present in about 40 to 70% of patients. In some studies, they are not reported. They didn't report the number of true left main trifurcation lesions. When we go back again to MITO, the largest one registered so far, you can see that the patient who had true left main trifurcation lesion, they had worse outcome, particularly MACE, and of course target lesion revascularization rate. Regarding the stenting strategy, of course, one stent technique was applied in about 15 to 60% of patients, and you can see that the 60% of patients received 2 stent technique in Kubo registry. In Gil, I'm not sure I will pronounce correctly, they also applied a dedicated to bifurcation stent. What can we say about impact of stenting strategy? It didn't influence the MACE, as you can see in MITO registry on the left. However, it did influence the target lesion revascularization rate, particularly number of in-stent restenosis, and the majority of in-stent restenosis was at the ostium of the left circumflex. Regarding the Kubo registry, they included 72 patients, and they performed systematically tracing. Either it is 1 stent technique or 2 or 3 stent technique. And what they concluded that multi-stent technique was influenced the high rate of target lesion revascularization rate compared to patients where they apply single stent technique. And again, they performed systematically tracing in all or triple balloon kissing in all patients. Regarding left main trifurcation versus left main bifurcation lesion, we just have extrapolated data from Excel trial. They included 61 patients with left main trifurcation lesions, and as you can see, there was no difference between trifurcation and bifurcation lesions, with even less numerically MACE in patients with trifurcation lesions. Do we have new data? We decided to do another multicentric retrospective analysis, We included 103 patients with left main trifurcation lesions, all comers, STEMI, non-STEMI cardiogenic shock, in 4 tertiary high-volume centers, 2 centers from Italy, Gemelli Hospital in Rome and San Raffaele Hospital in Milan, and the 2 centers in Serbia, Clinical Center of Serbia and my hospital. The primary endpoint was MACE, a composite of all-cause mortality, MI, and target lesion revascularization. The secondary endpoint was target lesion revascularization. So when we compare to other trials, our trial, the follow-up was 3 years. We included true left main trifurcation was present in 24% of patients. We mainly performed provisional single stent technique in 76% of patients. Tracing was applied in 15% of patients. And geographic success was achieved in 97% of patients. And regarding the MACE, MACE was present in 17.9% of patients, particularly due to the target lesion revascularization rate, which was 11.9%. Regarding cardiac death, it was present in 3.9 patients and overall cause mortality in 5.9% of patients. What we particularly wanted to do to examine how angiographic left main trifurcation complexity influenced the MACE. So first of all, we created another score. It was a great idea of Francesco to do sum of Medina points. For example, in this particular case, this is sum of 3 Medina points. Then to add 1 point for side branch lesion length more than 5 millimeters, we decided to use a cutoff of 5 millimeters instead of 10 millimeters in definition trial, thinking that maybe 5 millimeters in 2 side branches would be comparable to 10 millimeters in bifurcation lesions. So 1 point for side branch length more than 5 millimeters, as in this example only circumflex has side branch length of more than 5 millimeters. So in this way, we created modified Medina trifurcation score with a maximum or total of 6 points. Then we did perform univariate analysis for all anatomic, clinical, procedural factors. And as you can see, these variables are independent predictors of 3-year MACE. However, when we performed I don't know why that's multivariate analysis, only modified Medina trifurcation score, this was the only independent predictor of 3-year MACE. Regarding the secondary endpoint, TLR, 3-year TLR, number of deaths in left main trifurcation was the only independent predictor of 3-year target lesion revascularization. So what we can conclude, that PCI in patients with left main trifurcation lesion is technically demanding, might require dedicated techniques, might require 2 stents, 3 stents, 2-step kissing or tracing technique, but may result in high rates of angiographic and procedural success. And also it is associated with acceptable MACE rate of 17.9% in our trial, that can be independently predicted by our modified Medina trifurcation score. Thank you. This is broken. I didn't break. I don't know how, but it.
I have a question. In how many percentage did you use imaging, and was it reserved only for the true bifurcation with your modified Medina score? And also about tracing, did you did it systematically, or and in provisional stenting, did you do it all the time or not?
No. Regarding the imaging technique, it was applied in 35% of patients, with majority of them performed the OCT, 20% OCT, and 15% of them we performed the IVUS. And regarding the tracing, tracing was, as I already showed, that it was applied in 16% of patients. But 2-step kissing, it was applied in majority of patients, 60% of patients. And POT, for example, it was done in 90% of patients.
Congratulations, extremely stimulating and also extremely clever, the modified score. But we find now in the trifurcation between Scilla and Caridi, meaning on one side you showed us in a convincible way that multiple stents are related to adverse outcomes. On the other way, we know that in trifurcation we have a mismatch between the usual strategies that's left main to the LAD stenting, because it's usual, not always, but it's usual with a very large difference in diameter. So give us your recipe.
Yes, of course. There is, on the first slide, I already showed like the Finnett's law regarding the left main trifurcation lesion. Yes, there can be a very mismatch between the size of the left main and, for example, other side branches, LAD or ramus or circumflex. However, if we are speaking about true left main trifurcation lesion, then we have to appreciate that the side branch diameter should be more than 2.5 millimeters. And regarding all the stenting platforms now new available, that we can stretch them from 3.5 to 6. So nowadays it's not difficult to treat left main trifurcation lesion with the available second generation or third generation of DES. Especially in our trial, compared to other observational analysis, we treat all the patients with second generation DES and drug-eluting stent, compared to previous when there was also the first generation of drug-eluting stents and so
but yours has been always supporting provisional stenting.
Yes, in a situation when there is possibility to treat it with provisional single stent, maybe this is the better choice. However, we already saw the definition 2 study and the criteria for the complex lesion, not the true left main trifurcation or true left main bifurcation, but the complex bifurcation. And as the colleague already showed, when we have for bifurcation lesion more than 10%, 10 millimeters in length and more than 90% of the side branch, then maybe it could be the patient that should be treated like with the 2-stent technique in advance. However, in our cohort of patients, minority of them was treated, not minority, but one quarter of patients was treated with the 2 or 3 stent techniques.
I just provisional technique, which was mostly used, which 2 stents or 3 stents technique, bifurcation or trifurcation technique, was predominantly in your study?
It was TAP, the protrusion technique, yes, in majority of patients.
Mira, congratulations for a very nice study. How many patients actually received 3 stents at the trifurcation, and how did they do on follow-up?
In our trial, I think it was like 5% or 3%. A very small number of patients that deserve the 3-stent technique. Very small number of patients in this particular trial. Probably because it's observational trial registry, that all the patients who had probably higher syntax score, like maybe scheduled for surgery. So maybe this was the reason that we utilize mainly 1-stent technique than 2-stent techniques. Although, for example, in our analysis, 1/3 of patients had a syntax score less than 22. 1/3 than 22, 32, and also third of patients had syntax score higher than 32.
Yeah, I have seen the score was based on the lesion length on side branch.
Yes.
What about calcification, which is very important in these cases, and this very, very often is very calcified lesion?
Yes. Thank you for your comment. We didn't estimate the presence of calcification, just the lesion length in ramus and left circumflex.
And why 5 millimeters, not 10 millimeters?
Yes, that's something that I explained. We thought that maybe 5 millimeters in 2 side branches could be comparable with 10 millimeters in 1 side branch when we speak about left main bifurcation lesions. But
okay,
good point for sure.
Okay, I think we can move forward. Thank you, Mila.
Thank you.
So, next talk by Sandeep Arunateraya. It will be on the EBC main trial 3-year results, randomized comparison of stepwise provision. We know what is EBC main. No.
Great, good. Thank you. Thank you very much for the invitation. And I'd like to present the 3-year trial updates from EBC main. And obviously this was a trial, a randomized comparison of stepwise provisional versus a systematic dual stenting strategy in the left main bifurcation. Presenting this information on behalf of the EBC main investigators, of whom there are many in the room at the moment. Just like to acknowledge Medtronic Europe for funding the study. Now, we know that PCI for left main disease, and this has been from multiple randomized controlled trials, for disease that is low to intermediate syntax score that involves the left main, has comparable 5-year survival to coronary artery bypass grafting. PCI obviously has the benefits of less procedural risk and less time to discharge. However, longer-term results are still superior for coronary artery surgery. So it's really important for us to optimize our PCI procedure to try to chase a surgical-like long-term result. There's been a lot of debate regarding what the best bifurcation technique to use in the left main should be. And to date, randomized studies that have involved a large number of people with long-term follow-up have all investigated DK crush, and that's specifically been in an Asian population with high complexity disease. Now, in that setting, DK crush has performed very well and has shown superiority to both the provisional strategy and the Collot strategy for important endpoints of myocardial infarction as well as TLR. EBC main was designed to compare the difference or similarities between a provisional strategy to an upfront dual stent strategy in a European population with true left main disease with low to intermediate syntax scores. Kissing balloon inflation was routine for both the strategies in this population, and a modern drug-eluting stent platform was used. In all, 467 patients were enrolled from 11 European countries, and the trial was run by CIRC. Now, patients recruited for this study averaged about 70 years of age. They had a high incidence of previous PCI, and over a third presented with an ACS lesion. The mean syntax score was right on the borderline between low and intermediate. A fair amount had bystander PCI, almost half, and intravascular imaging was used to guide about 40% of the cases. You can see that overall the side branch lesion length averaged 7 millimeters, but importantly there was a difference between the two groups despite randomization, and the dual stent group ended up having longer disease lengths, with 25% having a side branch lesion length of 10 millimeters or greater, compared to only 9% in the provisional. You can also see the side branch diameters on average was 2.9 millimeters. Now this was by QCA, which tends to underestimate the luminal area. And actually, if we look at this side branch stent platform inserted, the median was 3.5 millimeters. In terms of the two-stent strategy used, the most common was Collot, and this was followed by T and TAP techniques. The rate of crush stenting was quite low in this study. You can see the rates of POT and kissing balloon inflation there, and they were high for both strategies. Now, the 12-month outcomes were reported back in 2021, and at this stage, MACE was not significantly different between provisional or dual stent cohorts. What was noteworthy was that only 1 in 5 patients in the provisional cohort ended up with a side vessel stent, and these patients obviously overall contributed to a group that had shorter procedures with less radiation and less cost, much like we saw in EBC2. We now have 3-year follow-up results, which has been completed in 463 of the 467 patients. The primary endpoint definition remains the same, which is a combination of all-cause mortality, all myocardial infarction, and target lesion revasc. We also looked at bifurcation-specific events, and we made a composite endpoint of procedural or sudden cardiac death, target bifurcation-related MI, or target bifurcation revascularization. Now, these were the outcomes of MACE at 3 years. This was presented by David Hildig-Smith at EuroPCR earlier this year. We could see that actually there was still no significant difference in MACE at the end of 3 years, but there was a clear trend in favor of provisional strategy with rates of 23.5% versus 29.5%. Now, when we looked at the individual components of the primary endpoint, we could see that mortality and myocardial infarction remained largely similar between these two groups. However, if you come down to target lesion revascularization, the the provisional strategy had almost half the rate of the systematic dual stent approach at 8.3% versus 15.6%. And also, if we look at specifically bifurcation-related MACE, this was 15.2% versus 22.4%. So both of these were quite much in favor of a provisional strategy. Now, this forest plot depicts subgroup interactions for the main MACE outcome. And interestingly, significant interactions were seen for side vessel caliber as well as side vessel lesion length. And we'll go into this in a bit more detail in the next few slides, but all of this is now subgroup analysis and should really be considered hypothesis generating only. So this slide shows curves which explore the effect of side vessel caliber on the primary outcome, stratified by the strategy the patients were assigned to. You can see the Kaplan-Meier curve on the left, which looks at provisional strategy, and really the MACE outcomes did not seem to vary based on side vessel diameter. However, if you look at the dual stent group, patients that had smaller side vessels really did significantly worse in terms of MACE outcomes. And when we looked at the stent platforms used, patients that had 3.5 stents or smaller did worse in MACE compared to patients with 4 platforms or larger. Now, this is in line with previous data that shows that stent failure is at a lower risk if you use larger stent platforms and achieve greater stent expansion. And I think this may be particularly important in the left main, as when you come across your side vessel ostium, which is often your circ ostium, there are mechanical reasons where you may not get full stent expansion at this site. If we swap onto the effect of side vessel disease length, instead of affecting the dual stent strategy, this seemed to really affect results with the provisional strategy. And you can see here that side vessel disease length extending 10 millimeters or beyond is associated with increased MACE with time, whereas it didn't seem to affect the dual stent strategy that much. Now, this is important because it may indicate that kissing balloon inflation by itself in the setting of extensive side vessel disease may not be sufficient. Even if you have a good angiographic result, you may need to do a stent for this, or potentially this might be an area where drug-coated balloons show some promise. So putting these results together, it is apparent that the provisional strategy for EBC main tended to show better outcomes when side vessels were smaller and when side vessel lesion lengths were more limited. The majority of patients recruited into EBC main fit these anatomical characteristics, and this really influenced the overall outcome of this trial. Now, the question everyone will ask is, well, how do the results of EBC main fit in with what we already know about left main bifurcations? And most of the data in this field comes from DK Crush 5. And it would seem that both of these trials are very oppositional. The EBC main favors provisional, DK Crush favors a dual stent. How do we reconcile this? So I think some of the information we have from our sub-analysis of the EBC main data helps with this, because we know now that anatomical factors have a strong influence in the outcome of bifurcation techniques. And when we look at the populations in EBC main and DK Crush 5, they really couldn't be more different in this regard. Looking at the syntax scores, so 44% of DK Crush 5 patients had a syntax score of greater than 32. If you look at definition complexity, this was in 32% of DK Crush 5 patients and in 1.5% of EBC main. Provisional side vessel stenting was required in almost half of the provisional patients in DK Crush 5, and the side vessel lesion length is over twice of what was found in EBC main. And with the limited data we have in EBC main looking at patients with these type of factors, there was a trend that dual stents may be better. So I would suggest that essentially the trials that we have, DK Crush and EBC main, are actually complementary. And what they do is they compare two different bifurcation techniques applied at two different ends of the spectrum of disease complexity. So in summary, the conclusion after 3 years of follow-up was that the majority of true left main disease that we encounter in a European practice is best treated through a provisional strategy with routine kissing balloon inflation rather than an upfront two-stent approach. Now, this led to a reduction in hard clinical endpoints, so it's less target lesion revascularization, less bifurcation-specific MACE. I think this supports what we've been saying, that if you don't need to put a stent in, you shouldn't, because you pay a price with that. We did get a signal that dual stent strategies may be favorable in the setting of extensive large caliber side vessel disease, but this is very much the minority of patients in EBC main, but perhaps this would explain why the results of DK Crush are the way that they are. That's all.
Thank you very much. So the study is open for discussion.
Congratulations for the excellent, it's an amazing amount of information. The results you have just presented are intention to treat, right?
All in the intention to treat analysis, yes.
Okay.
Yeah.
Then, modestly, I think that there was a problem with the randomization. It's statistically, I mean, the probability that you get that bias in the side branch characteristics in a group of 500 patients is negligible. And especially favoring the two-stent techniques in those lesions at the side branch that most likely profit the most from the techniques. I guess there was a problem in the randomization.
Yeah, I mean, there could have been selection bias into the trial, but once the patients were randomized, I mean, a 2 millimeter approach probably statistically is maybe, not clinically significant. There shouldn't really have been a reason why the randomization failed.
The truth is the fact that even if something is let's say, improbable, it happened. Because, I mean, a randomization was performed as usual. I mean, there was a communication and computer-generated system that was unaware about the complexity.
I mean, in EBC2, there was almost twice the rate of bystander PCI in the two-stent group compared to the
for sure, I mean,
like,
it's important. I mean,
yeah, but it's just a coincidence.
Yes, but what was he was telling that there was a significant difference despite the randomization in the baseline, some in favor, some against, across in favor.
Well, I would not disregard.
It depends from the variable that are listed when you have to randomize, but it happens. Meaning
Yes,
this happens, but it's a rare coincidence. That
this is a core lab QCA analysis, and there was no QCA analysis to be submitted at the time of randomization. Okay.
It's operator reported.
But this is QCA core lab, and randomization was done without any QCA analysis.
As usual.
Yeah, but do you understand my point? Is
yes,
nobody?
Yes.
Yeah. I mean, it's just a very rare coincidence that the group with longest lesions at the side branch gets more to stent techniques. I guess you have already thought about that, and probably you had to answer some reviewers' remarks about that. I guess.
But was that the case that there were longer lesions in the two-stent group in the overall study?
Yeah, I don't know if we can get the slide back
sorry,
up. So the dual
perhaps
stent,
I missed that. Perhaps
the mean side branch lesion length in the dual stent group was 7.9 millimeters, and the mean in the provisional was 5.8. So
and was that statistically significant?
That's statistically different. Okay. Yes. Yeah.
Can I just clarify? When you have two groups and there's randomization, if you have enough variables, then some of them will be different between the two groups. And by the play of chance, in this situation, in this particular clinical trial, that difference was met in the lesion length.
I'm sure you're too young, but Geminis did not benefit from thrombolysis and.
I do remember that, but this is all, like I said, it's hypothesis generating, but actually fits logically with
beyond. I mean, this that is for sure. I mean, a good comment. I mean, that should be explained just with the statistical limits of the sample size. I mean, if you have a 3,000 patient study, it is less probable that you will have this kind of problem. Anyway, I think that what you also not only performed good analysis but also commented well, because when we had the first result of this trial, we thought that we were completely against the decay crash results. And now, I mean, it seems that over time we are understanding better the fact that probably we treated different patients, and probably this is more important for the selection of the technique than the technique by itself, because now, I mean, we have the signal that is in favor of double stenting when you have extensive disease in the side branch, even if in our trial decay crash was marginally applied. This is also an important point, because it seems that when you have extensive disease, the double stenting technique can be more effective than provisional, even if decay crash is not the double stenting technique because it was marginally applied in the trial.
Well, actually, I think this new analysis, taking in consideration the length of lesion also in EBC main trial, answered why that difference between decay crash and EBC. So I think one of the main factors impacting the results is the length of lesion on side branch.
Yes, yeah, very much agree with that. And I think
So
it's
if
also...
you will redesign this study, what you will change in the
Well, I think the
in
study
the
needs to
inclusion
reflect
criteria?
the study needs to reflect what your clinical practice is, and the truth is that the clinical practice in Europe is that patients with very extensive lengths of disease get surgery, or they might be a case that you do once or twice a year. You can't do a randomized controlled trial. What you need to study is the population that you frequently do PCI on for left main disease, and that is the population that was included here.
Okay.
Well, the alternative is that we do the sickest patients also with bad disease who the surgeons don't want to do. And maybe that's the patient group to study as a big group. But when you say that particular aspect of the longer lesion length patients seeming to benefit from the two-stent technique, that just supports already randomized trial data in a different population, right? So it's hypothesis generating, but it's already supported by randomized trial data from another trial.
If I can comment, I will give you the word. I also can speculate the fact that in the EBC main trial, since decay crash was marginally applied, also double stenting group received the provisional flow to receive two stents intentionally. This also, challenges the fact that the only effective way to implant two stents should be decay crash.
Question about the crush. I didn't understand completely in the EBC main trial when I think there were 10% or whatever that were called crush. Were those decay crush or they were not decay crush? Okay.
I just wanted to add that length in decay crash 5 was 17 and here was 6 and 8. In definition 2 was 20. So we speak about 8 in two stents versus 17. Really difference which is striking. So completely
striking. Yes, what is good and new, I think, today is the fact that this striking difference also, in the subgroup that was similar to the other of our trial, provided similar results. David?
Yeah. To Vlad's point there, only 5% of patients did have a crush, but in the protocol it did say that if a crush was to be done, then decay crush was strongly to be favored.
Provisional stenting is also a double stenting technique.
So yes,
I have treated multiple bifurcation in my life, and even with very long lesion in the side branch, I always put the stent first in the main vessel.
Okay, but I also know that in the trial there was
a problem with decay crush that in the decay crush the provisional group was considered as a bailout, and they left untreated long segments. Only 44% of the side branch were stented, and that explains the amount of acute MI that we can see in the first week in decay crush 5.
But that's a pretty large crossover, 44 or 47%.
But
that's almost half people crossing over.
The same patient where the two groups.
I think 48.
So if you have a lesion which is 16 millimeter in length,
and
up to 30
that's
millimeter. I know since the 80s that we cannot be treated that with a balloon. We know that since the 80s.
Yves, and now we have data showing that, it makes sense sometimes to plan the implantation of two stents. What is also important to understand is the fact that I remember that there were some double stenting technique performed by inverted provisional. This means that in the case of extensive disease into the circumflex, some EBC main operators decided to perform dual stenting using inverted as suggested by the protocol. I think we should go forward. Thank you very much. And I think next presentation is from remote. We have Kefel Du, left main bifurcation stenting, impact of residual ischemia on cardiovascular mortality. Welcome.
Yeah, hello everybody, but it's not
Hello
my
everyone,
presentation.
I'm Dr. Dou from Fuai Hospital, Beijing, China. I'm very glad to share our latest research entitled Left Main Bifurcation Stenting, Impact of Residual Ischemia on Cardiovascular Mortality. As we know, left main coronary artery disease has long been recognized as a crucial anatomical subset of coronary atherosclerosis. Left main CD frequently involves distal bifurcation, and PCI for left main bifurcation is associated with more complex procedures and inferior outcomes compared with isolated osteo or shaft lesions. Using wire-based physiological assessment, previous study found that nearly 16.9% of patients had residual ischemia in circumflex after left main crossover stenting and associated with poor prognosis. The present study aimed to determine the rate and prognostic implications of post-PCI physiological residual ischemia according to mu-QFR after left main bifurcation PCI. mu-QFR is a new generation angiography-based computational physiology index, and it has been proven to be more appropriate for analysis of bifurcation lesions with good diagnostic accuracy. The present study is a post-hoc blinded analysis from a prospective cohort which consecutively enrolled patients with unprotected left main CD-PCI at Fuai Hospital. The primary outcome was 3-year cardiovascular death. Major secondary outcome was 3-year bifurcation-oriented composite endpoint, BOCE, defined by the bifurcation arc consensus document. mu-QFR assessments were performed separately in main vessel and side branch based on different single angiographic views. Residual ischemia was defined by post-PCI mu-QFR values less than 0.8 in LAD or LCX. As shown in study flow, 1,320 patients with unprotected left main bifurcation stenting were prospectively enrolled. After excluding 150 patients with AMI or unanalyzable mu-QFR, 1,000 or 170 patients were finally included in the present study. Post-residual ischemia was detected in 155 patients, including 117 with LCX ischemia alone, 32 with LAD ischemia alone, and 6 with both LAD and LCX ischemia. Compared with no residual ischemia group, patients with ischemia group had more comorbidities, lower left ventricular ejection fraction, and more extensive CAD. Regarding procedural characteristics, the residual ischemia group was associated with lower number of two-stent technique and the final kissing balloon inflation and higher residual syntax score. After multivariable logistic regression analysis, we found 8 independent predictors of post-PCI residual ischemia, including LVEF, true left main bifurcation, pre-PCI LCX RVD, anatomic syntax score, pre-PCI LCX mu-QFR, treatment strategy, post-PCI LCX diameter stenosis, and residual syntax score. When we look at 3-year clinical outcomes, the rate of cardiovascular death was significantly higher in residual ischemia group, 5.4% versus 1.3%. After adjusting possible confounders, the adjusted hazard ratio was 3.2, and incidence of BOCE were also significantly different between patients with and without residual ischemia, 17.8% and 5.8%. Moreover, residual ischemia, regardless of LAD or LCX, was associated with worse outcomes, especially among patients achieved acceptable physiological results in main branch. Residual ischemia in LCX alone was also associated significantly higher rate of 3-year cardiovascular death, 6.2% versus 1.3%, and BOCE 17.2% versus 5.8%. In addition, clinical outcomes were inversely and continuously associated with post-PCI mu-QFR values, and per 0.1 decrease in post-PCI mu-QFR value, the risk of 3-year cardiovascular death and BOCE increased 27% and 29% respectively. When using post-PCI mu-QFR or diameter stenosis percent to define physiological or anatomical significance respectively, mismatched results were found in 177 patients. Among these patients, physiological assessment showed superior prognostic value for 3-year clinical outcomes. In the present study, we found that after angiographically successful left main bifurcation PCI, residual ischemia assessed by mu-QFR was identified in 13.2% of patients and was associated with higher risk of 3-year cardiovascular death. Toward a more perfect interventional algorithm, adopting the strategy of routine post-PCI physiology-based assessment when treating left main bifurcation lesions is necessary, even when PCI appears anatomically satisfactory. Thank you for your attention.
Is the author connected? No. Okay. Is there any comment about this study from the panel? I don't think she. Sorry. I don't think you are Dr. Du.
No, she's the next speaker.
Okay, so we will discuss later on. So is there any question on this? No? Any comment?
I guess that there were no data about how many patients could be optimized after finding a suboptimal result. Because sometimes the physiology is not always possible to optimize the result according to the physiology.
I mean, this is the limit. However, I mean, the signal is there. The operator were satisfied with that, and then at the end you find that there is impact for what so the completeness of revascularization in patients undergoing left main PCI seems to be important. There are many ways, actually, if you look at the trial to do this. Physiology was one of that. Symptom score residual is another that was stratifying the outcome. Now we have this new tool that is the functional, that can be intermediate between the functional done with pressure wires and the angiography done just by angiography. So it seems a new tool that can be useful. Okay, next. Last but not least for all EBC is Dr. Annette Mazninka. I hope I said it correctly. Patterns of restenosis after single or dual stent implantation for left main bifurcation PCI, a sub-analysis of the EBC main trial. Sorry.
Thank you. So, good afternoon and dobry wieczór. I'm very grateful to be here and thank you for the invite to give this last talk of this fantastic meeting in this country that I love and originate from. I'm presenting this work on behalf of the EBC main trial investigators, and it's a sub-analysis on patterns of restenosis after left main bifurcation dual or single stenting. The only relevant disclosure is that EBC main was supported by an education grant from Medtronic. Sandeep eloquently presented the EBC main 3-year results, which showed higher target lesion revascularization with upfront dual stent strategy compared to stepwise provisional approach for left main bifurcation PCI. Prior registries showed higher target lesion revascularization with dual compared to single stenting, driven by circumflex ostium restenosis. Improvements in stents and pharmacotherapy have improved PCI outcomes, but restenosis location and its relation to stent technique after contemporary PCI is not well characterized. The aim of this sub-study was to investigate patterns of restenosis after left main bifurcation PCI in the EBC main trial, and to investigate any differences between dual and single stenting. To recap, EBC main was a multi-center randomized trial in 467 patients with stable and unstable coronary disease who had true left main bifurcations with both branches greater than 2.75. Patients were randomized to the stepwise provisional approach or the upfront dual stent strategy with Resolute onyx stents. Clinical events at 3 years were adjudicated by an independent clinical events committee. And this sub-study included all patients who underwent target lesion revascularization and had information available on restenosis location. The decisions to do invasive angiography during the follow-up period were made by local clinicians based on ischemic symptoms or non-invasive tests of ischemia. QCA was performed by a core lab, and significant restenosis was defined as lesion diameter stenosis of 50% or more. Restenosis was recorded in the left main, ostial and proximal LAD, and ostial and proximal circumflex. 8 patients who had target lesion revascularization had missing information on restenosis location, so we included 48 patients in this sub-analysis. 13 had single stenting, 35 had dual stenting. In patients that were treated with dual stenting, 89% had been randomized to the upfront dual stenting approach. The mean age was 70 years, and 73% were male. The proportion of diabetics and current smokers was similar between the two groups. Most patients had Medina 111 bifurcation disease, and half had at least moderate lesion calcification. The LAD was the main vessel in 2/3 of cases. In patients treated with single stenting, 2/3 had left main to LAD stenting, 1/3 had left main to circumflex stenting. Among patients treated with dual stenting, the technique used was Collot in 57%, Crush in 37%, T or TAP in 6%. LAD stent diameter was similar between the two groups, as was circumflex stent diameter. Nearly all patients had kissing balloon inflations, and half of these were exclusively with non-compliant balloons. POT was performed in nearly all patients. So here we see the pattern of restenosis in all patients who had target lesion revascularization included in this study. 58% had isolated ostial circumflex restenosis, 13% had isolated distal left main restenosis, and 6% had isolated ostial LAD restenosis. We can see that the isolated ostial circumflex restenosis was what most common, regardless of single or dual stenting.
Can you add that?
The mean percentage diameter stenosis at the circumflex ostium was 62%. And this wasn't associated with dual or single stenting, lesion calcification, bifurcation angle, or kissing balloon inflation exclusively with non-compliant balloons. If we look at the patients who were treated with dual stenting, there was no significant difference in the pattern of restenosis between those who had the upfront dual stenting approach compared to those with the stepwise provisional approach. Interestingly, patients who had single stenting from left main to circumflex had worse mean percentage diameter stenosis for lesions at the LAD ostium compared to patients who had left main to LAD stenting. But in contrast, the mean percentage diameter stenosis at the circumflex ostium for lesions there was high, irrespective of left main to LAD or left main to circumflex single stenting. So the take-home message is that stent coverage of the circumflex ostium does not protect from restenosis. So what's unique about the circumflex ostium? It often has steep angulation, which is associated with a hinge-like motion during the cardiac cycle, potentially predisposing to stent fracture. Changes to the circumflex ostium with stenting include vessel straightening and change in local shear stress, and that can potentially lead to vessel wall damage and potentially increase the risk of neointimal hyperplasia at that point. It's also a common site for stent underexpansion because proximity to the aortic wall predisposes to rigidity and recoil due to higher fibroelastic fibers. So compared with stenting, a drug-coated balloon to the circumflex ostium might have advantage. And this is because it combines mechanical expansion of the vessel whilst limiting inflammatory stimulation, but without implanting a permanent scaffold. So it preserves the geometry that was originally there for the coronary anatomy. A relevant ongoing randomized trial is DCB-BIF, and that's randomizing patients with true bifurcations to stepwise provisional strategy with drug-coated balloon to the side branch or non-compliant balloon to the side branch. So in summary, the strengths of this sub-analysis are core lab analysis, independent adjudication of clinical events, and high follow-up rates. The limitations are that it's a post-hoc analysis for randomized trial. There was missing information on restenosis location in 14% of patients who underwent target lesion revascularization, and routine angiographic follow-up was not performed. In conclusion, 3 years after left main bifurcation PCI, the circumflex ostium is the commonest site for restenosis requiring revascularization, and this remains true irrespective of dual or single stenting. Strategies are needed to improve longer-term PCI success at the circumflex ostium. I'll finish by thanking Prof. Dave Hildick-Smith for his support and mentorship. Thank you very much for listening.
Very good study. Have you any information on intravascular imaging in these patients?
Yes, so as was reported, about 40% had intravascular imaging, so it was about similar in this
Because
subset.
I think it's very important data, because particularly in two stents technique and the ostium of left main could be missed by the stent.
Yeah, so interestingly, I did publish the intracoronary imaging outcomes for EBC main, and because the trial wasn't designed to focus on intravascular imaging, it was done according to operator preference, and it wasn't protocoled to recall all the detailed parameters that we get now from intracoronary imaging studies. So there potentially was bias in perhaps using intracoronary imaging more in patient procedures that weren't progressing that well. So that's why I've chosen not to focus on that particularly in this presentation.
Have you any information about the treatment of these restenosis, especially after provisional stenting?
So I didn't. Well, these were patients who did get revascularization for these target lesion lesions, but I didn't actually look at the strategies that were used. We probably have that information, but I didn't include that here.
In the meantime, I imagine you are going to publish this data. It can be advisable probably to simplify the reporting with all the kind of restenosis to quarter stenosis types using Medina again. It can be, I mean, something that make the paper more readable for people, because you have this, this reporting of the various combinations, so that we will know that the most common type is a Medina 001 of stenosis. It will be.
Yes, okay.
So I have a question. Did you actually see stent fractures on repeat angiography? Did you actually see those? And then I have a comment also.
Yeah, so I can't really comment on that. I didn't really have that information, and I guess it might be easier to see on intracoronary imaging. I'm not sure how many use that.
So one thing I've learned over time, if you do imaging at the ostium circ, there's always eccentric calcium or ring of calcium. And in my practice, what I've done is really use shock wave there as a lesion prep before I do anything else, like add another stent or consider drug-coated balloon. So you may be, in part of this trial, you may want to do better lesion prep using shock wave, the ostium circ, which might give you a better result.
I can tell you that your comment is very smart, because we're talking about which is the true impact of imaging, and we have different protocols. And in the October, there was an intermediate scan that was performed, OCT assessment, after main vessel stenting. That also allowed to see what's going on into the side branch, because from OCT you may see the very... So what you are arising is the fact that during these procedures, probably it can be advisable to check for the expansion, for the bulking or appropriate expansion of the side branch, the circumflex, before implanting the stent if you are needed.
Only a comment that this finding is not new. So I remember the era of the bare metal stent, and when we analyzed the follow-up, the most frequent site of restenosis was always the side branch origin, disregarding left main, LAD, circumflex, or right coronary artery.
But since we worked so hardly to improve, it is really important to see that some problems are still there. So we should really.
It's a mystery.
Go on.
But this is a fact.
Just a point. Normally in trials, you stop the follow-up at the first event. Yeah, you are not looking at the treatment of this first event. I mean TLR, and we are not looking at what occurred during the second treatment, after maybe a third treatment. Remember last year we had a case of three stents in the left main coming from Indonesia, and our colleagues showed the first restenosis, the second one, the third one, the fourth one. So I think it will be interesting to collect the event even after the first one.
Agree.
I think will be an interesting point.
It is. I think that also in drugs trial, this is something that was discussed, because most of Kaplan-Meier and statistical report are, like you say, stopped at the first event, but there is a hierarchy in events and number events that can jeopardize the quality of life of the people. So, very smart. Okay, I think that the music is thank you very much, and music is introducing Goran for his final remarks.
One brief sentence, and this is the end of 19 EBC club meeting. So we started in 2005, and in these 19 years we really became a family, having members from all over the world. We are European Bifurcation Club, but at this meeting we had lectures from all 5 continents, and I'm really happy that we promote inclusiveness and diversity. And the only difference is that now we have many more young faces in the audience, and I'm really glad to see more women and more young people to replace us. EBC is working on a transition. Last year we decided to make 2-year term for the executive board. So this is our first year, and we will do one more. And at next EBC meeting at 20th, we will have new executive board. So I'm looking for your support, and I like to invite you to continue sending good ideas. I believe we should remain think tank, but as you may know, we shared the Zoom link with absolutely everybody on Twitter, on mails, so everybody can listen to our discussions, but this is really place for couple of 100 maximum people who can actively produce the consensus, discuss the evidence, exchange experience and practice, and help us build the consensus that we will share. So I would like to thank the industry, of course, for the kind support to make this possible. Big thank you to all of you for being with us 2 days from the morning until now. And at the end, although Alexandra is not here, big thank you to Mediate Events, Alexandra and her team, because this was really beautifully organized, and I'm so happy that Alexandra found such a beautiful place, and we look forward to the next meeting. So pick up for dinner is at 8 o'clock in the lobby, and I look forward to seeing you all. Thank you very much again.